Hi, Hannah. Good morning. Welcome to the Occupational Safety and Health Administration's informal rulemaking hearing for occupational exposure to COVID-19 in healthcare settings. My name is Lauren Phillips-Thorne from Apt Associates, contractor to OSHA. We are now ready to begin. We will start with welcome remarks from the Assistant Secretary of Labor for Occupational Safety and Health, Douglas L. Parker.
Thank you. Good morning, everyone. On behalf of the Department of Labor's Occupational Safety and Health Administration, I want to welcome you to the formal rulemaking hearing for occupational exposure to COVID-19 in healthcare settings. We at OSHA appreciate the time you've dedicated to participate in this event. This public hearing is a very important step in OSHA's efforts to protect healthcare employees from the significant health effects that can result from COVID-19. The development of a clear, accurate, and complete public record is a critical part of the rulemaking process. Your efforts will help shape the development of a final standard to protect healthcare and healthcare support service workers from workplace exposure to the COVID-19 virus that is scientifically sound, feasible, and health protective. On January 21, 2021, President Biden issued an executive order which directed OSHA to take action to reduce the risk that workers may contract COVID-19 in the workplace. OSHA determined that employee exposure to SARS-CoV-2, the virus that causes COVID-19, presented a grave danger to workers in healthcare settings, and on June 21, 2021, issued an emergency temporary standard to protect these workers from occupational exposure to COVID-19. The ETS established requirements, with some exceptions, for settings where any employee provided healthcare services or healthcare support services. The standard aimed to protect workers facing the highest COVID-19 hazards, those working in healthcare settings where suspected or confirmed COVID-19 patients are treated. This included employees in hospitals, nursing homes, and assisted living facilities, emergency responders, home healthcare workers, and employees in ambulatory care facilities where suspected or confirmed COVID-19 patients are treated. The ETS required covered healthcare employers to develop and implement a COVID-19 plan to identify and control COVID-19 hazards in the workplace. It also established specific requirements for patient screening and management, standard and transmission-based precautions, personal protective equipment, or PPE, including face masks or respirators, controls for aerosol-generating procedures, physical distancing, physical barriers, cleaning and disinfection, ventilation, health screening and medical management, vaccination support, training, anti-retaliation, record keeping, and reporting. With the rise of the Delta variant this past fall and the spread of Omicron variant this past winter, OSHA believes that healthcare workers continue to be at risk and measures to prevent the spread of COVID-19 are still needed to protect them. The agency is requesting input from stakeholders in order to develop a final rule that is based on the best available evidence, adequately protects healthcare workers, and is feasible for employers. OSHA has reopened the rulemaking record and scheduled today's hearing to seek new data and studies, as well as feedback on various topics, such as aligning with the Centers for Disease Control and Prevention's recommendations for healthcare infection control procedures, streamlining prescriptive regulatory provisions, modifying scope exemptions, tailoring controls to address interactions with people with suspected or confirmed COVID-19, revising provisions related to vaccination status and support for vaccination, covering construction activities in healthcare settings, triggering requirements based on community transmission levels, and addressing the potential for new strains related to SARS-CoV-2. The agency believes the feedback provided throughout the hearing will aid in the development of an improved COVID-19 standard. Again, I want to thank you for your time and participation. The agency appreciates your participation and your contributions to the public record and will fully consider all comments, testimony, and recommendations as this rulemaking progresses. We all share the same goal of ensuring a safe and healthful workplace for all workers. We look forward to hearing from all of you on this critically important standard. Thank you.
Thank you. Before we begin, we'd like to go over some logistics for today's public hearing. As a reminder, all attendees are muted automatically. If you are speaking today, you will receive a notification on your screen that you are being promoted to the panelist group a few minutes before it is your time to provide testimony. Once promoted to the panelist role, you will be able to unmute and turn on your camera. We ask that you do not unmute or turn on your camera until your name has been called and you have been asked to start your testimony. Speakers connected by telephone should unmute their phones when called to testify. If you submitted a presentation in advance, we will share the file and advance the slides. Please cue us verbally by saying "next slide" when you need us to advance. If you have a presentation to submit for your testimony this afternoon or for a future date, please send it both to public_hearing@aptassoc.com and ets@dol.gov. Presentations submitted at the time of your live testimony will be submitted to the public record, but will not be shared on screen during the testimony. If you are having technical difficulties, please send an email with your name and phone number to public_hearing@aptassoc.com, and I will now pass the floor to our administrative law judge to call the hearing to order.
Thank you, and good morning. We are on the record. The hearing will come to order. This is an informal public hearing on the Occupational Safety and Health Administration's proposed rule for occupational exposure to COVID-19 in healthcare settings. This proposed rule was published as an emergency temporary standard on June 21, 2021, in volume 86, the Federal Register, beginning at 32376. I am Stephen R. Henley, Chief Administrative Law Judge for the United States Department of Labor, and I will be presiding over today's hearing. The purpose of this hearing is to receive from interested parties oral testimony as well as other information pertinent to the proposed rule. After this hearing and the post-hearing comment period have closed, OSHA will review the entire record in determining the content of the final rule. My role as presiding judge is limited to ensuring a complete and accurate record is made and that all interested parties receive a fair hearing and have an opportunity to submit their information. The hearing schedule and OSHA's procedures governing this hearing are available on the website at www.osha.gov/coronavirus/healthcare/rulemaking. These documents were sent to people and organizations who filed a timely notice of intention to appear at this hearing. A few words about the nature of this hearing. Despite its informal nature, it is governed by rules. Both OSHA's rules governing hearings at 29 CFR Part 1911 and the hearing procedures issued specific to this rulemaking. These rules are meant to ensure that everyone has a fair opportunity to speak and express an opinion about the proposed rule. To that end, they also allow me to hold witnesses to their allotted times, limit undue repetition or excessive argument, and generally keep the hearing on schedule. Any written comments you have submitted to the docket have already been introduced as part of the record of this rulemaking. In the rare case where witnesses wish to provide any other documents that have not already been entered into the docket, they should provide them by email to ets@dol.gov before the witness begins their testimony so that they can be entered as exhibits in the record. Because all pre-submitted documents are already part of the record, your oral testimony should concentrate on presenting the highlights of your written comments or clarifying your written submissions. Stakeholders may also submit additional evidence or statements for a period of 21 days from the end of the hearing, which will be May 23, 2022. At that point, the record for this rulemaking will close. Today, after each speaker or panel of speakers completes their oral testimony, OSHA representatives will have an opportunity to ask questions of the speaker or panel. When OSHA has finished asking questions, there will be an opportunity, as time permits, for persons who filed a timely notice of intention to appear to question the witness or panel. This is the process I intend to follow. After OSHA has finished asking questions of a witness or panel, I will ask participants who wish to ask questions to identify themselves by pressing the raise hand button in WebEx or by pressing *3 on their phones for those who have called in. Based on the hearing schedule and the number of participants who wish to ask questions, I will determine the order in which participants will question the particular witness or panel and any time restrictions on that questioning. If there are more questions than we have time for today, it may be possible to ask additional questions on Monday afternoon after the conclusion of the final witness's testimony. I would also like to remind you that this proceeding is being recorded and transcribed by a court reporter. To ensure that the reporter is able to provide an accurate record of all of the testimony, questions, and responses, please remember to provide verbal responses to all questions. The court reporter may have a hard time seeing if you only nod or shake your head in response to a question. In addition, remember to identify yourself before beginning your testimony and before asking or answering a question. And do not worry, I know many participants are not accustomed to doing these things. I will try and remind you as we go along. Transcript of the hearing will be uploaded to the hearing docket on regulations.gov approximately 2 weeks following the hearing. Finally, I believe Ms. Tryon from the Solicitor's Office may have a few exhibits to enter into the record before we get to our first witness. Ms. Tryon, I think you're muted.
Thank you. Sorry about that, Your Honor. I would like to offer you the master index of the complete record of this rulemaking for inclusion in the hearing record. This is not a copy of all the documents that have been submitted to the docket. Rather, it is a list of all the documents that are part of the public docket of this rulemaking, docket number OSHA 2020-0004. All of the documents listed here are available for inspection and, as permissible, copying at the OSHA docket office. In addition, all of the documents are listed in the docket index for this rulemaking at www.regulations.gov, the federal e-rulemaking portal.
Thank you, Ms. Tryon. The master index, as presently available, is made a part of this record.
Thank you. I also have two exhibit-related requests. First, I would like to reserve exhibit number 1 for a complete list of hearing exhibits, which we will prepare after the close of the hearing. Second, I am marking a copy of the hearing schedule as exhibit number 2 and ask that it be entered into the record of this hearing.
I reserve exhibit 1 for the complete list of hearing exhibits as requested. The hearing schedule will be entered into the record as exhibit number 2.
Thank you, Your Honor.
Now, unless there are any further announcements or other housekeeping matters, I believe that we can proceed with the public testimony. The expected speaking order is currently displayed on the screen. I will be introducing each speaker in turn. Please speak slowly and clearly so our court reporter can record these proceedings accurately. First panel of speakers will be from the AFL-CIO, Rebecca Rendell, M.K. Fletcher, Peg Seminario, Bill Cjolin, and Randy Rabinowitz. Will the contractor please promote the speakers to be panelists?
They have been promoted. You can now unmute and turn on your cameras to provide your testimony.
Hi, can you hear me okay?
Ms. Rendell?
Yes, this is Rebecca Rangel.
You may begin, ma'am.
Thank you. Thank you for allowing the AFL-CIO the opportunity to testify at this hearing. My name is Rebecca Rangel, and I'm the Safety and Health Director at the AFL-CIO. I just want to note that our panel is going in a different order than it's listed on the screen, and we can ask to the appropriate person. We are the federation representing 57 national labor unions and their worker members across a wide variety of industries, including healthcare, construction, and food processing, and workers in many other industries. In March of 2020, AFL-CIO and unions petitioned OSHA for an emergency standard to protect workers from COVID exposures on the job. Since then, we have submitted 4 sets of comments and an enormous amount of evidence to this rulemaking record, including peer-reviewed studies, surveillance data, exposure data, and other documentation showing that healthcare workers and other workers remain at significant risk of material harm from COVID-19 because of exposures on their jobs. Exposure to COVID-19 is not just a public health issue. It is also specifically an occupational health issue and requires additional specific occupational health measures to control it. The COVID-19 pandemic is the largest occupational crisis ever. Yes, COVID-19 disease is spread in the workplace, and yes, it's preventable and can be controlled. And yes, we know how to do it. Next slide, please. Workplaces are different. Next slide, please. And the rules have to be different when people do not have control over their surrounding environments and conditions. That's why providing a safe workplace is the employer's responsibility under the Occupational Safety and Health Act. It's why protections have to be more specific in workplaces. My colleague on this panel, Peg, is going to elaborate on the sheer number and rate of healthcare worker infections during the first Omicron surge, when workers had nothing in place after OSHA announced it would withdraw the ETS. The impact she will present is astounding. Workers in other congregate settings need enforceable protections too. They have had nothing from OSHA other than unenforceable guidance the entire pandemic. And just like issuing other health rules under its statute, OSHA has a legal obligation to reduce significant risk to the extent feasible for all workers for whom that risk exists. Their risk still exists in 2022. In our many sets of comments to the agency and those from unions throughout this rulemaking record, we describe this risk, and we have known for a very long time what makes work settings at high risk. Crowded conditions, indoor environments, poor ventilation, being around infected people, staffing shortages. Last year, OSHA chose to narrow this rulemaking to healthcare because there are infected people all the time in healthcare settings. The probability of exposure is extremely high, and healthcare workers have frequent, prolonged exposures. A recent study showed that 52% of healthcare workers with COVID reported a known exposure to COVID at work. Next slide, please. Many workers involved in both direct patient care and not indirect patient care are at significant risk and have experienced disparate impacts from COVID exposures. A higher percentage of Blacks and Latinos work in healthcare occupations, including nurses, nursing aides, and home health workers, and many others. And many healthcare occupations are lower income. The healthcare workforce is older and many have existing comorbidities and health issues. So this standard is also about addressing disparities and creating a more equitable working environment that would improve livelihoods for a huge number of workers. Let me be very clear. A permanent COVID standard is needed, and it is urgently needed. A broader infectious disease standard is important, but it is years away. And as you'll hear from my colleagues on this panel and from others testifying at this hearing, workers remain at significant risk today from COVID-19 and urgently need those specific protections before another COVID surge. Since the ETS was issued last summer, we've had a new variant and subvariant that are more virulent and more transmissible than the ones before. Omicron is now the sole COVID variant spreading in the US. Research shows that its original form is 2 to 3 times as transmissible as Delta, which was just about to surge when the ETS was issued. And now we see the B2 subvariant is even more transmissible. We've seen how quickly things can turn once a variant takes hold. Without a standard or with a weak standard, workers remain unprotected from a known hazard. The past 2 years show that employers do not put adequate measures in workplaces with enough time to react to surges quickly. OSHA has not been able to issue any rules fast enough for that to happen. The idea that employers are just going to do the right thing on COVID with no standard or with a very weak baseline is irrational. They have shown just the opposite. On December 27th, when OSHA said it would be withdrawing the healthcare ETS in the middle of the Omicron surge, but that it encouraged employers to keep protecting healthcare workers. Employers have never been so quick to stop doing what they were doing when OSHA had told them to follow requirements. And many employers outside of healthcare have not adhered to any guidance, and there is no accountability for them to do so without any enforceable standard. Even though OSHA cannot get to every workplace, the effects of an affirmative OSHA standard are far-reaching by setting a strong baseline for employers to follow. So now is the time to plan and to get this right and to develop this rule expeditiously. Healthcare ETS that OSHA issued last summer was a huge step forward. It fell short on some areas that we will talk about the need to improve on. But it was a good start to ensure workers have the protections they need from COVID, and it did save lives. The problem with the existing ETS is it didn't incorporate all those things we've learned throughout the pandemic. It's as though the standard was issued the prior year. It doesn't correctly apply the science of COVID transmission. The language leaves too much wiggle room that workers haven't been able to get the protections out of the standard that the standard implied they would be able to do so to reduce their risk. And OSHA's notice for this hearing gives off the impression that we haven't learned anything the entire pandemic or since the ETS was issued. It seems to be an attempt to water down the ETS even more, and the notice still doesn't build on new and widely accepted information. So this is a critical moment for OSHA to fix that, and we appreciate them taking this step forward. So OSHA, you know how to do this. 2 years into the pandemic, we know more, not less. We've had 2 years to gather evidence and understand what works and what's most effective, what's needed, and employers have shown us what's feasible because they've done it. We know that promulgating a permanent standard is different than a temporary standard, but that's an opportunity and not a restriction to adapt to the moment we're in, and instead of running from it and use the information that we have. We've seen the results of actions and of the inactions. We know better now than to rely on deadly crisis policies that put workers at even greater risk. And we've seen employers race to the bottom when they are given no requirements to work towards. Unless OSHA steps in with strong protections that bring people back to work, we will soon be in an even more dire state. At a time when everyone needed work, employers ignored real safety measures because they could treat workers as disposable, letting them become infected and dying. They fought for laws on immunity to avoid all responsibilities to their workforce. But now that so many workers have died, are burned out, exhausted, and are leaving the workforce, employers are saying there's a staffing shortage. No, there are workplace safety and planning shortages. Simply put, OSHA standards require employers to adequately plan to prevent exposures. And just like other OSHA standards on infectious diseases and other workplace hazards, OSHA requires that in workplace plans, employers conduct a risk or exposure assessment. And this should be no different. OSHA's done this before. There are permanent infectious disease OSHA protections still in place. From the past, healthcare employers are used to implementing infectious disease protocols and programs and dealing with ongoing and probable exposures. We also know that workers cannot depend on CDC's metrics for how they're measuring and reporting COVID transmission, only now focusing on hospitalizations and deaths. We cannot use those metrics when OSHA also has the duty to protect workers from infection and from long-term disease acquired on their jobs. OSHA standards spur technology, they create demand, and they provide a roadmap. They always have, and we've seen what OSHA can do in COVID when it has the best, specific, most accurate enforcement tools, and my colleague MK will talk more about that. We could have done better 2 years ago, and we can do better now to make sure what happened 2 years ago never happens again. We don't make 2 years ago the new normal, and we don't make last summer the new normal. And we certainly don't go backwards from either of those time periods just because people are tired of COVID. This is a chance for OSHA and our federal government to get this right for working people. And one more thing, OSHA must not rely on CDC guidance and its permanent enforceable COVID standard. At this point in the pandemic, the idea that CDC's guidance has been sufficient to protect workers, to protect people and workers in particular, is unthinkable. I've covered some examples already, but the CDC guidelines have not only left workers at significant risk because it is weak, they have harmed workers. The agency also has no due process or requirements to produce an evidentiary record like OSHA does, like the hearings that we're having today. Comments in the record by employer associations say that because CDC changes guidance often, that OSHA should just lean in and adapt to that. But that's the wrong paradigm, and it's the opposite of what needs to be done. Because CDC changes guidance often for public health, OSHA needs a baseline of standards in workplaces where there are additional risks. OSHA is a workplace exposure control agency. Its obligations are reducing workers' exposures to hazards on the job, and OSHA's statutory obligations do not align with CDC's, and aligning with their policies is dangerous. So workers have felt abandoned by their government, and they're not only asking here for something unwieldy, something unknown, and something uncertain. They're not. This is not the time to roll back protections. This is not the time to ensure that permanent protections do not put us in the position that we've been in the entire pandemic, flip-flopping and not focusing on mitigation measures against an airborne pathogen. Time is running out to finally get this right for workers. Thank you so much for your time. When we take questions to our panel, I'm happy to direct them to the most appropriate person. I'll turn this over to my colleague, Peg Seminario, and then on to Bill, and then to MK, and then we have Randy here not to speak, but also on our a panel so she can be available for questions. Thank you.
Thank you. The next panelist, please unmute and turn on your camera. State your name and affiliation before beginning your testimony.
I am Peg Seminario. I am the retired Safety and Health Director, the AFLCIO, and I am appearing on behalf of the AFLCIO. And I appreciate the opportunity to join my colleagues from the AFLCIO to testify on the OSHA permanent standard for COVID-19 for healthcare workers. If I could have the next slide, please. As we heard from Ms. Reindel, COVID-19 has been the biggest occupational health crisis faced by workers in this country during OSHA's history and even before. For healthcare workers, they've been at particular risk because of the nature of their employment. And what we have currently, the current toll, which we know is an undercount, is enormous. CDC reports that healthcare personnel cases of COVID-19 infection are over 1 million. Healthcare personnel deaths, 4,100. And nursing home workers, where we have better data reported to CDC and CMS, similarly, over 1 million cases reported and 2,400 nursing home staff deaths. Next slide, please. But we also know that the data on healthcare worker COVID-19 infections and death are very incomplete, as OSHA has recognized. I think it's important to understand there's no requirement for occupation or industry to be reported on COVID case reports that come to CDC. Less than 15% of COVID infection case reports have healthcare worker employment status, and that we also know that a few of them have death information. We see that, when you look at the data and the sources of the data on healthcare worker infections come from only 27 states. And there are 3 states which predominate that reporting. And several large states, New York, Texas, Florida, they don't even report any healthcare worker infection data. So the numbers from CDC don't reflect the experience in a number of large states. There is a separate reporting system through CDC and CMS on nursing home data, which is mandatory, and that comes from 17,000 skilled nursing facilities. But there is no reporting of nursing home staff infections that come in from, by COVID infections by hospitals, assisted living, home health, and other healthcare settings. So again, we have detailed information on nursing homes, but basically very little, if any, information on other healthcare settings. Next slide, please. And as we have, as we all know, having lived through this pandemic, that there have been peaks and troughs in the pandemic, and healthcare workers have experienced, the same thing as the general public. And what we have seen most recently is the biggest surge of infections amongst healthcare workers during the Omicron period. Again, similar to what we've seen in the general public. And I think it's important to note that this surge began and exploded right after OSHA withdrew or announced it was not enforcing the ETS for healthcare workers. Next slide, please. And we've seen the same thing from the nursing home data, which again is more detailed and more complete than the data that comes in general for healthcare workers. And what we saw is that amongst nursing home workers, that the increase and the spike of infections was fast and furious. From the last week of December to mid-January, a 3-week period, there was a 500% increase in reported infections. And these are weekly reports to the CMS. And during the entire 10-week period of the Omicron surge in nursing homes, saw that 18% of all nursing home staff who were working were infected with the Omicron variant. So that's almost 20% of the nursing home workers in that 10-week period suffered a confirmed COVID infection. And as we'll hear more during this time period, we've had waning vaccine effectiveness, and we've also had, excuse me, a reduction in mandatory protections. Next slide, please. At the same time, that what we've also seen is that not only amongst nursing home workers, an increase in infections, we've also seen an increase in the reinfection rate among nursing home staff. Prior to Omicron, according to the CMS data, about every week, about 5 to 6% throughout the pandemic, the reinfections were responsible about 5 to 6% of all the positive tests. We get to Omicron, and you see immediately a very big, a big jump. And currently, you have about 13% of all of the infections amongst nursing home workers being reported every week are reinfections. So this shows us that that even reinfection, past infection, is not protecting nursing home workers from infection. And the same is true clearly of vaccination as well. Next slide, please. OSHA has asked for some information about, is there any data to compare healthcare workers with the general public? And again, as we discussed, the data on COVID-19 amongst workers is pretty, is not complete. Again, the nursing home data gives us, the best, most detailed information we have. And I did a comparison looking at the employment data reported by CMS, the reported infection rates. And what we have seen here is that during the Omicron surge, the rate of the infections amongst nursing home workers on a per 100,000 basis compared to the general public was more than twice as high as it was reported in the general public. I think it's also important to, again, the context on this, the nursing home staff, largely because of the CMS requirements, is much more heavily vaccinated, a much higher percentage of them are vaccinated, higher boosters than the general public. Looking at this among working age adults, CDC doesn't report the information among infection rates amongst, over 18, but looking at all the different, 10-year break periods, the data is reported that way. Amongst all the groups of adults, you see a lower rate of infection that was reported in nursing home workers and a lower rate of vaccination. Next slide, please. So focusing more on the need for better information and data going forward. As I said, we don't have any good data 2 years going into, more than 2 years into this pandemic. One source of data we do have now in healthcare are the COVID logs that are being required to be kept in healthcare workplaces covered by the standard. OSHA has suggested that those logs, the retention period be reduced to only, a year since the information was posted. We think this is a very bad idea. We think the log should be maintained for 5 years, as the OSHA 300 log is. And I think one of the things to think about, this is the best source of information we have in this country on healthcare infections and healthcare workers. And it's important to keep that in the workplace, to know what the trends are, what jobs have been, at risk. And it's also important to start collecting that information to get a better sense of risk amongst healthcare workers. We have advocated since the beginning of this pandemic for direct reporting of COVID infections, and particularly outbreaks, to the agency, because again, we don't have a way of tracking this. And we continue to call for outbreak reporting, and that would be a requirement that an employer report an outbreak, and they defined as 2 or 3 cases at the same workplace with the last 14 days. And that information should be publicly available by facility. Number of states have adopted these requirements. California, Virginia had them in place. Michigan, the state of New Mexico requires reporting of every COVID case in a workplace to the agency, and they use that to track and focus on those workplaces that are at high risk. And OSHA really needs to do the same. It's no different than your severe injury reporting. It's really something that needs to be done because it is the only way we are going to be able to look at and find workplaces where workers are at risk. And finally, the recording and reporting requirements on COVID, both the log, the improvements or the clarification on reporting hospitalizations and deaths, and also COVID outbreak reporting, they really should be extended to all workplaces. OSHA needs to know what is going on, not only in healthcare workplaces, but other workplaces as well. So we really call again for expanding and strengthening the recording and reporting, but applying it to all workplaces. We think it's the least that OSHA can do at this point for protecting workers outside of healthcare, since the healthcare standard does not apply to them. Thank you very much.
Thank you. Will the next panelist please unmute and turn on your camera and state your name and affiliation before beginning your testimony?
Thank you, Your Honor. My name is Bill Cjolin. I'm the retired industrial hygienist at the AFLCIO, and I'm pleased to join the panel today and have an opportunity to testify on this important rulemaking effort. There is substantial and overwhelming evidence in the OSHA docket that COVID-19 is an airborne transmissible disease. And in the AFL's submission recently to the docket, we've added new and overwhelming evidence that supports that conclusion that it's an airborne transmissible disease. And those exposures can infect workers both in the long range and in close proximity to the source of the exposure. Recently, really at the highest levels of our national government, the White House Office of Science and Technology Policy has concluded that airborne transmission is the, quote, most common way COVID-19 is transmitted, close quote. From a scientific perspective, we really ought to look at viruses like SARS-CoV-2 and regard all respiratory viruses as aerosol transmissible diseases, just like the original SARS, influenza, and so forth, as an airborne transmissible disease. And that ought to be our default so that we protect workers from the very beginning. It took far too long in this pandemic to acknowledge and to respond to the fact that this is an airborne transmissible disease and that put workers at increased risk. Currently, there's heightened concern for exposures in the healthcare industry. The Omicron variant is the sole variant that exists in the United States at this point in time, and it's 2 to 3 times more transmissible than the Delta variant, which puts healthcare workers at elevated risk. So OSHA traditionally and appropriately has required the hierarchy of controls to eliminate or reduce exposures. And that applies to airborne infectious diseases as well, like SARS-CoV-2 and other respiratory hazards. High among the hierarchy is ventilation and filtration. The Office of Science Technology Policy at the White House emphasizes ventilation as a means to control an airborne transmissible disease. There's plenty of evidence in the record that shows that ventilation and filtration is both feasible and available. There's documents from ASHRAE to look at buildings. There's portable ventilation units equipped with HEPA filters that can reduce exposures significantly. NIOSH has on its website ventilated headboards that they've helped develop, and they have instructions for how to construct these devices. NIOSH also has information on setting up temporary airborne isolation infection rooms in the case of surges. So there's plenty of information on ventilation that can be used in the final rule. Last in the hierarchy is respiratory protection, where other means higher in the hierarchy are either not feasible or are being put in place. And that's respiratory protection for an airborne transmissible disease. OSHA requires, when workers are exposed to respiratory hazards, that they be provided with a NIOSH-approved respirator. Not masks, not surgical masks, not barrier face coverings. Those are all forms of source control. No. Workers who are exposed to an airborne infectious agent need to be provided a NIOSH respirator. And that the minimum is an N95 filtering face-piece respirator. Other reusable forms like elastomeric respirators and PAPRs also can be used and have certain advantages over the disposable N95s. I'd like to shift my focus now to vaccine effectiveness. Vaccines have played an important role in protecting workers from COVID-19, particularly against serious illness and death. But vaccines are not a magic bullet. They don't offer effective protection against workers becoming infected. We need to implement the way that OSHA traditionally addresses a respiratory hazard by reducing or eliminating exposures using the hierarchy of controls so workers don't become infected at all. So why isn't the vaccine a magic bullet? Well, we found, and there's evidence in the record, that 2 doses, the protection of a vaccine declines with time. It provides limited protection against Omicron infection. 1 booster to the vaccine, which is not permitted, it provides protection from serious illness but with Omicron, it too declines after 1 booster. And the protection against infection also declines over time. And now in this country, there's a 2nd booster that is permitted in the midst of this Omicron surge. And there's recent evidence to show that the protection and effectiveness declines over time with regards to a serious illness. And in terms of protecting against infection, by the 8th week, we're talking about 2 months after you get the 4th booster, the protection against infection essentially declines completely. Now I'd like to shift to one of the principal reasons why we need to reduce or eliminate exposure, and that's to prevent workers from experiencing long COVID. The acute effects of becoming infected, the deaths, the serious illnesses are well known. The symptomatic infections are well known. But we now know that there are persistent long-term symptoms in workers who have experienced COVID-19 infection. Recently, President Biden has launched a major government effort to respond to long COVID because it's going to be a long, both public health and workplace problem for people in the general public and for workers as well. Mild COVID-19 results in 40% of those who've had a mild case of COVID-19 have long-term symptoms of fatigue, shortness of breath, memory loss, and many other symptoms. Among those with mild COVID-19, around 20% are unable to work. For a higher level, a more severe level of infection, hospitalized patients, one study showed that around 18% of those workers are no longer working, and 19% changed their occupational status in some way in response to experiencing long COVID. For workers who have been in the ICU, it's pretty much the next step before dying. 75% of those who were admitted to the ICU after COVID-19, 75% are experiencing physical symptoms, and 58% had work-related problems. So it's hugely important that we control and reduce exposures so that we prevent workers from becoming infected at all. Healthcare workers are at high risk of developing COVID. In a recent study in the UK, healthcare workers were the third most likely occupation to report long COVID symptoms. So it's not, so healthcare workers are at high risk of experiencing long COVID symptoms. That concludes my testimony. Thank you very much.
Thank you. Will the next panelist please unmute and turn on your camera and state your name and affiliation before beginning your testimony?
Yes, hi, I am MK Fletcher. I'm the Safety and Health Specialist at the AFLCIO. And if we could advance, I think it's 2 slides. Thank you very much. Workers need an enforceable permanent standard. As we have seen throughout this pandemic, employers need clear requirements to prevent workplace exposures, and without them, there is no way to ensure they're implementing the combination of layered protections and relying on the hierarchy of controls necessary to prevent exposure to COVID. Before OSHA issued the healthcare ETS, during those more than 16 months, the agency only issued 4 general duty clause citations in healthcare. In 3 of these instances, there was a fatality, and 1 involved the willful spread of COVID by a symptomatic employer that resulted in an outbreak. These citations were in response to tragedies. They were not preventative. The agency was generally able to cite when employers did not provide respirators or PPE or didn't follow record-keeping rules. But they were unable to cite when employers did not provide the comprehensive controls on their own as part of a larger plan necessary to address COVID-19 exposures. After OSHA issued an enforceable standard in healthcare, in just those 6 months, OSHA was able to issue more than 200 citations with violations that were specific to preventing COVID-19 exposures. OSHA cited employers who were not following critical areas of the standard to protect workers. Some of these included conducting a hazard assessment, creating a plan to address the COVID hazards that they identified, workers having input into that plan, screening patients for COVID, distancing, ventilation, notifying workers when they'd had an exposure, removing sick and exposed workers to prevent further workplace exposure, all the while maintaining their pay, status, and other benefits while they had to be out, training workers on the virus and the control measures in place to keep them safe, and keeping a log of COVID-19 infections in the workplace, which is critical, as Peg discussed. These protections were in addition to providing respirators and PPE and following the record-keeping rules, because these 3 things are not enough. And these specific protections as a whole package matter. They prevent exposures and keep workers from becoming infected in the workplace. A standard requires employers to have a plan to prevent COVID exposures on the job. They're required to assess their workplace to determine where the COVID hazards exist, and then develop and implement a plan to address the risks that have been found. Requiring this approach is how all programmatic OSHA standards work. Employers tailor their plan to the risks in their workplace without being overly prescriptive. This adds flexibility while ensuring the critical elements are there that all workers need to be protected through the implementation of effective control measures for COVID. And employers who don't simply plan and plan effectively can be held accountable. Without an enforceable standard, employers don't have to allow workers and their representatives to have any input into the plan to prevent COVID exposures. Our unions have expressed that some employers were hostile to partnerships on health and safety and resisted worker involvement. However, with a standard requiring the participation of workers, workers are able to provide their job expertise in developing the plan that is intended to protect them. Without a standard, employers don't have to inform workers when they've been exposed to the virus at work. You'll hear many of these examples from the union members who are here to share their experiences and expertise with the agency this week. Without a standard, employers stopped informing workers. Workers deserve to be told when they're exposed to any hazard, so they can participate in surveillance programs, monitor their own health, and make the personal decisions that are best for themselves and their families. Workers have the right to know their exposures to hazards on the job. OSHA asked for comment on creating more general provisions in a final standard, and this approach is the exact opposite of what should be done. And it also undermines the enforceability of a standard. OSHA standards specifically require the most effective control measures, and in every OSHA permanent standard, these specific provisions save lives. For example, adequate ventilation is critical to reducing the amount of virus in the air and addressing airborne transmission. The ETS required general ventilation requirements, but a permit standard should require specifics on ventilation. The authoritative body, ASHRAE, has specific recommendations in the healthcare industry, and those should be the minimum of what is required. This approach is necessary and feasible for a permanent standard. A permanent standard is different than something that is emergency and temporary. The employers will have adequate time to implement proper ventilation to address airborne transmission. Requiring some specificity in an OSHA standard is not new and is present in other OSHA standards. Recently, OSHA issued a standard on silica, maybe a couple of years ago now, but it doesn't just require specific ventilation measures, but it requires those measures based on the task being performed, down to very detailed information. OSHA must approach COVID protections with the same significance and clarity as other workplace hazards. Without these specific requirements in a standard, the standard is actually less enforceable and less effective for workers who need to ensure their employers are specifically addressing this hazard with the most effective controls. Otherwise, it will not result in reducing the significant risk that workers face from COVID. OSHA itself has explained this in the preamble to the ETS, stating that the general duty clause offered broad protections, but, and I quote, conveying obligations as clearly and specifically as possible provides employers with enhanced notice of how to comply with their OSHA Act obligations to protect workers from COVID-19. Also, to add, these specifics allow OSHA to require proper abatement when COVID hazards are found. OSHA must clearly require effective protections against airborne transmission so that employers and workers alike know what to expect on the job, and so that OSHA has the tools that it needs to ensure employers are keeping workers safe against a highly contagious virus that could become endemic. As we have for more than 2 years, we urge OSHA to move quickly to protect workers from COVID-19 exposures using a clear, comprehensive standard. The AFL supports this COVID standard being the basis of precautions for another novel strain of virus. Airborne precautions have been needed this entire pandemic, and just as we stated in our petition to the agency more than 2 years ago, and they'll be needed again to keep viral transmission at bay. If we had applied what we knew from SARS that we learned years ago to COVID, things would have not been this bad. We must apply the knowledge that we have. OSHA must. They must finally get this right for workers. And that concludes mine, and thank you so much for having us today.
Thank you. Mr. Rabinowitz, am I correct that you are available to answer questions but will not provide additional testimony?
That's correct. And it's Ms. Rabinowitz. Thank you.
All right, thank you, sir. Do the OSHA representatives have questions for this panel?
Yes, Your Honor, thank you. And just a minor point of clarification, it's Ms. Rabinowitz.
My apologies.
For Ms. Rindell, in your testimony, you talked about employers rolling back protections for COVID following OSHA's announcement that it was no longer going to be enforcing the ETS. Do you have some examples, either here or in post-hearing comments, to amplify that?
Excuse me, absolutely. I leave it to the unions who will be testifying to present some specific examples, and we're also happy to follow up in post-hearing comments.
Great. Thank you. For Ms. Seminario, in your testimony, you talked about the importance of outbreak investigations, and you proposed that OSHA should require employers notify OSHA, or the employer should notify OSHA when they have 2 to 3 cases of COVID in their workplace. Since the standard will apply to a wide range of settings, including smaller ambulatory care settings and large hospitals that may have many thousands of employees, is 2 to 3 cases over a 14-day period the right way to approach this for all employers that might be covered by the standard?
The reason why we have proposed 2 or 3 is that is what the recommendation of CSTE is on outbreak reporting for COVID. And different states have applied different triggers at different points in the pandemic. It might not be the best approach given the size differential and the risk, but as far as a ease and a clarity, I think that's one of the things that is really important with respect to the rule, is to be clear as to what the obligations are. As I said in my comments here, New Mexico OSHA at the beginning of the pandemic put in place a requirement that all employers had to report a single case of COVID to the state OSHA. And that after, I think it was 2 cases, they would put on a rapid response list and listed on the agency's webpage. And so I would say that, at a minimum, it's 2 or 3. Again, I think 3 is what is most of the a number of the states are using now, but 2 was the original recommendation of CSDE. So I would say go with what is simple and clear and consistent with what has been done. But the most important thing is to get the information in quickly. And we don't think this will overwhelm the agency. I know that there were concerns about that, but it's been shown that it's quite feasible to do this, because OSHA has no way of knowing right now where there are problems with respect to COVID transmission. And this is a very good way to do it. It's even more important now because as we do less and less contact tracing, the states are doing much less contact tracing. And that was a source in a number of states who did not require outbreak reporting, was getting it through their health departments, follow up on contact tracing. But that essentially is now not being done as by many states. They're focusing much more on hospitalization. So,
thank you. For Mr. Cjolin, in your testimony, and I take your point about COVID being an airborne transmissible disease and the need for ventilation and other elements of the hierarchy of controls before PPE. I think that you're still in the position that PPE is required at some times. And what I'm particularly interested in is your thoughts on PPE for workers who are not dealing with suspected or confirmed cases of COVID. So the current CDC recommendations and the OSHA standard before, the ETS had required respirators when people are dealing with suspected or confirmed cases. But let's say somebody is in an ambulatory care setting and is doing dialysis on somebody for whom there's no suspicion of COVID. What is the appropriate PPE for that person?
Well, okay, the person who is providing care, of course, with a known or suspected patient with COVID-19. However, other workers share that same airspace and inhale the virus, whether they're actually providing care or doing other ancillary duties in connection with their job, where they may very well be exposed to the virus that's present in the air. So those workers also need to be protected, and that may include the use of respiratory protection and something other than a source control device.
So I understand for workers who are in the area of somebody with COVID, whether they're providing care or they're providing support services, but are you saying that for people for whom there is no suspicion of COVID, they've been screened and or they exhibit no symptoms or cause suspicion, should everybody be in respirators because of the potential for asymptomatic transmission, or are there healthcare duties and tasks where surgical masks, medical masks, or other PPE might be the appropriate protection?
Employers have to do an exposure assessment, and they need to determine whether or not there's potential risk for exposure to the virus. But I think it's important to make sure that it's not narrowly constructed in terms of the workers that are provided with respiratory protection, and that it be expanded so that make sure that if there is risk or potential risk for exposure to the airborne virus, that they be provided with respiratory protection.
If I could just add to that briefly, I think it's important to understand here, you're trying to protect people from exposure to the virus, as Bill said. CDC currently for the public, since Omicron appeared, has recommended the most protective masks for members of the public who are exposed. And that is an N95. They also say the most comfortable, whatever, but the whole point here is to protect people. And I think that we have to get away from the idea here that a surgical mask protects people from exposure, because it doesn't. And so I would say that the highest level of protection, where you have a likely exposure, probable exposure here, is one that you need an N95. And for OSHA to use what it has done in past standards as an approach to exposure and exposure assessment, as Rebecca and Bill laid out, as being a core part of trying to make that assessment in a particular workplace setting.
That last answer came from PEG Seminario.
Sorry, thank you, Your Honor.
If I could add, this is Rebecca Reindell. I think I just also want to, Mr. Levinson used the term screening, and I just think that has been so variable. And what was laid out in the ETS in terms of screening was totally inadequate. So if we're basing anything on screening, I just think that's a difficult place to to start from in something like a healthcare setting. Thank you.
Sure. So I think while we're on the topic of screening, either for patients or for employees, when somebody's doing screening to determine whether or not somebody is suspected of having COVID, there are lots of symptoms that cover multiple illnesses, including runny nose or headaches or diarrhea, sore throats. What should an employer do if they're screening either employees or patients and anybody reports a very common symptom like that? Does that automatically become a suspected case of COVID?
PEG Seminario here. You test that person. You basically do a further assessment. I mean, we're able to do that now. I think one of the things here is that, as Rebecca said, we know a lot more. We have a lot more tools. I mean, what would you do if you had a member of your family exhibiting those symptoms? You would test them for COVID. And so one of the things that we think OSHA really needs to look at here and think about is how do you look at a testing regimen in a healthcare setting in particular, given that they're high risk, for people that need to be tested for making those determinations. The symptoms testing or screening, again, is pretty weak. I mean, in all the healthcare encounters I've had, and most recently yesterday, going to my physical therapy, there's nobody asking about any screening anymore in healthcare settings. So I think that's a fallacy. That's not happening. And so looking at when does it make sense to be conducting testing of individuals, isolation of individuals here, until you know rapidly, that there's a problem here. You take the precautionary approach, but you do it with the tools that we have now. And I think it's really critical that the OSHA standard reflect the tools and the knowledge we have now and not be based on what we knew 6 months ago, a year ago.
Thank you. I know I have some other folks. Yep, I know I have some other folks on the OSHA panel. How about Joe Coble?
Yes, good morning. I'd like to follow up on you noted that the airborne risk is heightened in poorly ventilated spaces. And to what extent, in your opinion, do you feel the current building codes and ASHRAE standards for hospitals and other healthcare settings provide adequate ventilation for prevention of airborne transmission? And then maybe Mr. Cjolin could address that.
Well, I don't know what you mean by adequate, but it's certainly an approach to reduce exposure. And there are other approaches that can be used simultaneously with ASHRAE approach in rooms with patients who are known or suspected of having COVID-19, and using portable ventilation units equipped with a HEPA vac. There's evidence in the record that shows that those are effective. Ventilated headboards as well with patients who are known or suspected of being infected with COVID-19 as well.
Peg Seminario, just to follow up. I mean, the ASHRAE standards, at least my understanding, and I am not an expert in hospital ventilation, is that they apply going forward. And that is 170 applies to new construction, renovations, additions in a facility. And so what you have in the healthcare setting is you've got a whole range of different kinds of facilities. And so we think that the standard is it's what we have now. Maybe ASHRAE will look at it in light of COVID, that would be a useful thing to be done. But, as you are well aware, OSHA puts requirements on engineering controls on employers, in all the standards. And the way that they've dealt with it in terms of feasibility is not just to say, oh, if you build a new building or when you renovate or you update your process here, you put in the ventilation, there's an affirmative requirement to do so. And you always give employers time to do that, right? So this isn't a new concept for OSHA. It may be not what's in the ASHRAE standard, but I think it's something to think about here going forward, both for COVID and also for your broader infectious disease standard, because we've got to start thinking about these exposures in healthcare the same way we do about other workplace exposures, and not set up a whole different structure and approach to dealing with what is an airborne hazard in the workplace, that workers need protection from. So I would say that with respect to also the building codes, they may incorporate 170, but a lot of the building codes for other healthcare facilities, I'm not sure that they all apply 170 to all healthcare settings. And the other standards on ASHRAE are just general ventilation for comfort. They don't even take into account anything with respect to controlling bioaerosols. And so I think it's something to, to look at, but right now you're focusing on healthcare and it'd be something to ask some of the healthcare employers about, right? How are they, what is the current state of ventilation and compliance with 170 in their facilities?
Well, thank you.
Andy, I think you're on mute too.
Sorry. Thank you. I was going to call on you, Chuck.
Okay, thanks. Yeah, Chuck McCormick, I'm an economist at OSHA. And Rebecca, I'd like to ask you a couple of questions. And so the first question is, we've received a number of comments suggesting that small rural hospitals cannot sustain the costs associated with paid medical removal, particularly if they have to contract or hire contract staff to fill in while they're also paying sick staff to be out of work. Do you have any information to offer regarding whether those claims are accurate?
Thanks, Chuck. I do. This is Rebecca Reinfection for the record. I do not have examples on hand, but I can certainly add them to my list for post-hearing.
Okay, thank you very much.
If I could add something, and this is just by way of being a little ancient here. A similar claim was made when OSHA first adopted MRP for lead. And a lot of employers said that they couldn't afford the initial phases of MRP because too many people would qualify. And at the time, OSHA came up with some guidance, like if you have this many employees or this proportion of your workplace, we'll presume it creates some feasibility problems, and required individual employers to submit proof that they met that general standard. And so that's a model that OSHA has used in the past that kept the MRP requirement in the law. But when there was a particular burden on any individual employer, ease that a little bit going forward. So I suggest that it's dated. It's from the late 70s, but it is possible to go dig it up and find it. So that's the one that I'm aware of when it came up before.
Okay, well, thank you. So Rebecca, let me just ask you a second question. More generally, in your experience, has the ETS helped convince people to stay in their jobs? In other words, do you believe workers are less likely to leave their jobs if they believe they're working in a safe workplace that provides adequate protection against COVID?
Yes, thanks, Chuck. That's a great question. From our experiences and the member experiences of our unions, that is true. That when their employers have been following the standard, that they have had safety protections in place that have made them more likely to come to work. Now, I will say that there are other policies that directly affect the impact that the ETS can have as well, like around staffing and, and so and it's hard to say also that the ETS was only in place for 6 months and that many states did not adopt that right away. So in some cases, it was only in place for a few months. But I think it's important to note that when Omicron hit, that's when many employers had just started rolling back. And so the surge around Omicron really shows you what can happen when the standard is not in effect. If you look at the Omicron surge compared to the serious impact of the Delta surge in the summer, I think you can start to see some differences there. So it's definitely a complex web, but the direct experiences of our union's membership is that that having those programs in place and having that employee representation at the table, having the participation of enforcing the standard, all had a significant impact on workers.
So thanks. So the only other thing I'd like to add is that, if you have any data, studies, other information about the things we've been talking about this morning, if you could please submit it to the docket, we would really appreciate it. Thank you.
Thank you. Amy Tryon for OSHA Solicitors.
Hi, good morning. I'm Amy Tryon with the Solicitor's Office. I wanted to start with a follow-up for Peg about you're advocating for, this is to do with screening testing for people who are displaying symptoms like common symptoms like a runny nose and similar things like that, that could be anything. And I wanted to ask your thoughts on who should be paying for those tests. You know, the CDC has disclaimed the need for screening tests. Should employers be paying for them? Nonetheless, do you have any evidence that insurers would pay for those? What are your thoughts on that?
You know, my thoughts is that employers in healthcare settings need to figure out how to implement testing as a way of determining risk, right? Again, no different than what OSHA requires with respect to doing an assessment on individuals, excuse me, with, you know, exposure monitoring. I mean, really look at this more as a exposure issue than as looking at it as somebody, I mean, it is because they are being, you know, infected. And so, you know, I would say if the whole point of screening, right, is to make a determination of the individual as to whether they should be coming into that setting, right? I mean, that's what we're talking about here. So what are we saying? That when somebody has symptoms, they should come in, right? I mean, that's essentially, I think, you know, coming up with, you know, some criteria as to what would, and I'm not saying just because somebody has watery eyes or anything, but coming up with some criteria for when you then make a determination as to whether or not that person should come in or should not come in. And I think in a hospital, thinking about it as somebody coming in who's going to be spending time there being inpatient, you should know with people coming into the facility and they're going to be there for any length of time, exposing folks, whether they're positive or not. And I know that, you know, from what we've heard from the unions, that the testing of people coming into a facility for inpatient care is now declining, right? And so I think that would be, you know, an approach that the agency should take. I don't have all the specifics lined out. We can certainly give it some thought. Talk more to the unions about how this would work and provide that post-hearing. But I think it's thinking about the concept of what you're trying to do and how you do it to identify the people who may be infected and bringing the virus into the work environment.
I would just add that to the extent that testing is required to maintain a safe workplace, OSHA has opined in the past that it is an employer's legal obligation to bear those costs and that the statute requires that. We don't see it as any different here, that it's inappropriate to shift the cost onto the workers of making sure that the workplace is safe.
Thank you. And just to clarify, are you advocating that everybody be tested upon arrival at a healthcare facility, at a nursing home, or just people who are show any symptoms? What's your opinion on that?
Peg Seminario here. Again, I think, you know, thinking about it for anybody who's going to be coming into a facility, who's going to be, you know, admitted, I mean, I would want to know whether or not they're positive, you know, what they're, given where we are in this pandemic. And again, we've got cases going back up. I mean, they're not as, you know, the level of infection is not what it was, but for a healthcare setting, it's still significant, right? It is still significant. And they are the high risk settings. And so definitely for all patients who are going to be admitted to that facility, you want to know, why wouldn't you, right? I mean, you know, you want to test those folks. Looking at, you know, other folks here, thinking about that, again, I think we need to give that some thought and talk to the unions and provide you, you know, some more specifics on it as we, you know, prepare our post-hearing comments on that.
Thank you. And then sort of relatedly, to the extent, you know, there were some mentions that it can be difficult to determine who has COVID and it's important that everybody be protected. What is your position on who should be wearing N95s? Should it be everyone in the hospital, everyone in the nursing home? Should it vary based on what type of facility it is? What's your position on that?
I think it's based upon an exposure assessment of the that the employer conducts, right? I think anybody who is, you know, involved with patient care at this point in time, whether or not it's a suspected or confirmed COVID patient, at this point in time where we are, should probably be wearing an N95, right? Unless we have, you know, knowledge, and until the person is ruled out, as not being infected, you've got to presume in those settings that they, that they are. And so again, but it all comes back to the exposure assessment and not the, and it was what Mr. Levinson raises the first question, which is, do we just look at people who are suspected or confirmed? And I think we now know that just because you're suspected or confirmed doesn't mean that there's not asymptomatic transmission. And the other thing we also know from the various studies that have been done, that some of the highest rates of infection amongst healthcare staff have been those in support positions in environmental services, people who work in the area not directly involved in direct patient care. And I think you'll hear more from the unions who are testifying about how hospitals actually work, right? And who's where and who is potentially exposed and has a probability of exposure. So I think those are the things that the agency needs to look at.
Thanks. And just one more question on testing. So would you, specifically to long-term care facilities, nursing homes, where there are patients who are in there long-term and not just sort of entering, staying and leaving, what sort of frequency of testing do you think is appropriate for people who are, maybe test negative on a Monday, but are there long-term and could contract COVID?
CMS actually has guidelines on that. They changed over time. I need to look at those. I looked at them last week. Again, I don't follow all of this in great detail, but they have very specific, not only guidelines, requirements, because of their regulations on nursing homes. And they are different for residents and staff. And so I would say, look at those. We will look at them as well and follow up as to whether we think they're adequate. But it's not as though there are, practice on this already in facilities. And I would ask some of the hospitals and others about what have they done on testing in facilities, and what are they doing now, but also, what the practice has been, because I think, as you'll hear, the practices are changing as everybody wants this pandemic to be done with, even though the exposures and the risks haven't gone away, and certainly not for healthcare workers.
Thank you. And I have just one more question again to Peg. You had mentioned the importance of the COVID logs. And we were wondering just if you happen to have access to any of these logs, or has AFLCIO done any analysis that you could provide to the record?
We have not, because we don't have direct access. We don't represent
Okay.
people. But some of the unions have, and I know, for example, NYSNA, who you'll be hearing from during the hearing, New York nurses, have done an assessment called in the COVID logs, trying to do an assessment, and they can tell you what they've seen, but also some of the problems with respect to what is allowed in access. And I think one of the problems is that for because of the way the access is permitted in the standard, it says you can't get the information on the job title or whatever the task was, whatever identifies what the person, who they are. And so it's been difficult for them to use them for an assessment in the workplace to look at what occupations and which jobs are at risk. And so we would suggest on the COVID log, and we put this in our comments, that you make them more comparable to what's on the OSHA log, which is, I think it's job title is what is in the OSHA log itself, the 300, and make that information available to, to workers and their representatives, taking off the worker's name, the personal identification information, because absent that, they're really not as useful as they need to be to figure out where is COVID occurring in the workplace and who is at risk. And that's really the biggest utility of those logs. So.
Thank you very much. Those are all the questions I have.
Okay, and I just have one more question for the AFL panel. If a healthcare facility is already following the CDC or the CMS recommendations or requirements on standard cleaning and disinfection in healthcare facilities, do you believe that there are any additional COVID-specific cleaning or disinfection requirements that should be required by a final standard? And if so, do you have any data to support that conclusion?
I can double check with our panelists, but I don't believe we have anything specific to recommend right now. We can certainly add it to our post-hearing list.
Thank you. Your Honor, that concludes the questions from the OSHA folks.
Thank you, Mr. Levinson. If any witness has a question for a member of this panel, please raise your hand or *3.
Judge, we have 2 raised hands. Carmen Comsty and Theo Allen.
Can you unmute
Mm-hmm.
the first individual, please?
Sure. Carmen, I'm unmuting you now.
Carmen, can you hear me? This is Judge Henley. Please unmute.
Yes, I can hear you. Can you hear me?
We can. Please provide us your name and affiliation, and if you can direct your question to a specific panelist, that would help.
Thanks, Your Honor. My name's Carmen Comsty. I'm with National Nurses United. I'm lead regulatory policy specialist with NNU. I had a couple of questions for Peg. You've talked about medical removal protections. Can you talk about the purpose of medical removal protections and why specifically it's important in a COVID standard?
Yes, thank you for that question. Medical removal protection has been included in a number of OSHA health standards going back to lead issued in 1978. One of the purposes of it was to encourage workers to participate in the medical screening because, obviously workers have some concern about being identified as having a health issue. If then that's going to cost them a loss of income. And that standard also required that people be removed based upon their blood lead exposures. And so the purpose of it was stated to encourage people to fully participate because it was important that they not stay in the workplace to be continually exposed. I mean, here in this case, it's really important because not only will they potentially be exposed, they are the source of the transmission, and so it becomes even more important. I think the other thing that we should think about with medical removal protection is that it, again, because of the fact that in this case it is the infected individual who is the source, and so it really is a control measure of removing that person from the workplace if they are positive or have been exposed and may become positive. And those costs of compliance of removing and isolating people, which is a control measure, have always had to be borne by the employer. And so in both of those regards, I think it's really critical. And I would point out there's a difference in this rule than other OSHA rules, and that this rule actually, limits the amount of pay for an individual. It caps that at a level which we don't think is appropriate. And OSHA has now suggested that they wouldn't provide MRP for people who were, maybe covered under some other, requirements. And I think it was CMS, and CMS does not require that people be paid if they are, for time for vaccination. I'm sorry, I was confusing the two. So it's really important as both encouraging people to get tested and to talk about their symptoms, as well as putting the cost of compliance on an employer.
This is Carmen again. Thank you, Peg, for that answer. I had a couple of questions for a number of the panelists on the OSHA's statutory responsibility and the CDC. So in the AFL-CIO's comments, you mentioned that OSHA's statutory responsibility is different than the CDC's, and I think this may be a good question for Randy. What's the difference between the statutory purposes of the OSHA Act and the CDC's statutory responsibility? Thanks.
So I can speak to the legal difference as opposed to whether CDC's protections are adequate. So in the most recent case, the Supreme Court case, NFIB versus OSHA, the court drew a distinction between public health regulation generally and occupational health regulation, which they thought were two different things. OSHA is required to meet certain statutory criteria to set a standard. They're not the same as CDC guidance requirements, and CDC, as someone mentioned earlier, doesn't develop an evidentiary record, doesn't have to provide a statement of reasons for the scientific basis for its guidance documents. We also think that in the 11th Circuit's decision in the Pell's case requires OSHA to determine that any particular requirements it imposes address a significant risk, adequately eliminate a significant risk to the extent feasible. And there's no assurance that a CDC requirement meets those statutory criteria, which is OSHA's obligation. And finally, there's a lot of academic literature about how it's inappropriate for agencies to incorporate future consensus requirements into their regulatory regime. It's called dynamic incorporation by reference, and it fails to meet the notice and comment requirements in the OSHA statute or the APA. And so we think it would be a particularly risky legal strategy for OSHA to essentially defer to CDC, and that given the delay we've already seen in getting adequate protections in place against COVID, it would be foolish to try such a risky legal strategy, which could have the effect of further delaying getting enforceable COVID protections on the books.
And if I could just add, I think
I'm sorry, Ms. Seminario, we don't have a lot of time for back and forth, so I'm going to advise today. We'll see if we can have additional questions on Monday, but I'll give Ms. Comsty, if you have one more question that you'd like to pose now, you may ask it. Otherwise, we're going to move on.
Great. Sure. I do have one more question, and this question is for Bill. So, Bill, you talked about the need for respirators in a COVID standard. How important is it for respirator wearers in healthcare settings to have a fully compliant respiratory protection program under Section 1910.134 in place? Thanks.
Yes, this is Bill Cjolin. It's critically important. A respirator cannot provide its intended level of protection in the absence of being as part of a fully compliant respiratory protection program under 1910.134. For example, the standard requires medical evaluation to determine whether or not the worker is medically suitable for wearing that particular device, and that needs to be determined. They need to collect you need to select the correct respirator for the exposure that the worker is experiencing, and will that device protect the worker against that exposure. A fully compliant respirator program would require fit testing to determine whether or not that device fits adequately on the face of the worker. And if that didn't occur, that worker may be given a device that doesn't seal properly with the face, allowing contaminants to enter the breathing zone, and therefore putting the worker at risk of developing, in this case, an infection with SARS-CoV-2. Also, decontamination. There are decontamination requirements for reusable respirators, and that's to ensure that when the device is being used, and it's being exposed to infectious agents, that it be effectively cleaned and disinfected before it's worn again. And so all of these things are part of a fully compliant respirator protection program that is administered by the respirator administrator so that someone has authority to run the entire program. So just handing a respirator to someone and doing nothing else doesn't come close to guaranteeing the protection that that device is supposed to provide.
Thank you, sir. This is Judge Henley. Unfortunately, to remain on schedule and to provide the remaining panel members time to testify today, we don't have additional time for questions of this panel today. I indicated we'll try to add you to the last day upon completion of all the testimony. I'd like to thank the panel members from the AFL-CIO for their testimony this morning. We're going to take a short recess before we hear from the SEII witnesses. We'll reconvene in 10 minutes. That is 11:20 a.m. Until then, we're in recess. Okay, welcome back, everybody. Can the contractor pull down the slide, please?
Yes, Judge, apologies. We are just updating the next slide with the updated order of speakers.
So we are back on the record. Before proceeding with the next panel, I believe, Ms. Tryon, you have an additional exhibit to offer.
Yes, Your Honor. We have marked the PowerPoint presentation used by the AFL-CIO in the their presentation that just finished as Exhibit 3, and we'd like to offer that for inclusion in the record.
So included.
Thank you.
The next panel is from the Service Employees International Union. This morning, we'll hear from Adelina Ramos, and then after our lunch break, we'll hear from Leslie Fran. If I can ask the contractor to promote speakers, please, to panelists. Good morning, Ms. Ramos. Can you hear me?
Good morning.
Will you please state your full name and affiliation before beginning your testimony?
My name is Adelina Ramos. I'm a CNA at nursing home in Greenville, Rhode Island, and with the union SEIU 1199.
Thank you. You may proceed.
Good morning. Thank you for inviting me today to speak. My name is Adelina Ramos. I'm a CNA at a nursing home in Greenville, Rhode Island. I am a proud immigrant to this country, have moved here from Cape Verde Islands of western coast of Africa when I was a teen. The past 2 years have been horrifying. That's the only way to describe it. On Mother's Day of 2020, I cared for 26 very ill patients, and there was only one other nurse and a CNA. The residents were bedridden and could not move, eat, or drink. They all require oxygen change every 15 minutes. I work in my facility in Alzheimer's unit, and my residents were confused and upset when no one was there to help them when they called for us. Because of short staffing, we had to make impossible choices about which residents had to be more urgent need. Do I go to the resident who's been sitting in a soiled bed for 3 hours, or do I go to the resident who has fallen, hurt themselves, and is screaming for help? Helpless doesn't begin to describe how that feels. On top of that, there wasn't enough PPE for staff. The PPE that we did have, management locked it up, and no one had the keys to the PPE. We had to wear the same masks. We didn't have the right size gloves, and we wear the same gowns for days at a time. We plead for more staff on each shift, but they said they couldn't find anyone. We plead for more PPE and more training so we could do our jobs correctly with the skill. Care for attention our residents deserved. Management looked the other way because they had no one to be accountable to. And so our residents and staff kept getting sick, and then people start dying. When I started doing this work, I knew I would have residents die. It's just part of the job. But I never thought I would be putting them in the body bags because there was no one else to do it. When the pandemic hit my facility in 2020, we lost over 20 residents between the end of April and Memorial Day. A CNA died too at that time. She was one of the first nursing home workers to die of COVID in Rhode Island. We're still critically short-staffed. My regular hours to work is 32 hours a week, but I end up doing around 74 hours a week. I keep trying to keep Wednesdays on my only day off, which is the reason why I'm able to be here today. Otherwise, I'm working double shifts. We became CNAs because we want to. We were born to care for others, but people who want to do this work can't do this work. It's too much. We're told our jobs are essential, but nursing home workers are treated as expendable. I wish I could tell you that things got better with the emergency fund that nursing homes got, but they didn't. All I can tell you is that it got worse. Where do all these emergency funds go? Where the accountability for nursing home owners? How was this allowed to happen? As a member of my union, I have the power to unite with my coworkers and call out bad actors. We can advocate for ourselves and our residents and shine the light on all the wrong in our care system, which COVID-19 exposed in the most tragic and deadly way, but we can only do so much. A national OSHA protection standard is desperately needed. The pandemic has shown that employers cannot be trusted to do the right thing. Too many nursing home workers find ways too many nursing home owners find ways to cheat the system or act as though following the rules is optional. They profit over people. A national protection standard would eliminate bad actors by holding them accountable to follow mandatory policies and procedures. This standard will make sure that nursing homes in all states, in all communities are well supported, well staffed, and are held to the same standard of care, especially Black and Brown communities that were hit hardest by COVID-19. CNAs like me across the country are working double shift 6 days a week. We're exhausted, but in that exhaustion comes wisdom. We know that what's happening in these facilities. We know why residents are dying. We know why our long-term care system is crumbling. It's because we live in this each and every day. It's time to listen to the nursing home workers. The standard is what we've been calling for. Thank you.
Thank you, Ms. Ramos, for your testimony. Does OSHA have questions for Ms. Ramos?
Your Honor, I think we were going to have the other SEIU speaker first and then do it as a panel.
Okay, that's certainly fine.
This is Amy Tryon. My understanding is that other SEIU speaker had a schedule issue and needs to be moved to after lunch. So perhaps we should ask questions now of Ms. Ramos, and so that she can sign off.
Okay, that sounds good, Amy. Ms. Ramos, thank you very, very much for your testimony. My first question is there anybody at your facility who is designated as a safety coordinator or responsible for COVID care? And how did that work in your facility?
We have infection control person in our facility, and she's the one that does all the protections for the infection controls and make sure we have like PPEs and tell us what's going on in the facility. But it's the communication, it's not as much to us, the employees. So we always have to ask questions. They don't come to us to give us like updates and questions. So since we are a union facility, we will always have a right, and we know that our rights it's to go and ask them questions and they have to give us an answer. If we don't get an answer from them, our organizers make sure that we get the answers that we need and the PPE that we need from our coordinators. But for them to just come up to us and tell us like what's going on, it's kind of like we have to put up a fight.
Thank you. And you talked a little bit about your training that you received and maybe some things that you didn't receive. Can you talk a little bit about what additional training you would have wanted or you do want that you didn't receive so far?
The training is and the past practices, the trainings that we did receive in our facilities, it's totally different than what we've been receiving. It was more hands-on on training that we did receive. We would have our infection control person do a specific training, like for example, if we have a flu coming, so it's before the flu season or during the flu season, she would have come up with a list of employees, and she would go over and said, oh, I haven't give you a training on this. So she would write your name down, and then she would call you on her office, and then there would be like probably like 5 or 6 of us, and she'll go over for 20 minutes how to use the proper PPE. And we have to do like a demonstration. If we're not doing it right, she would correct us. So, but lately, the past few years, it's been like we have to watch videos online. It's more like we have to read, and they'll tell us like, you know, this is the website that you guys have to do this, and you guys have to go on, log in, and read about it, and then we have to answer questions. And I mean, a lot of older people, they're not as techy as the younger generation. So, and a lot of employees feels like they don't know how to they don't do well with reading. They like to do training like hands-on, not as so much on the computer. And we told our employers that we should go back to that, but and they were saying they don't have time because they don't have enough staff to do it. So it's always like around the question. They would just tell us to go online and do it.
Thank you. And I just had one last question. When you're thinking about how things work in your facility and among the patients, how do you know who's got COVID? Are you the one doing the testing? Is information being communicated to you about which patients might have gotten COVID while you were off shift? And can you talk a little bit about how you know when you need to be wearing appropriate protective clothing or following specific infection control requirements?
So, for example, we just had a breakout like 2-3 weeks ago. A lot of us didn't know there was a breakout because they didn't inform us. So how we found out that there were employees that test positive, and it was because we went to work on that specific unit, and then we were told that we have to wear the correct PPE because our employee that was working on that specific unit test positive, and then they test the residents, and one of the residents was positive also. So, but not everyone was informed. Not everyone in the facility knew that that was going on. It's like, if you go work on that specific unit, you would find out. So, like I said before, so since like we're organized facility, we had to call our union and let them know what was going on. And that's the great thing about having union in your facility, because you have a voice and they will like make sure that things are done correctly. So we called our union organizer and we told our union organizer what was going on. And our union organizer called them and told them, you know, they can't do that. They have to let everybody know what was going on. And then from there, they sent a mass text to all the employees to let them know there was COVID in the facility, and then we have to wear the PPE when we work on that unit, and the rest of the unit, it would just be the procedure PPE that we have to wear.
Thank you. Amy, did you have any other questions?
Yes, sorry, just one moment. I just wanted to ask about who wears, sorry, I just wanted to ask about your own type of face covering that you wear, your own mask, and what everybody else wears on the rest of the unit.
So for our company, they have a specific procedure that if there's no breakout, we wear surgical mask and we wear goggles. But if there is a case of COVID, we have to wear N95 and we have to wear goggles on the units.
Okay, thank you. Have you ever brought in your own N95 to use voluntarily, or have you ever seen anybody do that?
I actually did it myself because that was before they start doing the fit and test.
Okay.
Because I was telling them that I was getting really bad anxiety when I wore specific mask. I wasn't like feeling well when I wear that specific mask. So I went on Amazon, I bought different type of masks, and I told them that's the mask I feel more comfortable with, and that's the mask I'm going to wear. So then when they did the fit and test for us, I wrote that I wasn't wearing the certain mask would make my anxiety go up. And so I was told, the mask that I feel comfortable with to wear. But at the time I told them they have to order those masks because that's the mask I feel more comfortable with. And I was told they couldn't order them. So I ordered them myself on Amazon. And then I told my organizer that I was couldn't wear the mask that they had, and I had to wear a different mask. And then my organizer reached out to them and said they should provide us with the mask that we feel comfortable with. And from that, they offer me to, like 3 days later, they gave me the mask.
Thank you for sharing that and for your testimony here. I don't have any more questions.
Your Honor, that concludes the questions from the OSHA panel.
Thank you very much. May I ask the contractor, do we have any questions in the chat box? Witness questions, raising hands, *3.
Oh, Alan, who has raised his hand, I can promote him to panelist.
Please do.
Theo, you are now able to unmute to ask your question.
So, Mr. Allen, this is Judge Henley. Please state your name, your affiliation, and let's start with a single question and see if we have any additional questioners.
Thank you, Your Honor. I'll give it now. Instead of giving it first thing Monday morning, my name's Theo Allen, TheoAllen. I don't represent a group, even though I'm affiliated with People's CDC World Health Network, which is presenting something founded COVID is airborne, and I'm the person who requested the hearing that we're holding today. But I'm going to follow up on some of the questions our solicitor asked. So, Ms. Ramos, thank you for your essential service. Did your employer discuss with you the rights that you have to voluntarily wear a respirator under the COVID emergency temporary standard?
That's a great question. Sure. I we didn't offer to wear a respirator. I don't know if that's the nursing home standards, or we were only offered to wear N95s.
What I was asking about was that about your ability, even on non-COVID units, to voluntarily wear a respirator. Did your employer discuss with you that?
No, not that I recall. I only recall that we are to wear either just regular PPE, the standard PPE, or if you have outbreak, we will wear the N95s.
Second question is, did your employer, even though I disagree with the gowns and gloves, did your employer require you to wear that for COVID patients?
So for gloves and gowns, if we were working with COVID patients, we are required to wear gowns and gloves and N95s, correct?
How often did you have to change your gowns and gloves? Or were you able to, did you change your gloves after every patient?
Is that when we had the outbreak on the 2020? Is that your question, or now?
It's, you can answer both during the outbreak and now, and it's a yes, no.
Okay. So during the outbreak back in 2020, we had to wear the same mask for weeks. And then if we work 16-hour shift, we wear the same mask for the whole entire day, and we wear the same gowns for the whole entire day. And then we wear the same mask and the same gowns for like weeks. After the end of our shift, we had to put our N95 in a paper bag and put our names on it and hang it up and with our gowns, and come back the next day and wear the same ones, which we found that wasn't the right way to do it, because when you have any type of infections, when we were showing in the past, when you have any type of infections, every time that you wear the PPE, you have to disposable them as soon as you're done with. And we told them that wasn't the proper way to wear the PPE. That's why more residents were getting sick, because we were in the same gowns, the same mask throughout the shift, and we're going rooms to rooms. And that's how we were getting sick too, because the virus was still on the gowns and the masks. But we did change our gloves patient to patients like we always do. That was the only thing that we changed constantly. But when it came to gowns and masks, we had to wear the same ones for like weeks. And
Thank you.
and as of right now, if you're working on the COVID unit and then all the residents are positive, you have to wear still, they want you to wear still the same gown and then the same mask. But if there's only one patient positive on that unit, that's only time that you wear the PPE for that specific room.
Thank you, Ms. Ramos. Allen, to stay
I was
on.
only going to ask about, I only have one.
Allen, hold up. Mr. Allen, stop, please. Let me finish my question. We need to stay on time, and we have additional questioners, so you can ask one more question of this panel.
I only actually have one more question, and then a quick one, which is, how do I submit my follow-up questions I didn't get to ask, for example, for past panelists to the record? And this is a yes, no for Ms. Ramos, which is, have you seen the videos of Project First Line being shown by your employer? Yeah, it's a simple yes or no.
I don't recall if I did or not.
Thank you. That's all I have. And the last one was just a procedural question for the judge.
Yeah, thank you, Mr. Allen. We're investigating whether we can take written questions. We'll have an answer before we conclude the hearing.
Thank you. That's it.
Will the contractor promote Mr. Glucksman?
He has been promoted.
Sir?
Yeah.
Please unmute. You have a camera option. There you go.
Thank you for the promotion. Hi, Ms. Ramos. My name is Dan Glucksman with the International Safety Equipment Association. And my question is, how did you, you said you found some respirators online. And my question was, how did you find them online? What were some of your evaluations? Like, how did you decide the respirator you chose would work for you? And I'm also wondering if others did the same, or did they start using the respirator that you then found and were able to use?
So because the one that we had only one kind at first at my job. So the kind that we had, I felt like my heart rate was pumping and my face was getting warm. I was feeling like my anxiety was like really awful with it. So I decided to buy different kinds on Amazon, all the N95s that it was available on Amazon, and whichever one that I feel like my breathing was more controllable and I was feeling more comfortable with. And that's how I tried the different ones that I felt like it was more comfortable for me.
Thanks. And did others do the same?
I'm not sure if others did the
Yeah.
same. I only know for myself.
All right. Thank you very much.
Thank you, Mr. Glucksman. Do we have additional questioners? Contractor,
I do
anybody?
not see any additional questioners at this time.
Okay, thank you very much. I think it's, thank you again, Ms. Ramos, for your testimony. We're going to break for lunch. The next panelist should be Ms. Frayne. Also, SEIU will start at 1 p.m. Till then, we're in recess. Welcome back, everybody. It's 1 o'clock. The contractor on?
We are.
And what about my court reporter?
Yes, sir, I'm here.
And the contract support is Leslie Frayne. Dial in.
Yes, Leslie Frayne is present and receiving an invitation to become panelists now.
Okay. So before we go back on the record, a couple housekeeping items. For those witnesses who were unable to ask your questions during the allotted Q&A time, you can submit your comments and questions to ets@dol.gov. These questions will be added to the hearing record, and those panelist testifiers can choose to reply in their post-hearing comments. I'll remind you of the email address throughout today, and I believe we're going to post the same information in the chat box. And for planning purposes, we'll try and take our next recess after the witness from the Argentum Senior Living Association. With that, we're back on the record. And if the contractor can promote Leslie Frayne, please, to be a panelist. Ms. Frayne, good afternoon. If you could please state your name and affiliation for the record before beginning your testimony.
Leslie Frayne, Executive Vice President of the Service Employees International Union.
Thank you. You may proceed.
Thank you so much for the opportunity to speak today. I'm pleased to be here today to speak on behalf of more than 1 million SEIU members who work in hospitals, nursing homes, clinics, and home and community-based settings, workers who've risked their lives throughout the pandemic to take care of others. All healthcare workers, regardless of the job they do, the color of their skin, or where they're from, have a fundamental right to be safe at work and to know that doing their jobs doesn't mean putting their loved ones in jeopardy when they come home after work. I join other labor leaders and experts in urging OSHA to adopt a permanent standard that holds employers accountable to properly address novel viruses in the workplace. We need a standard that offers vital protections, including adequate personal protective equipment, training on how to properly use it, time allowances for vaccination, and paid sick leave for those who test positive for COVID or must quarantine to mitigate the spread of the virus. I know that I don't have to tell you about the devastating physical and psychological toll that working people have endured throughout the pandemic. That devastation has been particularly profound for healthcare workers because of the hands-on nature of their work and because they care directly for people infected with the virus. An estimated 3,600 healthcare workers lost their lives to COVID-19 just in the first year of the pandemic. 2,000 of those deaths were nursing home workers. Nurses were also gravely affected, and healthcare support staff, who are lower paid relative to other healthcare professionals, suffered disproportionately. Strong unions have played an important role in making demands for basic safety and in holding employers accountable. But the gravity of the problem and the pervasiveness of this ever-changing virus demands a federal solution. We need a federal solution for workers like Francine Bailey. Francine is a certified nursing assistant who contracted COVID after working without proper PPE at a nursing home. Francine recovered, but not before passing the virus on to her mother who lived with her. Her mom didn't make it, and Francine lives now with the knowledge that but for her employer's failure to provide adequate PPE, her mom would likely still be with her today. And then there's Celia Marcos, a seasoned hospital charge nurse. Her hospital, run by a for-profit corporation, was especially short-staffed because of a surge in COVID cases. So Celia, with only a surgical mask on her face, was directed to single-handedly care for a patient in cardiac arrest on a floor that her supervisor incorrectly assured her was COVID-free. Celia died of COVID a short 2 weeks later. Not a day has gone by in the last 2 years that I haven't been moved by the stories of SEIU members like Celia and Francine, and the healthcare workers all across the country who continue to this day to rush toward the virus, not away from it. It's an outrage that the very pillars of courage and compassion we've depended on to take care of us are still too often left without basic workplace protections. I think we've learned a lot during the pandemic, but those learnings only underscore that we cannot and we must not leave it up to employers to consistently do the right thing. It's why workers like Arleta Moore are sounding the alarm and organizing to be respected, protected, and paid. Arleta works as an environmental services worker in a hospital. She's responsible for cleaning and disinfecting patient rooms, a critical job in preventing the spread of infection. I want to tell her story in particular, because even when higher paid employees working in the very same rooms with COVID patients got access to PPE, Arleta did not. It's hard to avoid concluding that protecting her and the other EVS workers, a workforce that is mostly Black, brown, and immigrant, was simply not her employer's priority. Thanks to union members banding together to demand proper PPE for all workers, regardless of job title, Arleta and her coworkers finally received N95 masks, gowns, and glasses. But it shouldn't have taken a fight, and it shouldn't have taken months for hospital management to do the right thing. The emergency standard was crucial because it forced employers to provide PPE and training on how to use it correctly. It served as a vital safeguard for workers who had no choice but to fend for themselves, sometimes resorting to wearing bandanas as respiratory protection or trash bags as gowns. But it's not just about PPE. I can't underscore enough how important the paid leave provisions in the ETS were for the financial security of workers who contracted the virus or had a close contact exposure and needed to quarantine. Having paid sick leave meant they were no longer forced to make the difficult choice between going to work sick and potentially infecting others and not getting paid at all. And this is especially true for part-time workers and low-wage workers like home care workers, who are the least likely to have access to paid time off. The emergency standard also supported workers to get vaccinated. It provided paid leave to recover from any side effects or travel time if vaccination wasn't provided on site. The ETS was a game changer for many healthcare workers. And when it lapsed, despite a significant surge in cases, many employers began rolling back protections for workers. In many work sites, we saw a swift return to pre-ETS conditions in terms of paid leave and respiratory protections, and a deepening of existing and glaring disparities, particularly in the treatment of low-wage positions predominantly held by Black and brown workers. This scaling back of protections increased risk in work sites where chronic short staffing has reached crisis levels. Now traumatized or fearing for their own health and safety, healthcare workers are reconsidering the jobs they love. In fact, nearly 1 in 5 healthcare workers have quit their positions since February 2020. Up to 30% are currently thinking about leaving. That percentage is especially high for nurses, and nursing homes are experiencing average turnover rates of around 100%. Simply put, without the protections mandated by the emergency temporary standard, healthcare workers cannot do their jobs safely, and hospital patients and nursing home residents will suffer. Before I close, I want to reiterate key provisions in the ETS that are as relevant today as they were when the temporary standard was released in February 2020. We urge OSHA to adopt the ETS as a permanent standard with safeguards for workers regardless of their vaccination status, including medical removal with pay, personal protective equipment, and exposure notifications, and continued employer supports for vaccination and booster shots. In my testimony, I've relayed stories that provide a brief snapshot of the lived experience of healthcare workers on the front line of pandemic. I know that earlier you heard from SEIU member Adelina Ramos, who told her story. And if you take one thing away from our combined testimony, I hope it will be her voice and her clarity about why we can't leave it up to employers to keep workers safe in the absence of a strong federal OSHA standard. I'm happy to answer any questions you may have. And I'm also joined by Liz Royal from the SEIU healthcare staff, who may be better equipped to answer more technical questions than I am.
Thank you, Ms. Frank. Mr. Levinson, do you have questions of this witness?
Yes, Your Honor, thank you. Thank you very much for your testimony, Ms. Frayne. So we have a couple of questions. Can you talk a little bit about PPE availability and how that changed in your observation, both before the ETS was in effect, when the ETS was in effect, and then after OSHA stopped enforcing the ETS?
Yeah, I mean, two things happened at the same time. Obviously, supply chain problems it lessened as the pandemic proceeded. So it is honestly a little hard to say how much was the ETS and how much was just the supply chain getting better and there being more availability. But we certainly saw a marked improvement in access to PPE. And I would say that's particularly true for the lower paid and less skilled job titles. Where to just recap the story of the Arleta Moore that I told earlier, far too often, even when the supply chain problems loosened up a little bit, employers said, okay, well, for nurses and respiratory therapists, I get it, but there was an incredible willingness to allow EVS workers, dietary workers, and sometimes even nurses' aides, despite how hands-on they are, to make do without PPE or lesser PPE, surgical masks versus N95 respirators, for example, and also just patterns of required reuse, where workers were told to store their mask in a paper bag and reuse it over and over again. And when the ETS was lifted, again, we don't have data on this, of course, it's all anecdotal, but the number of times that workers reported that, well, now they're saying a surgical mask is good enough again, even, or now they're saying we're going back to sort of having to fend for ourselves, as well as the many examples, and I believe that Adelina testified to this earlier, of where workers just had to provide their own, or in many cases, and I would say this is especially true among home care workers, where the union became their source of PPE because their employers were simply not providing it. And so we did the best that we could to try to deliver PPE to our members, but that is fundamentally not our role, and of course does nothing to protect the millions of healthcare workers who are not in unions.
Thank you. One of the other things that we're interested in is the experience of your members with respect to vaccination, and in particular, the new concept of up to date in addition to the initial vaccination series. And if you could talk a little bit about what's going on right now amongst your members in terms of, are vaccines being provided to people for whom they might be appropriate? Are boosters being provided? And do you notice a difference between workplaces that are covered by CMS, for example, hospitals, and maybe those that are not, for example, home care workers?
Yeah, vaccination, we've worked hard, often partnering with employers and with public health departments to do both vaccine education and to augment vaccine availability. Early on in the pandemic, or when vaccines first became available, I think we would say that availability was greatest in hospitals. Nursing homes were particularly problematic because the partnership with CVS and Walgreens was very rigid, and so nursing homes would provide the vaccines on site, but only at a particular time. And if you were a shift worker or worked 2 jobs or had childcare problems, that time might not work for you, and there was very little follow-up. And then I would say for home care workers, there was really very little effort. And this is true of both sort of independent provider home care workers who are paid directly by the Medicaid program, and also private agency workers. There was very little evidence of employers providing vaccination. And I think that as we explored and we did polls of our members, what were the reasons why people weren't getting vaccinated when they were not? It was a combination of frankly, some reluctance that was based on that we felt could have been overcome with a more robust education program in many, not all situations. Lack of access, particularly in nursing homes and home care. And then finally, I would say just fear of, even for folks who understood that they, in the long run, they were going to likely to be much healthier if they got the vaccine, just said, I can't afford to get it if I'm going to have to take a day off without pay. And again, true for all workers, but especially true for part-time workers who are even in work sites where they technically provide they technically provide paid time off, often do not to part-time workers, and home care workers who as a group are the least likely to have paid time off. So I would say over time, as access has become more broad-based, we hear less frequently from members saying, I didn't get vaccinated because I couldn't find a vaccine. People, I think for the most part, our members at this point have multiple ways where they can get a vaccine. It would be more convenient if it was at work, but the vaccines are broadly enough available that I think that that is less of an issue. But the fear of reactions and what that means for your health and your income remains an issue.
Thank you. And I have one more question before I turn it over to some other folks from OSHA. When you think about the experience of your members, as they work with their employers, are they finding that there is a designated safety coordinator for COVID care? Do they know who to go to when they have questions, issues, shortages of PPE or other supplies? And how do you see that working in the workplaces that your members are employed?
Well, I would say two things. One is that it is very hard to, it would be a mistake to paint employers with a broad brush, and that the variation between employers who really were role models in terms of sharing information and making it easy for people to access supplies. I want to sort of lift up that there were certainly employers who really did everything within their power, and others that did not. I would say, in addition, this is an area where I think the difference, and I think Adelina spoke a little bit to this earlier, the difference between union and non-union matters a lot, because in a unionized facility, whether or not an employer has been clear about this is who to go to, and this is how you get whatever it is you need, whether it is PPE, training on how to use PPE, or information about vaccines, or information about other infection control procedures. In a unionized facility, workers, if the employer doesn't make that information readily available, workers have the ability to go to their union steward or to their union organizer, or their union representative, and that is information that we have, I think, been quite vigilant in insisting that we have. And so I think that we have, in unionized facilities, between employers who were more responsible than others and the role of the union in sharing information, that has been better. But when it comes to things like awareness around and transparency around where there has been somebody has been diagnosed with COVID, and giving workers the information that they need in order to determine whether they need to quarantine or not, I think that has been one of the harder areas in terms of information flow.
Thank you. Brian Lincoln from OSHA, I believe you have a question.
Yes, hi, I'm another economist at OSHA. You alluded a little bit to questions about labor shortages in our current economy and in these sectors, and wondering if you wanted to expand a little on what you're seeing there, and ways you feel the ETS can help or hurt those situations. And as a follow-up already, certainly after the hearing, if you have any data you'd like to provide to us in the post-hearing comments, that'd be great. Thanks.
Thank you, and thank you for the invitation to provide data post-hearing. The members of our union have a slogan where they say that our demand is that our employers respect us, protect us, and pay us and staff us, because I think that those are the four factors that have really led to a current crisis in which workers are obviously leaving their jobs in large numbers. And the Respect Us is important because it speaks to a real deep-seated anger among healthcare workers who feel like they were asked to sacrifice and they did. And yet all of the rhetoric about cheering on essential workers was often ended up feeling very shallow, where it was just all talk and not much action. I think that on the protection front, workers' fear of they've seen coworkers die, they've seen residents die. They very often live in congregate settings, especially lower wage workers, where they live with people with elderly relatives, unimmunized little ones, or people with pre-existing health conditions that make them particularly vulnerable, and they just live with an incredible fear of bringing this thing home. And even if increasingly they feel some confidence that it might not be life-threatening for them, they know it could potentially be life-threatening for family members. And the fear is clearly driving people to rethink their employment options. And I think some of that is true within healthcare, where sometimes nursing home workers will say, I still want to take care of seniors and people with disabilities, but if maybe home care means less of an exposure than nursing homes. And so they're making choices within healthcare. And then in many cases, just saying healthcare itself is too risky, particularly as we've seen the ongoing reality that of frontline workers' ability to get higher paying work that is less stressful and less risky in other sectors completely. And then finally, I would say that the staffing crisis is sort of a perfect storm, because healthcare workers always work short-staffed. That's not a new issue. But at the very point when they needed more staff because of the acuity of patients and residents because of COVID, the staffing problem got worse. And that employers' response has far too often been to do sort of sign-on bonuses, which get people in the door, but certainly don't keep them there. And in many cases, make workers say, well, actually, that's a reason to leave because I could get a sign-on bonus somewhere else, and use of temporary agencies. So I think it is a perfect storm of those four conditions. And how much of the exodus is being driven specifically by safety, I think will be a challenge to quantify, if it's even possible to quantify. But I would certainly say, and again, this is anecdotal, but the reports that we hear from people who are changing jobs are this pervasive anger and fear is definitely a driving factor that is leaving people to leave, which is then exacerbating the staffing problem, which is then exacerbating the safety problem, and so on and so forth.
So with a permanent ETS standard where it's across the board that employers would have to fill those provisions, then at least that aspect of turnover would be obviated. Does that sound right?
I think that's right. And it's not, I mean, I don't want to overstate. It isn't like the ETS will end the staffing problem, because safety is only one of the considerations, but I would say it is certainly one of the top 2 or 3 in the reports that we hear from our members.
Okay, great. Thanks very much.
I think Amy Tryon, I think you have a question.
Yes, hi, good afternoon. I wanted to clarify or follow up with you a little bit on remaining obstacles to employees getting vaccinated. I think I understood you to say that availability of the vaccine isn't an issue anymore, but that I wanted you to clarify if you see any remaining role for OSHA in terms of ensuring or encouraging vaccine access. So could you clarify about that?
So I don't want to overstate. I think that in rural areas, there may still be some access problems. But I think that most of our members understand that if they want to get vaccinated, vaccines their availability is so much broader than it was when they were first made available, that I would say it is, I don't want to say never, but it is not that often that we hear from members saying, I don't know how to get vaccinated, or there isn't a place for me to get vaccinated. I do think that having boosters in particular available on site would increase the vaccination rates because frankly, for people who are on the fence about whether to get it or not, the difference between being able to get it at work and having to make a trip when you may not have transportation, when you may not have childcare is significant. So I think that requiring on-site access would increase utilization rates, especially for boosters, less because people don't have other ways of getting them, but just that the more that you lower the obstacles to getting them, the easier you make it, the more people will get vaccinated, and clearly that saves lives. I also think that there is much more to be done on the education front in order for, and particularly about the importance of boosters. And then finally, this question of, do you lose pay if you take time off to deal with the side effects of having gotten vaccinated? That's an area where the ETS made a huge difference. And again, it is most significant for people who lack paid time off. But frankly, even people who have paid sick time worry about using it on something that feels voluntary, like the side effects that you get from a vaccine, as opposed to saving it for what you may need it for if you have a serious illness or serious illness in your family. So I think that while again, I don't want to overstate, and there are other ways that you can get vaccines and boosters, making it available, requiring it to be available on site, anything that can be done to increase education, and this all-important question of paid time off, I think would be will make a huge difference in terms of driving up vaccination rates and especially boosters, which we are very worried about.
And do you think that the paid time off is a factor for, in terms of actually getting the vaccine, or just the side effects and any recovery from that?
Well, I think it's both. Obviously, if you get it on site, then it's time off to get the vaccine is less of an issue. But if you can't get it on site, and again, I point to home care workers who have never been able to get it on site, and then nursing home workers for whom access has been very sporadic. Hospitals, I think, a little bit better. But I think it's an issue for both where on-site access is not available.
Thank you. And just one more question. You mentioned that certain employers were withdrawing or decreasing protections after OSHA suspended enforcement of the ETS. And I was wondering if you could provide any more details about that, and if you happen to have any data sort of detailing the impact that you might be able to share with OSHA.
So I will confer with staff on that. I'm not sure that that data is available per se, available just because I'm not aware of it. Our information is largely anecdotal, but it is anecdotal with enough frequency of just the stories that surface in union meetings, the stories that when we've that members have told, that we feel clear that there has been a difference. And again, I would just underscore what I said before. We think that the difference, particularly on the PPE end, has been greatest at the lowest end of the salary structure, and has been greatest in the long-term care space. But I would also point to, and again, this is something we might need to work with after the hearing, but on basic things like the numbers of negative pressure rooms. That's another issue where we've definitely saw a change after the ETS was revoked or was expired.
Thank you very much. I don't have anything else.
Andy, I think you're muted.
Thank you. Your Honor, I was just saying thank you very much. OSHA doesn't have any more questions.
Thank you. Do I have any questions in the queue from the witnesses?
There is one hand raised at this time by Theo Allen, and I can promote them to panelist now.
So welcome back, Mr. Allen. Again, I'm going to advise you, given the time.
I have two questions, but I'm only going to ask
Mr. Allen, Mr. Allen, wait, hold on, please. Let me finish. Welcome back. Given the time constraints, I believe you're only going to ask one question, but I'm limiting you to one question. Any questions you can ask of this witness, you can submit in the email address that we provided in the chat box, and we'll endeavor to have the witness answer them as part of their post-hearing materials. So you are allowed to ask one question of this witness. Go ahead.
Thank you, Your Honor. I want to ask one question on the record and one question here, and this is just a clarification. Based on your written briefs, I read it as saying that you recommend mandatory sick time for only when the vaccines are mandated or the boosters are mandated. Is it the case that you would recommend it if it's just recommended vaccines and not mandated?
So I apologize.
Can I just get a verbal response?
I apologize if my comments were unclear. We want to encourage vaccination universally for all healthcare workers, whether it is in a mandated situation or not a mandated situation. And so whenever there is a recommendation for a vaccine, we want to remove all barriers to getting it, and lack of paid time off is certainly a barrier to getting it.
Thank you, Ms. Frayne, and again, Ms. Ramos, and the SEIU testimony this afternoon.
Thank you very much for having us.
Will the contractor bring up the panel from the American Hospital Association, please? Rosalind Schulman and Nancy Foster.
Rosalind and Nancy have both been promoted to the panelist group.
Good afternoon.
Good afternoon. If we can have you up, turn on your cameras if they're available.
There we go.
And who do I have the pleasure of addressing? Ms. Schulman, okay?
Yes. I'm Rosalind Schulman, Director of Policy.
Sorry, ma'am.
Pardon me?
We have a little disconnect here. Yes, ma'am, you may proceed. Please state your name and affiliation for the record.
I'm Rosalind Schulman, Director of Policy for the American Hospital Association. Today, I'm joined by my colleague, Nancy Foster, AHA's Vice President for Quality and Patient Safety Policy. On behalf of the AHA's nearly 5,000 member hospitals, health systems, and other healthcare organizations, and our clinical partners, including more than 270,000 affiliated physicians, 2 million nurses, and other caregivers, and the 43,000 healthcare leaders who belong to our professional membership groups, we appreciate the opportunity to share our views on OSHA's additional considerations regarding COVID-19 healthcare regulation. Our members represent the full range of healthcare facilities, from small and rural critical access hospitals to large health systems. They include teaching and non-teaching hospitals, acute care hospitals, inpatient rehabilitation, and behavioral health, among others. They provide a wide range of services, including inpatient, outpatient, emergency care, pediatrics, and cancer services. Today, Nancy and I will discuss the AHA's recommendations to OSHA on its COVID-19 healthcare regulation. We'll also share what hospitals and health systems across the country have done and continue to do to ensure the health and safety of their workforce during the pandemic, and how they use evidence-based CDC guidance and recommendations to do so. And finally, we'll address some of OSHA's more specific considerations and questions that were included in the March notice. So with that, if you could turn it over to my colleague, Nancy.
Thanks so much, Rosalind, and good afternoon, everyone. For more than 2 years, through multiple surges of COVID-19 and several distinct variants of the SARS-CoV-2 virus, healthcare workers across the country have saved lives and worked tirelessly and courageously to care for patients. Their crucial roles have never been more evident than during the course of this pandemic. And throughout it all, the safety and protection of all healthcare workers has been and continues to be a top focus for our member hospitals. In addition to the nurses, doctors, respiratory therapists, and other caregivers, our hospital and health system leaders, engineers, supply chain managers, and staff have been there, supporting care, seeking supplies of personal protective equipment, re-engineering ventilation systems, sharing updates on the latest clinical care guidance, arranging for staff vaccinations, and performing countless other tasks to support and protect staff. Through these diligent efforts, hospitals have worked hard to ensure all members of their teams are as safe as possible and that the latest evidence-based practices and policies are followed. What we have learned from this public health crisis is that clear and consistent communication about what will protect staff, patients, and communities is essential and may change as we learn more about each new version of the virus, as we test new products and strategies, and as we introduce new approaches to treatment. Hospitals and their staff need clarity from the federal agencies in identifying what actions must be taken to protect against transmission of COVID-19. They also need rapid changes in those instructions as the new science emerges. Having competing federal regulations diminishes that clarity, and the slow and deliberate speed at which regulations change makes it impossible to incorporate the rapidly emerging scientific evidence. That's why AHA strongly supports the continued reliance on CDC's guidance as we deal with the evolving pandemic. While we appreciate OSHA's consideration of potential flexibility and other changes to the COVID-19 healthcare rule, we continue to oppose the establishment of new regulations that are not fully aligned with the CDC's evolving evidence-based guidance. CDC guidance and recommendations have long been the national standard for safe operations and infection control, and have been utilized by healthcare providers since the beginning of the public health emergency. Hospitals and health systems are held to those standards already by CMS regulators. Even when the COVID-19 vaccines first became available, even before they first became available, hospitals were actively engaged in efforts to ensure their staff would be among the first in line to be eligible for a vaccination. And hospitals continue to make COVID vaccines readily available to staff. These vaccines remain the most important step in keeping people safe from the most serious hazards of COVID. Hospitals and other healthcare settings are subject to COVID-19 vaccination mandate that is strictly enforced by CMS. This mandate applies to all eligible staff working at a facility that is participating in Medicare or Medicaid, regardless of the clinical responsibility of that individual. It also includes staff who are in off-site locations in which they interact with patients. OSHA itself has acknowledged that the agency has sufficient existing authority to help protect healthcare employees from the hazards of COVID-19. OSHA maintains and vigorously enforces its general duty clause and other general standards, including the personal protective equipment and respiratory protection standards. In June of 2021, OSHA established a national emphasis program. That program provides for targeted enforcement action and compliance assistance in hospitals and other high-risk settings. Most recently, OSHA announced a short-term increase in its focused inspections directed at hospitals and skilled nursing facilities that treat or handle COVID patients. As evidence of hospitals' commitment to protecting their workers, let me share with you some of the steps hospitals have taken to ensure that staff safety is paramount while caring for COVID and non-COVID patients. And these are in addition to the vaccination efforts I've already mentioned. Hospitals and health systems have provided training for staff on COVID-19, on the COVID vaccines, and on infection control practices that are particularly important in preventing the transmission of COVID. Hospitals and health systems have provided call lines and other mechanisms for staff to get their questions answered. Hospitals and health systems have improved their air filtration systems. Hospitals and health systems, in one of the hardest decisions made during COVID, instituted restrictive visitor policies. These policies were emotionally difficult for all involved, including patients, families, and staff. But it was necessary to institute these policies to protect the workforce and to prevent transmission from hospital to community. Hospitals and health systems enacted inpatient bed management and staffing policies. These included stopping elective procedures, isolating and quarantining ill staff, and literally inventing ways to dramatically increase bed capacity to enable the cohorting of COVID patients and limit exposure for those working in other patient care areas. One system reported to us that they increased their capacity by nearly 350%. Hospitals and health systems undertook incredible efforts to acquire N95s and other PPE that was in scarce supply, including in some cases chartering planes to retrieve PPE that was hung up in shipping delays, or working with local firms to produce PPE. And before we had access to the over-the-counter COVID tests that are so readily available now, hospitals and health systems worked to get their laboratories authorized and to obtain the supplies that were necessary so that they could test for COVID. Running these tests in their own labs allowed much faster identification of who was COVID positive and was essential to protecting the staff. It also allowed hospitals to make testing available for staff so that they could feel safer about their own health and about interacting with their families. Between the CDC guidance and recommendations, the CMS vaccination requirement, and the existing OSHA general standards, we strongly believe that an inconsistent OSHA COVID-19 healthcare standard would be counterproductive. It would cause confusion and will ultimately lower hospital employees' morale and worsen the unprecedented personnel shortage we are currently experiencing. As such, we urge OSHA not to finalize this interim final rule. However, if OSHA does proceed with this rule, we have some additional comments for you. I'll turn to my colleague Rosalind, who will describe our views on the issues that OSHA specifically asked in its notice. Roz?
Thanks, Nancy. So before I begin with our specific responses to the issues in the notice, I'd like to say that what I'll be discussing is based only on the very limited information that was included in the notice. Since the notice didn't include any proposed regulatory language for any potential changes or any related regulatory impact analysis, our comments can only be limited in scope, and they do lack the thorough review and comment that any new regulatory provision deserves. With that, let me start with regard to OSHA's potential change related to the alignment with CDC recommendations for healthcare infection control practices. While the AHA fully supports the use of CDC guidelines in all matters related to infection prevention and control, we are concerned that a final rule that adopts by reference specific versions of CDC's guidance will inevitably result in OSHA's standard becoming increasingly more outdated as the scientific understanding of COVID-19 grows and recommended healthcare infection and control practices evolve. Therefore, as stated in our original ETS comment letter, the AHA continues to recommend that OSHA incorporate by reference relevant CDC guidance and other standards by linking directly to the live online documents. Embedding static versions of CDC's guidance into the ETS will lead to disparate standards that will confuse healthcare employers and their employees and could result in excessive burden and potentially harm. The CDC is in the best position to determine how healthcare providers should evolve their practices to mitigate the spread of the virus. Further, whenever CDC substantially updates its guidance, we would recommend that OSHA clearly state when compliance with the change would be required. With regard to OSHA's consideration of additional flexibility for employers through more broadly stated requirements and a safe harbor enforcement policy based on relevant CDC guidance, in general, the AHA supports this approach. The ETS included many requirements that were overly specific and complex and inconsistent with CDC guidance, leading to confusion and wasted efforts. In particular, we recommend that barrier requirements should be greatly scaled back or removed. As for ventilation requirements, we recommend the OSHA reference that OSHA reference the current ventilation consensus standards that are adopted by CMS, and that's the ASHE/ASHRAE Standard 170. We also agree that the other provisions of the ETS mentioned in the notice should be less specific, such as the criteria for medical removal and return to work, cleaning and aerosol generating procedures, etc. Instead, we suggest OSHA refer directly to the applicable CDC guidance that discusses these considerations. Further, if a safe harbor enforcement policy is instituted, it is critical that OSHA's area offices and the compliance, safety, and health officers are thoroughly trained on the evolution of CDC's guidance and recommendations over time so that they can apply the safe harbor policy appropriately. Moving on, OSHA discusses possibly tailoring controls to address interactions with people with suspected or confirmed COVID-19, which could include eliminating certain requirements that were included in the healthcare ETS that applied broadly across all areas of covered healthcare settings. We will again note that CDC already addresses such considerations in its COVID-19 guidance. If OSHA were to incorporate the relevant COVID-19 healthcare guidance by directly referencing live documents, then such tailoring of controls as envisioned by OSHA would be unnecessary. However, in the absence of such specific reference to CDC's live guidance, the AHA would not support this approach as it would further drive a wedge between OSHA's rule and CDC's evidence-based guidance. On another topic, OSHA is asking for comment on how its final rule should take into account the changing vaccination requirements, particularly as it relates to recommended booster doses and being up to date. The AHA recommends that OSHA's definition of fully vaccinated be consistent with CMS's definition, which is currently defined as having completed the primary series of vaccines. But given that being up to date with recommended booster shots has been shown to provide greater protection, AHA also recommends that OSHA's rule include additional flexibilities to healthcare workers who are up to date on their vaccines, as is already reflected in CDC's guidance. On another topic, OSHA is considering relaxing or eliminating certain ETS requirements based on the vaccination status of the individual worker involved or of the vaccination rate of the entire staff. Again, AHA urges OSHA to adopt the CDC's evidence-based guidance and its recommended routine infection prevention and control practices for the COVID-19 pandemic. CDC factors into its recommendations the vaccination status of healthcare personnel based on scientific evidence of a lower risk of illness, hospitalization, and death for these individuals. For example, several of CDC's recommended infection prevention and control measures, such as the use of source control and physical distancing, as well as screening tests, are influenced by both the level of SARS-CoV-2 transmission in the community, as well as the individual's vaccination status. OSHA regulations that are inconsistent with CDC's recommendations would be confusing and counterproductive, again, in healthcare settings. Moving on, OSHA is considering covering construction industry workers in the final rules provisions. It is important that OSHA understand that hospitals, and particularly large hospitals and health systems, have hundreds of different kinds of contracts for a wide variety of services. This makes it hard to respond thoughtfully to the notion of including contract employees, including construction industry employees, because their jobs, their risk exposure, and the opportunity for the hospital or health system to prevent infection are not the same. For example, contract nursing or physician staff may have similar risk profiles to other nurses and doctors who are employed by the hospital. However, contractors providing periodic elevator maintenance services or reconstructing areas of the facility have very different risk profiles. Also, hospitals have run into barriers in trying to track the vaccination status of contract staff, including construction industry contractors. There are particular struggles for those located in rural areas who have encountered resistance from some contractors in obtaining information on the vaccine status of contract employees, or in following the hospital's policies and procedures related to screening or masking. Our rural members have expressed concern about their ability to retain construction contracts for much needed facility renovation in these kinds of cases. So the AHA encourages OSHA to address any policies related to construction or other contractors with a clear understanding of these differences in risk and a realistic view of what such requirements would mean for the contractors, many of which are national or regional in scope and serve a wide variety of hospitals. OSHA is also considering linking regulatory requirements to measures of local risk. The AHA would support OSHA's deferring to CDC's guidance for healthcare settings, which already incorporates community transmission levels in its recommendations. By contrast, we note that CDC's COVID-19 community levels recommendations do not apply in healthcare settings and should not be used by OSHA. And then finally, with regard to OSHA's question about the evolution of SARS-CoV-2 into a second novel strain, the AHA opposes applying OSHA's COVID-19 healthcare standard to new strains of the virus that cause COVID. It would not be appropriate for OSHA to make assumptions about how an unknown strain of the virus would spread in healthcare settings and the steps needed to mitigate its spread. Thank you for the opportunity to present our views, and we would be happy to answer questions.
Thank you, Mr. Levinson. Thank you, Ms. Cjolin. Mr. Levinson.
Thank you, Your Honor. Thank you, Ms. Cjolin and Ms. Foster, for your testimony. We have a couple of questions. To start, can you talk a little bit about how your members are addressing screening and identification of suspected or confirmed cases of COVID among patients who are entering their facilities, and how they are separating suspected and confirmed COVID patients from other parts of the facility that are not set up to treat COVID? And then do you have any data to support the efficacy of the system to correctly identify suspected and confirmed cases?
Maybe I'll start and see if Nancy has any other responses. Well, as I mentioned, our members follow CDC guidance in terms of screening procedures for patients, visitors, et cetera. And so it's our understanding that they, as required by CDC, they do provide that kind of screening to visitors coming in or to patients as they are being admitted to the hospital. Many hospitals test patients that are coming in for COVID as a prerequisite to admission. As far as how they separate COVID and non-COVID patients, I think we have some pretty good examples that maybe Nancy can provide, but my understanding is that many hospitals cohort patients based on their COVID-19 infection status. And some hospitals indeed have reopened old facilities or opened up offsite locations as units that handle COVID-19 patients, or on the other hand, or handle COVID patients who do not have COVID. So there is a cohorting by potentially by unit, by floor, or in some cases, particularly during the large surges, in completely different facilities.
Just to add to Roz's comments, thank you so much, and thanks for the question, Mr. Levinson. Hospitals, particularly during large surges, were very engaged in the active cohorting and expanding their capacity to care for COVID patients in separate wards and so forth, or separate buildings when necessary. Now that we've seen a diminution of the number of hospitalized patients, thankfully, with COVID, certainly we are testing anyone who is symptomatic. We are asking those or giving those individuals, those patients who are coming in for an elective procedure, an at-home test so that they can do their own testing prior to coming in, and then asking them to provide the results to us. Or in some cases, we're doing it on our own. The emergent cases are a little more problematic. You can't actually ask them to do their own test in advance. So there we rely on the symptom checker, or if they know if they have been exposed. Oftentimes we are testing them if there's any chance they've been exposed. and then individuals who we believe not to have been exposed and not to be under consideration of having COVID likely would not be tested unless they began to show symptoms while in the hospital.
Thank you. With respect to employees, are you requiring employees to report any and all symptoms for COVID, including non-specific things like runny noses, headaches, diarrhea, etc.? And then are you requiring employees to notify you if they are asymptomatic but test positive for COVID, for example, on a home test kit?
Roz, if I could get started on that one, if you're all right with that. And thank you for that question. We are certainly requiring everybody who tests positive to report that information to their usually to the unit manager, who then reports it up to HR, or to whatever is the designated place within the hospital to receive that information. In addition to that, we are asking people to stay home if they are symptomatic, and yes, to do an at-home test. But we are not, because we don't want them coming into the site, we generally are not testing them on site, if that makes sense.
Let me ask, among your members, how common is it due to staffing shortages to allow people who are asymptomatic but perhaps positive to work and or exposed and waiting for, people who would otherwise be quarantined rather, to work due to staffing shortages?
I will say, and Nancy, add to this if you like, but I would say that consistent with CDC guidelines around contingency and crisis workforce shortages, that only in the most extreme circumstances of workforce shortages during a surge, I think would that be a strategy that would be used? I don't think we have data to quantify how often that is the case, but again, consistent with CDC guidelines, if there is extreme shortage and the surge in patients, then providing protective measures to the extent that you can for somebody who may be experiencing symptoms and bringing them in is possible in order to care for the patients, which of course is what hospitals do. Is our primary objective is ensuring that patients are cared for.
If I could only add one thought to Rosalind's comments, I would say our hospitals that anecdotally have said to us they have brought people back in during a surge have done so with a lot of thought. They have put those individuals in areas where the patients are COVID positive or have otherwise put them in an isolated work situation so that they can contribute to the work that needs to be done, but are not in a position to expose other patients, certainly, and they are wearing N95s or higher grade respirators to do source control in order to protect people as well as possible.
Thank you. I think Joe Coble, I believe you're ready with some questions.
Yes, good afternoon. My name is Joe Coble. I'm an industrial hygienist with OSHA. And I wanted to just focus a little bit on your comment regarding improving ventilation in hospitals. You said as part of your overall program, you've maybe re-engineered some, and specifically mentioned ASHRAE 170. And what you see is the advantages or potential disadvantages of complying with ASHRAE 170 as a indication of adequate ventilation.
Thank you for that question. While the current state of ventilation in hospitals is, there are many hospitals have adopted some of the components of the ASHRAE 170. However, I'm certainly not an expert in hospital engineering, and much of what I'm going to say comes from our engineering personal membership group. But and we would be happy to supplement whatever I'm going to indicate, which comes from our comment letter, for the record. But for now, I'll just reiterate what we said in our comment letter, and that is that that OSHA require that facilities install new or upgrading that OSHA require that facilities that are installing new or upgrading existing air handling systems follow the latest edition of CMS's adopted standard for healthcare ventilation, which is that ASHRAE standard 170. Regarding existing systems, the AHA recommends that OSHA require existing facilities evaluate their air handling systems as they currently exist to determine if improvements can be made to the filtration. And this evaluation should include verification of the system design, verification of the system's current operating capability, and if filtration can be updated to a minimum of MERV 13 rated filters without affecting the system's other performance requirements. And further, as you know, ventilation is one of a myriad of practices that are used within hospitals to reduce the risk of health care acquired infections. And so, you know, all of this is supported, of course, with the use of PPE, administrative controls, and isolation of infectious patients, to mention a few. According to our engineering group, which is ASHE, the American Society for Healthcare Engineering, applying the current design standards to all existing hospitals would have a negative effect on the ability of these facilities to properly apply all aspects of infection prevention and control, and therefore could impact the ability of hospitals to provide appropriate protections to staff, patients, and visitors. I'll also note, though, that ASHRAE and ASHE together are developing an operational guidance for healthcare ventilation systems, which when completed could be a better consideration for OSHA's reference. And we're happy to refer you to those individuals who are working on this.
Oh, yes, thank you. And just to follow up, you mentioned that hospitals are covered by CMS, which incorporates CDC guidance based partially on ASHRAE 170. But how much of your membership is not CMS? And in particular, say, ambulatory care facilities, do they make up any, you know, what percentage of your membership, or do you cover those? Are they part of AIHA? And are you aware of what improvements they may have been making to ventilation?
Ambulatory, if I may take that one, Roz, thanks for that question. Ambulatory care facilities that are owned or operated by the hospital or health system are part of CMS, are governed under the same Medicare rules that apply to the hospital, and are inspected either by CMS or one of its designated or deemed accrediting bodies. So they are fully covered.
And are there any members that would say be like a patient first, or what we sometimes think of as an ambulatory care that would not be directly associated with a hospital? Do you have members like that?
We do not have members that are ambulatory care standalone facilities. In other words, they are owned or operated by a hospital or health system.
Okay.
Ms. Foster, maybe if I could put a finer point on this. Are any of those facilities that are owned or operated by the hospital system located in a facility that's not completely controlled by the hospital? So for example, they're in a medical arts office building where there's a ventilation system for the building, but it's not owned by the hospital system, and they just have a clinic or some other ambulatory care facility in that building. And that's what we're interested in. What are the practices there among your members for ventilation?
Thank you, Mr. Levinson. That does provide additional clarity. There are certainly physician offices or sometimes clinics located in buildings that are owned or operated by some other organization, but in order to comply with the CMS standards, our facility would have to work with that building owner in order to ensure that they were essentially up to code for compliance with the CMS conditions of participation. Now, I can get more information for you if you would like on specifically how that happens. I've never been through that part of the survey myself. Sorry.
Thank you. Yes, if there's any additional information on, are they following ASHRAE 170 in these other facilities, that would be very helpful for us to have. At this time, Brian Lincoln.
Can I ask just one more question? I'm switching gears a little bit just because you were mentioned that barriers were not viable in hospitals. I was wondering how many barriers have been set up in hospitals, and where do you think barriers actually could be a benefit? And what are the issues with with why you're objecting to the barriers?
Thank you for that question. That is an issue that we addressed in our original ETS comments. I will say that what we have heard and what we have gotten through some research is that barriers just don't work, and in fact might cause bigger problems with regard to ventilation and airflow, because they interrupt the airflow that is set up through the ventilation systems that our engineers put in place. Furthermore, humans have a tendency to go around barriers, and so putting up a polypropylene barrier with a little opening so you can pass things through, or if you need to talk to somebody, particularly if you're wearing masks, pulling your head around the barrier defeats the purpose of it. And so we just think, and there has been evidence showing that barriers, there are some studies that we cited in our ETS and I'm comment letter that I'm happy to share with you that demonstrated that that they could actually pose a hazard in terms of interfering with airflow in healthcare facilities. I'm trying to remember the rest of your question there.
At what point what about, say, barriers at reception desks or where they're dealing with the public? I mean, would you object to that type of barrier as well?
I think that barriers are used in appropriate settings where they may be useful in settings in which other protections, like a fully vaccinated staff or a source control, and where physical distancing can't be maintained. And so in those circumstances, just like you see in a bank or in other locations, they might be appropriate, for, if for nothing else, for splash protection. But in general, we believe that hospitals should have the ability to assess the situation, the risk of every situation within their facility, to determine whether physical distancing can be maintained in some other way, or other protections exist to protect both the employees as well as the visitors or patients.
Okay, thank you very much. Your perspective is valuable on that.
Thank you. I think Brian Lincoln from OSHA has questions next.
Yes, hi. I just had a couple of their requests, but certainly you can comment as well. And they're just requests. It's always a question of what's available. One place we'd be curious about finding more information is about standalone ambulatory care centers with hospitals, standalone in the sense that it would fit the exemptions that we have. You're obviously one place that might know about that. You did mention, outpatient obviously is one thing that happens in your hospital. So that would be one place we, one part of the data we need to find that would be good to look at. I guess I could just list them and then you could, whatever you wish to say. The second one, there's three. The second one is we have found a couple of observational studies that look at the actual flow, how many visitors are coming in the doors to hospitals. Obviously a very tricky thing, and I don't think there are many hospitals that track that. But any other studies that you know about, if there's any internal data that you guys have on that, that would definitely be useful. And then the third is just a general, you guys do the wonderful hospital statistics here. Any updated data that could be useful for us if, if it's possible to give it to us in the post-comment hearings, that would be great. Those were my questions. Thanks.
Thank you so much for the question. Yeah, we're going to have to get back to you on that. We will ask the right people here at AHA, including our data folks and the folks that work on our annual survey, and get back to you with some information. It would be helpful if you could, with that last, the general updates, if you could be a little more specific, maybe through an email or so I can communicate the right information.
Okay.
And if I might add on the first question too, is there a specific issue beyond the ventilation that you were curious about on the ambulatory surgery centers? It'd be great to know what that is, because in terms of personnel policies, mask wearing and so forth, health systems and hospitals like standardization throughout. So there would not be unique policies.
Sure. So as the economist, I'm just more curious about counting how many people are in those places. It's more a question.
Got it.
Maybe others here that want to know other things, but for our limited purposes, it's just about that.
Thank you very much for the clarity.
Just to clarify further, did you want data on ambulatory care sites or ambulatory surgical centers?
And you may want to, but in general, it's going to be ambulatory sites that there's these exemptions, and we wanted to get a better handle on.
So broader. Gotcha.
Yeah.
Mr. Levinson, I think we're running out of time for the portion.
Yes, Your Honor, that concluded our questions. Thank you.
All right, thank you very much. And certainly, Ms. Cjolin, Ms. Foster, if you have questions about the scope of the OSHA's request, you can certainly submit the question to Mr. Levinson or the ETA at dol.gov, and we'll follow up with that. Thank you very much for your testimony this afternoon. Unfortunately, given the time constraints, we don't have the opportunity to ask questions from the witnesses. However, we've asked witnesses who have questions of this panel, please submit them to the chat box, email ets@dol.gov, and we'll provide them to this panel for consideration in responding to their post-hearing comments. Again, thank you for your testimony, Ms. Cjolin and Ms. Foster.
Thank you.
Thank you, Your
Honor. The next panel will be a combined panel from the American Healthcare Association, National Center for Assisted Living, Sean Bethea, and the Pennsylvania Healthcare Association, Zach Schamberg. If you can promote them, the panelists, please. Good afternoon. If you could please first identify yourself and your affiliation, and then we'll proceed with your testimony.
Absolutely. LaShawn Bethea with the American Healthcare Association and National Center for Assisted Living.
And Mr.
Good afternoon. I'm Zach Schamberg. I am the president and CEO of the Pennsylvania Healthcare Association.
Thank you. Ms. Bethea, I believe you're first.
Absolutely. Thank you. Good afternoon. Thank you for giving me this opportunity to speak today. Again, my name is LaShawn Bethea, and I am the executive director for the National Center for Assisted Living, also known as NCAL. NCAL is a part of the American Healthcare Association and represents more than 14,500 nonprofit and proprietary skilled nursing facilities, assisted living communities, subacute centers, and homes for individuals with intellectual and developmental disabilities. Our mission is to improve lives while delivering solutions for quality care. Over the past 2 years, we have dedicated ourselves to helping providers navigate the intense challenges presented by COVID-19 while sharing feedback and offering practical but effective solutions to state and federal agencies. ACA and NCAL wants to thank OSHA for hosting this hearing and seeking comments to the elements of a permanent standard. We also want to recognize OSHA for the support that they have and continue to provide to employers. The June Emergency Temporary Standard, when it was released, was accompanied by many comprehensive and clear resources aimed at helping employers adopt the standards. This was extremely helpful to employers across the board. And while we wholeheartedly thank OSHA for prioritizing this type of support to employers, I am a registered nurse and an attorney. And while I have worked in other settings such as the emergency room and acute care behavioral health, I have over 25 years of experience in long-term care, beginning my journey as a licensed practical nurse in a skilled nursing facility. I have held many roles in long-term care, from direct care nurse and unit manager to staff development coordinator and assessment coordinator. Most recently, I served as the Diversity, Equity, and Inclusion Committee Chair and Vice President of Legislative Affairs for Genesis Healthcare. In this role, I had an opportunity to meet with many long-term care nurses, certified nursing assistants, caregivers, and other long-term care workers to talk about the impact of the pandemic and vaccines, and saw firsthand the challenges created by rapidly changing state and federal standards. AFLCIO deeply appreciates the importance of protecting staff in skilled nursing, assisted living communities, and other long-term care settings. From the beginning, long-term care has been at the forefront of this pandemic. We experienced high-profile outbreaks, severe shortages of personal protective equipment, lack of testing, and supplies. And despite all of this, long-term care staff showed up and put themselves at risk to care for the most vulnerable population. Our residents call these settings their homes, and fellow residents and staff are family alike. The staff that has dedicated their lives to caring for them are truly our heroes. Since the beginning of the pandemic, long-term care employers have had to adapt to rapidly evolving guidance or regulation from multiple sources, including the Centers for Disease Prevention and Control, the Centers for Medicare and Medicaid, which regulates nursing homes, OSHA, and various state agencies. Often this guidance or regulation is duplicative. For example, employers must report COVID-19 cases and deaths to both federal and state agencies, as well as OSHA. In addition, these agencies have introduced their own infection control regulation or guidance, which at times conflicts. This has been a significant source of burden for employees and employers who make good faith efforts to comply with overlapping and at times inconsistent guidance or regulation as they work to protect the health and safety of employees. Healthcare providers must follow the most up-to-date infection control practices that reflect the nuances of their setting to provide the best care for their residents and patients and to protect their staff from outbreaks. Consistency amongst all regulatory agencies is critical for optimizing compliance and mitigating confusion, particularly for those employees and employers that are subject to comply with regulation promulgated by multiple agencies. There were conflicts between the OSHA's June ETS and the CDC guidance in areas such as PPE use, cleaning measures, requirements for aerosol generating procedures, and exemptions for vaccinated employees. We pointed out several of these examples in our initial comments on the June ETS, such as on the guidance for changing source control masks or exemptions for vaccinated workers. Since we submitted those comments, CDC has made several important changes to their infection control guidance for long-term care, and CMS has also made changes and new regulation related to COVID-19 practices. These guidance and regulation are all intended to reduce infections, outbreaks, and the spread of COVID-19 in long-term care settings, which ensures the safety of staff and residents alike. For OSHA to introduce their own infection control standards will inevitably lead to variations that are not only confusing for providers, but more importantly lead to inconsistent or inappropriate application of the infection control practices and detract from meeting the intent and purpose of these standards, which is to protect the health and safety of employees. In addition, OSHA intends for this standard to cover a broad range of healthcare settings, including both acute and post-acute care providers, while in contrast, the CDC infection control guidance may differ based on the setting. For staff, seeing and hearing conflicting and changing guidance between federal agencies erodes their trust. For example, staff may not understand why one federal or state agency requires certain PPE in a specific setting while another does not. This is particularly true when an employee works in multiple healthcare settings. And often the rationale for the difference is not clearly stated, so employers may struggle to explain the reasoning as they may not understand it themselves. This causes staff to distrust the guidance coming from federal or state agencies and more broadly erode their confidence in the importance of infection control practices. This is even more challenging for facilities actively combating vaccine and booster resistance. It also causes staff to become frustrated, burnt out, or discontent, which may have a negative impact on the well-documented staffing shortage across the country, which is particularly critical in post-acute care. And our profession cannot afford to lose additional staff. This is why ACA and NCAL strongly supports OSHA's suggestion to create a safe harbor clause where providers following a standard set by another agency, such as the CDC or CMS, would be protected from any enforcement action by OSHA. This would allow providers to focus their efforts on following a consistent source of guidance and demonstrate continuity in guidance to their staff. AFA NCAL also supports the idea of tailoring the standard to the amount of COVID present in the community and or the vaccination status of the individual. The CDC has already adopted standards that tie infection control practices to the transmission rates in the community. We commonly hear from providers that their staff are fatigued and frustrated by the burdensome COVID-19 infection control standards, such as the use of masks when COVID-19 rates are extremely low in the community. In areas where mask mandates have already been dropped, staff often ask why some healthcare providers must follow higher standards than other healthcare settings, such as doctors' offices. While ACA NCAL understands the importance of protecting staff and residents alike from COVID-19 infection, we also see how high-risk prevention approach can have a detrimental impact on staff wellness. Similarly, the requirement of physical distancing and physical barriers that were included in the June ETS detract from the home-like environment that providers strive to create, which is also supported by the CMS regulation and the CMS HCBS final rule, which includes assisted living. Thus, adding physical barriers or requiring distancing in common areas detracts from their quality of life. It is well documented that while infection control measures such as masks and physical distancing and barriers were very necessary to prevent hospitalizations and deaths among the elderly, they also took a great toll on their health, happiness, and well-being. We must find a way to minimize risk for severe illness, death, and outbreaks while still protecting the staff and preserving residents' quality of life. Finally, ACA NCAL expresses concern over the promulgation of this standard along with the airborne infection standard. While we are not privy to the provisions that will be included in the airborne infection standard, we have concern over creating two separate standards aimed at reducing the spread of infectious diseases. We would encourage OSHA to develop one infectious disease standard that covers COVID-19 and other infectious diseases. This will allow providers to focus their efforts on understanding one standard rather than multiple, increasing their ability to adhere to the standard and effectively protect staff and residents alike. Again, we express our deep gratitude for OSHA for their tireless efforts to protect our staff in our healthcare facilities and for hosting this hearing to seek input from providers and staff alike. I am happy to answer any questions.
Thank you, Ms. Buffet. I think we'll hold questions until after we hear from Mr. Schamberg. Okay, Mr. Schamberg.
Thank you, Your Honor. Good afternoon, everyone. Thank you for the opportunity to testify today. My name is Zach Schamberg, and I'm the president and CEO of the Pennsylvania Healthcare Association, better known simply as PHCA. We are a state affiliate of the American Healthcare Association and National Center for Assisted Living. PHCA represents long-term care in Pennsylvania. That's nursing homes, personal care homes, and assisted living communities. We represent the providers, we represent the workers, and most importantly, we represent the vulnerable residents they serve. And it's been our honor to represent those on the front lines of the COVID-19 pandemic for the past 2 years. After all, long-term care has truly been the epicenter of all that's taken place. Today, I'm proud to speak on behalf of the more than 450 facilities and communities in our membership. And I'm also very proud to be one of the only state associations to testify throughout the next few days. This was truly too important and too consequential for the day-to-day operations of our membership to just watch from the sidelines here in Harrisburg. We wanted to ensure that we and they, our members, were heard. And like LaShawn, I want to extend my gratitude to OSHA for holding these hearings and for allowing Pennsylvania's perspective to be shared. It's interesting because from day one of the COVID-19 pandemic, one of the most important resources that we fought for here in Pennsylvania, aside from PPE, testing, emergency funding, and the COVID-19 vaccine itself, was a seat at the table, or just a chance to share our expertise to create a better final product for our residents and our workers. And you're giving us that opportunity today. Certainly throughout the past 2 years, the health and safety of our workers and residents has remained the priority in long-term care. And I believe we're here today to maintain that priority, especially for those who have remained on the front lines, our healthcare heroes. But with that priority must come a recognition of what our providers are facing each and every day, and balancing the two so that we can ensure both safety and continuity of care for our vulnerable residents. First, it's probably helpful to describe the facilities that we PHCA represents and the regulatory environment that has truly enveloped those facilities, which is a key factor that adds to the complexity of introducing a new standard like the ETS. Skilled nursing facilities or nursing homes follow guidance and requirements set forth by the CDC and CMS. But Pennsylvania's Department of Health also plays a large regulatory role for nursing homes. And that department instituted many directives for our providers throughout the COVID-19 pandemic, often every single day or every other day. In addition, providers here were handed guidance by county departments of health as well as local governments. And they didn't have the opportunity, especially early on, to pick and choose. Every one of those directives needed to be followed. Assisted living communities and personal care homes, on the other hand, provide a more independent living opportunity for providers or residents who do not need 24/7 around-the-clock nursing home care. And so they follow directives from Pennsylvania's Department of Human Services, which during the pandemic looked to the state's Department of Health for their recommendations, which is receiving guidance from CMS based on CDC advice. So I would take a step back and ask, are you confused yet? Imagine being a provider at the height of the pandemic and attempting to follow those various directives while also attempting to keep residents and workers safe and families who couldn't enter facilities informed. The nuances and the differences within the healthcare continuum, or just simply between nursing homes, personal care homes, and assisted living communities, plays a very important role in maintaining the health and safety of residents and staff, and they have to be accounted for. Early in the pandemic, as departments and agencies attempted to introduce broad directives for providers, the system simply didn't work. Federal and state agencies often contradicted one another, once again, on a daily basis. Ultimately, the past 2 years have taught us that intergovernmental collaboration and continuity on health and safety directives is essential for long-term care providers. We're talking about one of the most regulated industries in the entire United States when we talk about long-term care. And as I began to outline, serving a wide array of government agencies at the state and federal level can create confusion, unnecessary redundancy, and challenges if the guidance continues to change, particularly during an emergency. Thus, we are asking that OSHA standards match or adhere to guidance already set forth by the CDC, CMS, and/or state authorities, because differences will only create more confusion. And it's also why we strongly support the proposed safe harbor clause. clause, which is a great example of following a more unified standard that has already been set by another agency. While there may be some hesitancy in aligning with CDC recommendations because those recommendations continue to change, we would caution that setting a permanent standard for a virus that only continues to evolve could prove to be very short-sighted, and setting a permanent standard for infection control practices can easily become outdated within a short period of time. Let's allow the experts on the front lines, our administrators, our directors of nursing, our caregivers, to make the best, most up-to-date clinical decisions for their workers and their residents. Another valuable lesson we've learned in Pennsylvania throughout the past 2 years is really to trust our facility and our community leaders. When we strip away the bureaucracy and we provide space to develop and to learn and to progress, we see better outcomes. We see higher quality. Earlier, I mentioned that long-term care has truly been on the front lines of the COVID-19 pandemic since March 2020. And what providers know today about this virus has greatly evolved beyond what they knew and what they were advised on during the early months of 2020. With proper resources, education, enhanced infection control practices, and the vaccine, we have seen cases and deaths drop significantly in long-term care, even as the COVID-19 virus mutates. Credit must be given to providers for navigating how to work in this new environment. But with this new environment comes our current workforce environment. In Pennsylvania and across the country, it is no secret that there is a long-term care workforce crisis. And I want to be clear, not a shortage, a crisis. And you heard about that in testimony early this morning and just now. In Pennsylvania, it's gotten so bad that we have a very real access to care issue. There are beds available in our facilities, but there are no workers to staff them. And we should not implement any new standard, policy, or procedure that could further exacerbate this crisis or strain our workforce even more. And it's why we have some concerns with the ETS. For instance, designating that workplace safety coordinator, which for some of our members, such as small personal care homes with very limited staffing and limited resources, could be quite challenging. But given our workforce environment, this may be difficult for nursing homes with hundreds of residents as well. Again, we have to balance this directive with providing essential care to our residents, who will be able to take on this responsibility on top of serving their vulnerable residents. We've said it since the start of the pandemic, the last thing we should be doing is prioritizing paperwork over our patients and the residents that we serve. And that brings me to data collection. One of the greatest challenges for providers throughout the pandemic has been the duplicity of data reporting. At one point in 2020, Pennsylvania nursing home providers were reporting COVID-19 data to up to 7 different platforms every day. Again, with those requirements, who has time to provide care? With an ETS like this, inevitably, we would expect more reporting. And if OSHA is going to require more reporting and more data, we hope that you'll rely on data that is already being reported and collected at the state or federal level. And we recommend that OSHA leverage that data first. But some data collection and record keeping should be reconsidered, including for hazardous events or infections that could take place outside of the workplace. Again, we understand the importance of worker safety, but to extend an employer's oversight and responsibility over events that take place away from our facilities and communities would not just be burdensome for that employer, but it really could create distrust and harm morale among employees. Additionally, as you heard earlier, monitoring the vaccine compliance of those who we do not directly employ, including contractors, clinic workers, even agency staff, has already created challenges for providers across our state, especially as there is more and more reliance on that agency staffing and other contractors. I will conclude my comments with this. Due to the complexity of the provisions within this rule, we are also concerned about OSHA's enforcement efforts around the ETS. Throughout the past 2 years, PHCA has time and time again asked government agencies and departments at both the state and the federal level for partnership with our industry, not punishment, collaboration, not division. We recommend that OSHA inspectors recognize a provider's good faith efforts toward meeting these standards and allowing flexibility for full implementation beyond the designated deadlines. This will better serve staff and residents working and residing in our facilities. We acknowledge that OSHA has been supportive of employers with helpful resources since this ETS was introduced, and we would ask that you continue to provide those resources to long-term care facilities and providers, because together we can work to make every facility and every community safer. Again, I want to thank you on behalf of Pennsylvania's long-term care continuum, and we are happy to answer any questions at this time.
Thank you, Mr. Schamberg. Mr. Levinson, do you have questions of this panel?
This is Jessica Schifano from OSHA, and I will be kicking off the OSHA questioning for this afternoon session. Thank you very much, both of you, for your testimony. We've heard some others expressing concerns about implementing controls in response to changes in community transmission levels. And you mentioned that that's something that you would like, or that your members may have already been implementing. So you can tell us a little bit about how this is done in practice.
So I will say that, it varies by state if there are state-specific regulations for providers in terms of what they need to follow, but ultimately CDC and CMS has implemented requirements in terms of how to follow what is happening in terms of community spread and what the screening and cohorting requirements should be like based on community spread. So in the skilled nursing facility setting, they're following the specific requirements of CMS. In the assisted living setting, they're following the specific requirements of the state, which often, as Zach mentioned earlier, follows what the CMS says, who also follows what the CDC says.
Yeah, that's exactly right. I would just echo that and say that in Pennsylvania, our nursing homes have been following that CMS guideline, where based on community spread, we would increase testing, whether it was weekly, whether it was monthly, weekly, or biweekly at some points, as well as some of the cohorting and prescriptive measures to keep folks safe, again, based on transmission in the community.
And there were easy ways for those facilities to track that information and be able to adjust the control measures and do the testing based on those triggers.
Yeah, in Pennsylvania, we would get that data, we would receive that data and those updates again on a weekly basis, and we would be able to see that county transmission, and we would adhere to that. Again, adjusting our policies and our safety protocols based on community spread. I think it's important to note that one of the things we learned, and I talked about in my testimony, a lot of the lessons learned throughout the past 2 years, was that what was happening in our communities really could have a direct effect in our facilities, that based on community spread, we were seeing higher and higher spread in our skilled nursing facilities, in our personal care homes and assisted living communities. So it was the right measure to take then, it's the right measure to take today.
Thank you. Both of you expressed the need for consistency and requirements across all of these different settings and multiple levels of intervention from regulatory agencies. So would you agree that following the most protective standards for employees would make sense?
I would say that well, obviously we want to take steps to protect our employees because, we want our employees to, one, be safe in terms of when they're providing care in our settings, as well as when they're going home. I would say following the CDC guidelines, which is evidence-based, would be, I think, the most appropriate because they're doing that balance between, they're using science to make a determination around what is the most appropriate action to take. So I think following the CDC's recommendation, which is based on science, would likely be most appropriate in our setting.
I would agree with that. Again, I want to make 2 points. The big concern that we have from providers.
Mr. Schamberg, we're having trouble hearing you.
Oh,
how
about
difficult?
Sorry, Your Honor.
Hopefully, yeah, there you go.
Okay,
Yeah,
thanks.
better.
Thank you. one of the two challenges that we've had is with this, and to address that question, is that duplicative guidance, following guidance that could offset one another, following guidance that could interact with one another and really cause confusion. I talked a lot about that in my testimony. So I think that's important. One, picking whether it's CDC, CMS, OSHA, and moving forward. And second, I don't want to understate the importance of bringing providers and the experts to the table so that as we are deciding which guidance to move forward with, which protocols are necessary, bringing those on the front lines together and asking the question, what will work? What will keep residents and workers safe? What can we implement without causing more and more challenges or burdens?
Thank you. This question, I think, is for Mr. Schomburg. You mentioned the difficulty of potentially having a safety coordinator in a number of the facilities that you are aware of. We have heard earlier from employees that messaging about the controls and training on the protections often wasn't clear. So if there isn't a COVID safety coordinator that's in place, how would you ensure consistent messaging, hazard assessment, and sharing of key information?
With facility or community leadership, whether it's an administrator, an executive director, I think that is certainly important messaging that all employees should hear. I would just caution OSHA that, again, as we're talking about more and more responsibility given to a strained workforce, we've got to be cognizant of that. And we've got to make sure that the information can be delivered and that every worker should know about it. But we've also got to be very cognizant of the fact that we are experiencing a workforce crisis. We do have a lot of strained employees, and especially for some of the smaller communities that we represent in Pennsylvania, that's a lot of responsibility to be given to a small staff with very, very limited resources.
Thank you. We have heard other testimony today about screening and how that's implemented in different types of facilities, both for patients, for visitors, for employees. So if you could talk a little bit about the member facilities that you deal with and the sorts of screening that they've put in place, especially to identify who may be suspected or confirmed to have COVID, and then being able to implement the proper precautions based on that status.
Sure. So I think this was mentioned earlier, Jessica, and so I'll just re-emphasize that CMS has put out pretty prescriptive guidelines in terms of requirements around screening. And so skilled nursing facilities are required to follow those guidelines. It's a regulatory requirement. In the assisted living setting, the states have requirements around screening. Again, many of those states follow CMS and follow CDC for the reasons that we've stated earlier in terms of trying to be consistent and having clear guidance. So I think generally speaking, the skilled nursing facility and assisted living providers follow the guidance from either the CMS, which is regulatorily required, or from the state, which again might be regulatorily required as well.
Sean summed that up very well.
Thank you. You mentioned again the consistency issue and having concerns about having to follow multiple requirements. Do you have any examples where your member facilities could not comply with OSHA requirements because of conflicting requirements from others?
So I don't have examples where they weren't able to comply, but I will tell you where there was confusion. I think a perfect example of that is where, OSHA had a requirement around vaccine, status, whether someone needed to wear a mask or needed to socially distance. And that was in direct conflict with what the CDC's requirements around masking. And so OSHA may have said, if you're fully vaccinated, you don't necessarily need to wear a mask in this particular setting or you don't need to social distance, whereas the CDC says, regardless of whether you are fully vaccinated or not, you need to wear a mask. And that did cause some challenges with the providers trying to educate staff around getting vaccinated or around whether they needed to be compliant with the mask requirements. I think the another example is around mask use, where OSHA may have said, you need to frequently change your mask as much as possible. And the CDC said, we think putting your hands to your face frequently is going to increase the likelihood of spread. And so we really only want you to change your mask if it becomes soiled or not used. And so those are two examples. There are probably a couple more, and that we've included in our written testimony that have caused some confusion around educating staff and caused a little bit of mistrust from staff who were maybe a little bit skeptical of trying to understand, well, why did they say why does one, why do I have to do it this way one time and not this way another time, and not really having a clear indication of, why is it different and why are those rules, changing?
Who is harmed in that, but it's that staff member and it's the leadership of a facility or community who has to answer or try to answer for those disparities. Jessica, what we can do is ask our members for other specific examples, and we can get those to you after the hearing.
Thank you. We'd appreciate including those in your post-hearing comments. I'm going to turn it over to my colleague, Brian Lincoln, for a couple more questions.
Sorry, hi. Again, I'm an economist, and I just have some data questions that you may or may not have anything available about. The main one actually being for hospitals, we have been able to find some sources, but this question of, we have to kind of count of how many people are actually coming into your facilities for the screening. We have to cost that. And I don't think too many facilities actually keep track of that in any kind of detail, but any studies that you know about that, any data sources that could address that question, for nursing homes and long-term care sector in particular, since that's where you all are, that would certainly be useful.
Mr. Lincoln, this is Judge Henley. I apologize. Can you move closer to your microphone, please? Fading in and out.
Oh, I'm sorry. Should I repeat the question?
I had a little bit of difficulty, so I would appreciate the repeat.
Okay, I'm sorry. It was the same question I asked of the American Hospital Association. Any data you have on the flow of visitors that come into a nursing home or a long-term care facility? Data. Observational studies are what we found. Some people have done for hospitals. So any kind of data or any studies that on that topic would be great.
Mr. Lincoln, just a follow-up question. Are you looking for the types of individuals, the number of individuals, the frequency?
The
count. Okay. Yes, I think we can look into that and see what information we can provide.
That'd be great. Thank you.
Thank you, Mr. Lincoln. Jessica, any other questions from OSHA representatives?
I don't think we have any other questions at this time. Thank you.
Thank you. Ms. Bethea, Mr. Schamberg, thank you very much for your testimony. There may be some questions from the witnesses. Unfortunately, because of time constraints, we can't ask them during this hearing. We've asked them to submit the questions to ets@dol.gov. If there are questions for this panel, we'll make sure that we provide them to you and you can choose to answer them in any post-hearing submissions. Thank you again for your testimony this afternoon.
Thank you, Your Honor.
The next panelist is from the Hospital Nursing Home COVID-19 Prevention Coalition. If you could promote Bita Lashkari, please. Or are we going out of order?
Apologies. The next speaker on our list is James Balda.
Okay, I guess we're going out of order. So the next speaker is from Argentum Senior Living Association, James Balda. Good afternoon, sir.
Good afternoon, Your Honor, and thank you for the time to join you this afternoon. My name is James Balda, and I'm President and CEO of Argentum. Argentum is the leading national association exclusively dedicated to supporting companies operating professionally managed, resident-centered senior living communities and the older adults and families they serve. Along with our state partners, Argentum's membership represents approximately 75% of the professionally managed communities in the senior living industry. On behalf of our members, Argentum appreciates the opportunity to provide comments as well as this testimony regarding OSHA's proposed rulemaking. As a threshold matter, Argentum joins other stakeholders in urging OSHA to proceed with an additional post-hearing comment period to provide additional time to file evidence and data relevant to this proceeding and OSHA's final rulemaking. In its notice, OSHA solicits additional comments and data related to the emergence and prevalence of the Delta and Omicron variants, as well as other developments since the ETS comment period closed in August of 2021. While Argentum agrees with the agency that there have been many important developments since August of 2021 that warrant the opportunity to submit additional comments, we believe the initial 30 days provided in the notice just wasn't enough time to gather and submit this information. As a national association for senior living communities, Argentum solicits important comments and feedback from its members, providing care on the ground throughout the country. An additional comment period would allow us to more comprehensively gather this important information and allow the agency to truly develop a clear and accurate and complete rulemaking record. As for additional comments, we primarily wanted to use our time with you today to provide the agency with additional information on the senior living community. While Argentum appreciates OSHA's efforts to protect healthcare and healthcare support service workers from exposure and harm from COVID-19, we believe that the nature of the services our members provide and the residences in which they're offered differs significantly from that provided by other types of settings like nursing facilities, and should thus be outside the scope of healthcare services as the term is used by OSHA in this rulemaking. Senior living is a home and community-based model that encompasses a wide range of care settings for older adults, combining housing and supportive services and facilitating healthcare as needed, but not providing healthcare. There are currently nearly 2 million residents calling senior living home across assisted living, memory care, independent living, and continuing care retirement services. Senior living communities are designed for and serve as homes for older individuals. For example, individuals 55 and older, who can generally care for themselves without regular nursing or other routine medical assistance. Depending upon state regulatory and licensing requirements, a senior living community may offer a continuum of accommodations and services for seniors, including, but not limited to, assisted living, independent living, continuing care, and memory care services. Senior living communities are predominantly private pay, meaning the customer, the resident, and their family members pay for the housing and care they receive, and were regulated in all 50 states and the District of Columbia. It's important to recognize that although the senior living community facilitates the provision of healthcare services, senior living primarily assists residents with the basic self-care or activities of daily living, such as eating, dressing, bathing, and the management or administration of medication. Most importantly, our members' residents consider these communities their homes. The many requirements in OSHA's rulemaking that may be applicable to healthcare settings are inconsistent with this concept. For example, erecting physical barriers throughout the facilities can cause confusion and stress for residents, especially those suffering from cognitive impairment. The same can be said for the requirement to mask within an individual's own home. Furthermore, we note that senior living communities are also a lower risk environment than hospital ambulatory care settings and non-hospital ambulatory care settings, which were exempt from the ETS in certain circumstances. As such, we believe that any final rulemaking by the agency should exclude senior living communities from its scope. To the extent that senior living remains within the scope of OSHA's rulemaking, we urge the agency to adopt an enforcement approach that provides for the greatest amount of flexibility possible to covered entities. Argentum is seriously concerned about the burden any permanent standard would place on our members. Throughout the course of the pandemic, the assisted living community has experienced significant expenses and losses due to the coronavirus. Specifically, since the beginning of the pandemic, senior living communities have successfully implemented enhanced protocols to prevent COVID-19 from entering the community and to mitigate the spread of and otherwise limit the harm from COVID-19, but all at significant expense. The cost of complying with an additional layer of regulatory complexity are amplified by the fact that despite caring for a highly vulnerable population, senior living communities have not received anywhere near the same level of federal and other types of providers. ALFs have suffered over $30 billion in losses due to PPE, testing, cleaning, staffing needs, and hero pay, as well as record low occupancy rates. Yet to date, assisted living caregivers have received only about $1 billion in relief from the Provider Relief Fund, which represents less than 1% of the overall fund. Many are still waiting for relief, and others have been inexplicably denied. Furthermore, senior living facilities were left out of other COVID relief programs implemented over the past few years that were vital to many other entities. This meant that where other entities received assistance for their increased expenses related to supplies such as PPE and testing, senior living did not. As a result, many of our members are still struggling to keep their doors open. We're concerned that any permanent standard will only serve to exacerbate these issues to the detriment of the senior population that we're committed to serving in their homes. Relatedly, overly prescriptive rules place additional burdens on employees and restrict the pool of workers who are willing to endure these burdens. This could be particularly devastating for our members who are experiencing a severe workforce shortage that has only been worsened by the pandemic. We ask that the agency consider these workforce shortages as it finalizes a standard that may implement burdensome requirements that will cause current and potential employees to find work in other industries. Retention and recruitment of a strong workforce allow our members to continue providing the highest quality care to the senior population that call our communities their home. Last, we stress that these standards and the burdens and costs that come with them are simply unnecessary in the senior living context. Notably, senior living communities are already subject to stringent infection control requirements through recommendations from the CDC and at the state and local level. Furthermore, as already mentioned, senior living has implemented enhanced protocols to prevent COVID-19 from entering the community and to mitigate the spread of and limit the harm from COVID-19. These efforts have allowed our members to implement dynamic infection control programs that have kept their residents safe. And the numbers back up this assertion. Despite being home to a highly vulnerable population to COVID-19, with an average resident age of 85, senior living communities had comparatively favorable outcomes in caring for this at-risk population. According to a study from NORC at the University of Chicago, 2/3 of ALFs had no COVID-19 related fatalities in 2020. Furthermore, the fatality rate in senior living facilities was 1/3 of skilled nursing facilities. Notably, these results are reflective of calendar year 2020, largely before vaccines became available to further protect residents and staff. Since that time, senior living communities have led successful efforts to vaccinate both residents and staff. To conclude, we ask that OSHA take time to understand the nature of the housing and services provided by the senior living community. Our GENM is happy to provide OSHA with additional information the agency may find helpful. Should the agency proceed with this rulemaking, we urge you to consider the severe financial distress as well as worsening workforce shortages many of our members are experiencing, and how these rulemaking requirements will exacerbate these issues. Our GENM truly appreciates the opportunity to present this testimony before the agency, and thank you for your time and consideration.
Thank you, Mr. Balda. Ms. Schifano, questions for this witness?
Thank you so much for your testimony. The OSHA panel doesn't have any questions.
Thank you again, sir. There may be questions from the witnesses. As I indicated previously, we've asked those individuals to post their questions at ets@dol.gov. If there are questions for you submitted, we'll provide them for your consideration in any post-hearing submissions. Thank you again, sir.
Thank you.
It's 3 p.m. We'll take a short recess before we hear from our last two panels, the National Nurses United and the New York State Nurses Association. We'll reconvene at 3:15. We're in recess. Welcome back. Do I have my court reporter? Court reporter?
Sir, I'm here.
And my contractor?
You're here.
Okay, we're back on the record. The next panel is the National Nurses United. Will the contractor please promote the panelists?
Yes, we have promoted all of the speakers except for the 4 following individuals. If you hear your name, we would ask that you raise your hand by clicking the raise hand button at the bottom of your screen or by dialing *3 to indicate your presence. They are Zenaida Triunfo Cortez, Gerard Brogan, Patricia Gonzalez, and Amira Sakira.
Ms. Comsty, do you know if they're joining us this afternoon?
No, they are not, Your Honor.
Thank you. Will the remaining 6 all be testifying?
No, Your Honor, Jean Ross, Rosalind De Leon Minch, and Deborah Berger will be testifying, and myself, Bryn O'Neill, and Eleanor Godfrey will be here as well to answer any questions.
Okay, I apologize. You said Jean Ross and Deborah Berger will testify and the rest will be available for questions?
And Rosalind De Leon Minch will also be testifying.
Okay, thank you. So please identify yourself and again, your affiliation before your testimony. Who is proceeding first, please?
Jean Ross.
Thank you, Ms. Ross. You may proceed.
Good afternoon. My name is Jean Ross. I'm a registered nurse and president of National Nurses United, or NNU, the largest union and professional association of registered nurses in the United States. On behalf of the 175,000 nurses represented by NNU, we want to thank OSHA for holding this hearing today on a permanent COVID-19 standard for healthcare settings. On the front lines of the pandemic, nurses and other healthcare workers have experienced high rates of exposure, infection, death, and deep moral harm because our employers continue to fail to prepare and protect us and our patients for COVID. For more than 2 years, nurses and other healthcare workers have run toward the emergency of the pandemic. We have been lauded as heroes, but this praise rings empty without enforceable protections at work. In the beginning, it quickly became clear that our employers were not prepared or willing to protect us. Starting in March 2020, NNU nurses began calling for a national enforceable OSHA standard to hold healthcare employers accountable. As of April 19th, 2022, NNU has tracked nearly 1.5 million healthcare worker COVID infections, and at least 5,104 healthcare workers have died from COVID, including at least 492 registered nurses. These nurse deaths from COVID are disproportionately nurses of color. Next slide, please. NNU has held vigil after vigil, reading the names of our fellow nurses who have died from COVID. And each time it has been gut-wrenching because we know how to protect nurses and other workers from contracting COVID. These infections and deaths could have been prevented. For decades, we've known from the science of infectious disease and occupational health and safety how to protect people on the job from aerosol transmissible diseases like COVID. As nurses, we know what protections we need, and we know that when dealing with a novel virus, the response must be grounded in the precautionary principle. We should not wait until harm is proven to take preventive measure. But our employers are often more concerned with their bottom line. Our healthcare employers' historic and ongoing reliance on just-in-time resourcing that has stretched us thin on a normal day became a matter of life or death in the pandemic. We watched in horror, demoralized, when our employers took our PPE, locked it up, and rationed it even when there was no shortage. Employers also denied nurses COVID testing and refused to test patients. Or when they did test patients, they often refused to wait for the results before placing that patient on a hospital unit without any precautions to protect workers or patients if the patient were positive. Due to the ongoing significant risk to healthcare workers from COVID, NNU strongly supports OSHA in issuing a permanent standard on COVID-19 in healthcare settings. But the standard, as proposed in the emergency temporary standard, must be improved. NNU urges OSHA to act expeditiously and adopt a standard that includes a comprehensive, multiple measure approach to COVID infection and exposure control. OSHA must include the full range of hazard control measures in a final COVID standard, with engineering controls like ventilation and isolation rooms, and administrative controls like test-based screening, patient isolation, and medical removal. The standard must have robust requirements on reporting, testing, contact tracing, and exposure notification and provision of optimal PPE. Critically, a standard must adhere to the precautionary principle and provide optimal workplace protections at all times. This means that the final standard should provide optimal protections based on the most up-to-date science on COVID. At a minimum, the standard must fully recognize aerosol transmission of COVID. In June 2021, after a year and a half of fighting for the most basic occupational health and safety measures in our hospitals, we were so thankful when OSHA issued the COVID Healthcare Emergency Temporary Standard. As NNU described in a letter to OSHA in November of last year, which is available in the docket, the mitigation measures outlined in the ETS have supported union nurses in our efforts to hold employers accountable. NNU nurses, armed with the requirements of the ETS, have fought for and won access and improvements to written COVID policies and COVID logs. We have won fit testing of respirators on COVID units for the first time, and we have won proper access and use of PPE, getting rid of reuse and rationing of PPE that endangered nurses and our patients, among other improvements. But despite the gains after the ETS was issued, it was also a stopgap measure. Some employers have refused to follow the requirements of the ETS, and OSHA now has a non-enforcement position. This is why strong requirements in a final standard and enforcement by OSHA is necessary. If given flexibility in the standard, employers will race to the bottom and claim any exemption. As we approach 1 million confirmed COVID deaths in the United States, the next surge is at our doorstep once again. Just since the beginning of this year, as of April 18th, over 26 million more infections and more than 160,000 new deaths. These from COVID have been reported in the United States. New daily cases are once again increasing as sublineages of the Omicron variant spread. Just in the past 14 days, 43 states have seen an increase in cases, and 20 states have seen an increase in COVID hospitalizations. When patients get sick, they need health care. There is no health system without our healthcare workforce. Healthcare workers are still at significant risk of COVID exposure. Since the beginning of 2022, each week, an average of 20,982 healthcare workers have been infected, and an average of 22 of them have died. This is almost certainly an undercount, since reliable exposure notification and access to testing continues to be an issue for many healthcare workers. And there is still no centralized reporting and tracking of healthcare worker COVID infections. This is a grave injustice to every healthcare worker who has died. While preventing infections, hospitalizations, and deaths has been nurses' major focus, there are other serious and lasting impacts of the pandemic. Nurses are suffering from alarming rates of PTSD and moral injury. Watching employers prioritize their profits over our patients, our health and safety, and our lives is demoralizing. Next slide, please. Our most recent survey of nurses, conducted in February and March 2022, reveals the alarming and increasing mental health impact of COVID exposure and lack of protections at work on our nurses. Nearly 3/4 of nurses said they are afraid they'll infect a family member. 83% feel stressed more often than before the pandemic. More than 68% feel sad or depressed more often than they did before the pandemic. More than half feel traumatized by their experiences caring for patients during this pandemic. All of these statistics rose dramatically since we last surveyed nurses nationwide in September of last year. When we are not protected at work, we are not just worried about our own health and safety. We are also concerned about our patients and our families. Some nurses had to make unbearable choices during the pandemic. As Talisa Harden testified before Congress in May of 2020, her hospital unit lacked appropriate protections from COVID, and as a result, Talisa was forced to send her daughter away to live with her grandmother so that Talisa would not infect her. At the time Talisa testified, it was more than 5 weeks since she had seen her daughter in person. Her daughter also paid a price, worrying about her mom and fearing she might die, as well as experiencing separation anxiety. Nurses experience traumatic stress and moral injury from the fear of infecting our families and our patients. Even with vaccines readily available, some nurses have children under 5 who are not yet eligible to be vaccinated, or they have immunocompromised family members. We must continue to prioritize preventing COVID infections and exposure at work, since we know that even mild or asymptomatic cases can have long-term debilitating health effects. And when we are not allowed by our employers to properly quarantine or isolate, we worry about infecting our patients. The patients we care for often have health conditions that make them vulnerable to severe illness, including premature infants in the neonatal ICU and patients with cancer, heart disease, and numerous other chronic conditions. Nurses are experiencing traumatic stress and moral injury from the sheer number of people dying around us from COVID. We see our colleagues die from COVID because our employer failed to protect us. We hold our patients' hands when they are dying, or worse, we suffer because our patients die alone. In closing, I want to recognize a few of the nurses we have lost by name. Next slide, please. Thomas Pickey was a devoted single father to his daughter Amanda. He came to nursing late in his 50s. As a nurse, he was known as a calm, grounding presence. Tom's employer required nurses to reuse N95s. Concerned about his safety, he wanted to bring his own respirator and face shield. The employer refused to let him. On January 8th, 2021, Tom died at the hospital where he'd been cared for by his fellow nurses and the doctors he had once worked beside. Next slide, please. Janine Pace Ponder was a mentor to many young nurses. Her friend and colleagues recalled her saying about their employer, "These people don't care about us. It will take one of us to die before they do something." In July 2020, Janine was working on a unit where both COVID and non-COVID patients were being cared for. She had been given only a surgical mask to wear. When 2 COVID-positive patients became disoriented and wandered out of their rooms, Janine ran after them, fearing they could expose other patients and staff. She contracted the virus, and after 5 days, she passed away in the emergency room of the hospital where she had worked for 25 years. We don't want to be heroes. We just want to be there for our patients and to survive to be there tomorrow too. Thank you again for your time today. Now, I will turn it over to Rosalind De Leon Minch.
Thank you so much, Jean Ross. My name is Rosalind De Leon Minch, and I am an industrial hygienist for National Nurses United. Before I get started, I'd like to thank OSHA for holding this important hearing so that we can begin to set a strong, permanent standard on COVID-19 to protect healthcare workers and patients. Today, I'm going to walk through 8 important truths about the science of COVID-19 and why providing optimal workplace protections through a strong permanent OSHA standard for nurses and other healthcare workers is critical to safe patient care and to respond to the ongoing pandemic. The scientific evidence for these points is included in the comments that we submitted. Next slide, please. Truth number 1. The COVID-19 pandemic puts nurses and other healthcare workers at significant risk. As Jean mentioned, nurses and other healthcare workers have worked on the front lines of this pandemic for over 2 years. They are exhausted. They're being treated as expendable. Too many nurses have gotten infected and died from COVID because their employers failed to protect them. The COVID-19 pandemic is not over and will continue to put healthcare workers at significant risk. And the way to protect workers from this significant risk is to issue a strong and protective enforceable OSHA standard on COVID-19. And while vaccination is important, COVID vaccines wane over time, especially with immune evasive variants, and ongoing evolution of the virus is likely to produce new variants of concern that may be more severe and further evade our protection from vaccines. Next slide, please. Truth number 2. Overwhelming scientific evidence shows that SARS-CoV-2, the virus that causes COVID-19 disease, is transmitted through infectious aerosols that are emitted when infected individuals breathe, speak, cough, or sneeze, regardless of symptoms or vaccination status. In fact, asymptomatic or pre-symptomatic infections have played a significant role in the spread of SARS-CoV-2. Studies indicate that approximately half of all transmission events are from cases that have no symptoms at the time of transmission. These aerosol particles can travel through the air to distances farther than 6 feet and can remain suspended in the air for long periods of time. Researchers have recovered viable or infectious SARS-CoV-2 in the air from hospital rooms with COVID patients collected at nearly 16 feet away in the absence of a cough or aerosol generating procedure. Researchers have also detected the virus in ventilation exhaust filters located at least 50 meters from patient room vent openings within wards. And because individuals who do not know that they are infected can emit infectious virus into the air, and in light of the spread of more transmissible SARS-CoV-2 variants in the United States, effective prevention of transmission remains of paramount importance for the protection and safety of all healthcare workers. Registered nurses are uniquely at increased risk of COVID exposure due to the nature of their work, providing hands-on care for our communities, interacting with patients more intimately and for longer periods of time. Registered nurses and other healthcare workers also perform or participate in aerosol generating procedures, especially with COVID patients who may require CPR, intubation, and other treatments. Other aerosol generating events, such as coughing, sneezing, and breathing from both symptomatic and asymptomatic COVID patients, also frequently expose healthcare workers to infectious aerosols. This is a matter of life and death. Failure to fully recognize aerosol transmission has profound implications for how to stop the spread of the COVID-19 pandemic. This is why OSHA's final COVID-19 standard should require optimal layered workplace protections for nurses and other healthcare workers, irrespective of workers' vaccination status, including respiratory protection, precautionary screening and testing of all patients and visitors, dedicated COVID and non-COVID units, and other measures. Next slide, please. Truth number 3. COVID vaccines are a critical part of a public health program, but are not enough by themselves to combat the pandemic. Several studies have found that vaccine effectiveness against symptomatic disease with the Omicron variant is significantly lower than against previous variants. For example, the latest data from the UK found that 2 to 4 weeks after either a Pfizer or Moderna booster dose, vaccine effectiveness against symptomatic disease with the Omicron variant dropped from around 60 to 75% to almost no effect 20 weeks and after. An MMWR report found that booster protection against COVID-associated emergency department and urgent care visits and hospitalizations among adults declined within 4 months during the Omicron predominance. Studies have also shown that infected, fully vaccinated, and boosted individuals can readily transmit the virus and that vaccine-induced immunity wanes over time. Frontline nurses and other healthcare workers were among the first to receive a booster dose in early October, which means many healthcare workers are now several months out from their initial booster dose. And with a highly transmissible and immune-evasive Omicron sublineage BA2 now dominant in the United States, this puts nurses at increased risk for severe disease. And this danger is further magnified by the lack of an enforceable OSHA standard on COVID-19. Next slide, please. Truth number 4. Nurses and other healthcare workers need an OSHA standard based on the best science and the precautionary principle. But for over 2 years, healthcare employers have relied on a menu of weak guidelines from the CDC that are not based on science and endanger workers, patients, and public health. And these weak CDC guidelines automatically become a race to the bottom for employers, constantly finding ways to cut costs and boost profits instead of planning for patient and public health needs. Let's not forget that the CDC issued guidance enabling healthcare employers to institute dangerous practices, including decontamination and reuse of N95 respirators, and asserting that bandanas and scarves were sufficient protection against an airborne virus in hospital settings, which resulted in untold number of healthcare worker infections and deaths. Over 2 years into the pandemic, the CDC has yet to fully recognize aerosol transmission of the virus, despite overwhelming evidence and scientists saying that from the beginning. The CDC is still drawing a false and dangerous equivalency between respirators and face masks, even though respirators are scientifically proven to be better at protecting against aerosol transmission. The CDC's latest isolation guidance that allows exposed and infected healthcare workers to return to work is not based on science, but on ensuring that healthcare employers have a supply of workers. The CDC's new COVID-19 community level metric is both harmful and antithetical to public health, allowing uncontrolled spread of the virus in communities by significantly increasing the case thresholds and by using lagging indicators such as severe disease and hospitalization. The new metric inappropriately alters the current understanding of COVID-19 risk. In abandoning public health measures and changing goalposts, the CDC continues to put healthcare workers and the public at risk and make the United States vulnerable to future devastating surges. We cannot remain in a perpetual state of unpreparedness. This is why OSHA's permanent COVID-19 standards should not be aligned with CDC guidance and should require healthcare employers to provide optimal workplace protections for nurses and other healthcare workers, irrespective of community transmission. To effectively protect our healthcare workforce from the significant risk of COVID-19, employers must proactively anticipate occupational exposure to COVID-19 by implementing multiple protective measures to prevent transmission of the virus within facilities and to protect workers from exposures to safely care for patients. Next slide, please. Truth number 5. When nurses are safe, patients are safe. Hospitals should be centers of healing, not a source of infection. Both legally and morally, healthcare employers have an obligation to invest and prioritize the health and safety of their employees. Hospitals and healthcare facilities play a critical function in caring for individuals with suspected and confirmed COVID-19 and in preventing the spread of infection. Next slide, please. Truth number 6. As Jean mentioned, we are now seeing an increase in cases and hospitalizations, barely 2 months since the Omicron BA.1 surge caused the sharpest peak in cases and hospitalizations of the entire pandemic in the United States. We're also seeing multiple Omicron sublineages emerge in the United States and around the world. The COVID-19 pandemic is not over, and neither is virus evolution. The long-term evolutionary trajectory of coronaviruses is unknown, and failure to prevent widespread transmission will result in further evolution and spread of variants of concern that may be more severe and evade vaccine protection even further. Next slide, please. Truth number 7. Repeated surges in COVID infections, hospitalizations, and deaths put nurses and other healthcare workers at heightened and perpetual risk from infection and moral injury. Repeated COVID reinfections also raise serious concerns for healthcare workers who have worked on the front lines of the pandemic for over 2 years. One study found that hospitalization was more common at reinfection than the initial COVID infection. Another study found that patients discharged from COVID hospitalization had more than double the risk of subsequent hospitalization or death, and a 4.8-fold higher risk of all-cause mortality compared to the general population. More COVID infections mean more hospitalizations and deaths, and more opportunities for variants of concern to emerge. More COVID infections also means more debilitating chronic complications and societal disruption due to school absences and missed workdays. Nurses and other healthcare workers diagnosed with COVID-19 face lasting symptoms, which directly impact patients and our ability to respond to the pandemic. Next slide, please. And finally, truth number 8. A vast body of research has shown that even asymptomatic and mild infections can result in long COVID. One study found a 40% increased risk of new onset diabetes at least 1 year after infection, even among those who had mild infections and no previous risk factors. A UK biobank study of 400 individuals who had mild to moderate or asymptomatic COVID-19 had significant reduction in gray matter thickness in several regions of the brain and larger cognitive decline. This is why OSHA must issue a strong and protective enforceable OSHA standard on COVID-19 to protect healthcare workers and patients, regardless of symptoms, vaccination status, or community transmission. Thank you again for your time, and now I will turn it over to Deborah Berger. Next slide, please.
Thank you for your time today. My name is Deborah Berger, and I'm a registered nurse and president of National Nurses United. Let me start by saying that as nurses, we want this pandemic to be over as much as anyone, but it is not over. COVID continues to be a significant risk to nurses and other healthcare workers. Since OSHA issued the healthcare ETS in June, new highly transmissible COVID variants that escape immunity from prior infection and vaccination have emerged. This means that healthcare workers will continue to be exposed to COVID on the job as potentially continue to be infected. As long as we face that risk, we need protection. There is no healthcare system without healthcare workforce. Protecting us is foundational to providing safe patient care and combating the COVID pandemic. Currently, there is a nationwide nursing staffing crisis, but there is no shortage of dedicated nurses who are willing to work where they have the resources they need to safely care for patients. As Jean mentioned, healthcare employers' just-in-time practices have eroded the nation's ability to properly prepare for emergencies like the pandemic. Just-in-time practices also treat hospital staff as inventory items. To cut costs and maximize profits, our employers schedule only the minimum number of nurses and other workers. Even before the pandemic, hospitals intentionally did not maintain a robust pool of nurses to draw from when scheduling shifts. We have been demoralized by employers who treat us as disposable. Nurses do not want to work in unsafe conditions where we can become infected with a potentially deadly virus and also infect our patients, our families, and our coworkers. To retain nurses and bring back those who have left the bedside, OSHA must have the strongest protections for healthcare workers against COVID exposure, including a multiple measures approach. This is how we ensure healthcare facilities are safe for workers and safe for our patients, so everyone can get the care they need as COVID continues to circulate. We can change the trajectory of the pandemic. We must and we can do better. Next slide, please. I want to highlight some key areas in which NNU urges OSHA to update the COVID ETS standards when issuing a permanent standard. First, OSHA should not rely on weak CDC guidance in the final standard. Second, OSHA should require employers to proactively establish surge plans, including plans to expand isolation beds with negative pressure ventilation and HEPA filtration, plans to establish PPE stockpiles, and plans to provide safe staffing during COVID surges. Third, OSHA should remove all exemptions to the scope of application of the standard, including removal of any triggers or tailoring of the standard based on non-employee screening and worker vaccination status. Fourth, OSHA should ensure that fully vaccinated and boosted workers and workers with recent COVID infections are not exempt from the medical removal and related benefits. Fifth, OSHA's final standard should reflect the best available scientific evidence based on aerosol transmission of COVID. Employers strip away protections from nurses who fall outside the CDC's arbitrary definition of close contact. But nurses continue to report COVID infections that occurred with exposure for less than 15 minutes and beyond 6 feet. Because CDC's definition, many nurses are denied medical removal. Lastly, OSHA should strengthen ventilation and patient isolation requirements. OSHA should prohibit mixing of COVID positive, suspected, and non-COVID patients in the same patient care unit or for a worker's assignment. Our full recommendations are included in our comments. I want to expand on our position that OSHA should not rely on weak CDC guidance in its final rule. NNU members were exposed, infected, and some died because their employer, relying on CDC guidance, did not give them respirators. Despite the danger it possesses to healthcare workers, the CDC continues to maintain crisis and contingency standards that employers use to withhold or ration PPE even when there is no shortage. CDC's COVID isolation guidance also endangers workers and patients, allowing COVID positive nurses to return to work with no isolation period. This is part of a pattern of CDC guidance that is not based on scientific evidence. The CDC rollback on protections reinforced the message from our employer that we are expendable inventory items. This also struck fear in our hearts because it put us in a terrible position of potentially infecting our patients. Employers' failure to protect workers creates a vicious cycle of unnecessary exposures, infections, and deaths that leave fewer and fewer healthy nurses available to care for patients. As Tinny, an NNU member, said, quote, "Right now, the nurses and the patients are suffering because the hospital didn't do what it needed to prepare for this surge. The hospital didn't staff up, it let travelers go, and it did not train staff during the quiet months to be able to provide meaningful help in the ICU, step down, and COVID units." End quote. This is having a cumulative effect on healthcare workers who have been on the front lines for over 2 years and are exhausted. Employers' utter disregard for our safety and that of our families and patients and our communities has pushed some healthcare workers to the breaking point. Next slide, please. Weak CDC guidance enables employers' absolute lack of concern for worker and patient safety. Our employers tell the nurses that they are following the CDC. For one example, one NNU member who works in a pediatric oncology unit was told to put a COVID positive patient in a room with a cancer patient who did not have COVID. She was rightfully terrified to expose a child with cancer to COVID. Based on CDC guidance, her manager proclaimed that her COVID positive patient had recovered because a few days had passed since they tested positive. The nurse insisted that they be placed in separate rooms until he received a negative COVID test. Nurses are the last line of defense for patients. Every patient, especially medically vulnerable patients, deserve to be provided with safe patient care. Additionally, OSHA should not create tiers within the rule, and OSHA should not establish triggers for protecting workers. Rather, OSHA must adhere to the precautionary principle in the final standard. The standard must apply to all healthcare workers and all healthcare workplaces, irrespective of a patient's symptoms, community transmission levels, or a worker's vaccination status. COVID vaccines are important, but we know that we cannot boost our way out of the pandemic. Asymptomatic and mild infection should never be downplayed. NNU conducted a national survey of over 5,000 RNs that was published in September of last year that found striking numbers of nurses facing lasting COVID symptoms. A third of the nurses reported having symptoms lasting 3 to 9 months. 12% had symptoms lasting 9 to 12 months, and 12% more than a year. Most common symptoms reported included tiredness, fatigue, joint or muscle pain, memory or concentration difficulties, headaches or migraines, and difficulty breathing or shortnesses of breath. While studies have shown that COVID vaccines may reduce the risk of long COVID, evidence on their protective effect remains inconclusive, and we know some vaccinated COVID patients suffer from serious long-term effects. Nurses and other healthcare workers are critical to patient care, so we must maintain our own health to safely care for our patients. Our professional duty as nurses requires us to provide safe therapeutic care. Nurses must protect our patients, especially those who may or will be suffering from long COVID. But we cannot provide safe patient care, and we cannot protect our patients when our employers do not protect us. Strengthening workplace protections for our healthcare workforce is crucial to ending the staffing crisis. In closing, I will recognize just a few of the healthcare workers who have been harmed from their employer's disregard for their health. Next slide, please. In spring 2020, Helen Godey, a registered nurse, called every single person she knew to check up on them and make sure they had active advice from a registered nurse to take this new virus seriously. Helen became ill after caring for an infected patient at the hospital. She was one of at least 10 out of 36 nurses on her medical surgical unit who contracted the virus. Helen passed away from COVID at the hospital where she worked for 16 years. She was 54 years old. Next slide, please. Celia Yap Bonango, a registered nurse, raised concerns about the lack of PPE made available to nurses when COVID patients began seeking treatment at her hospital. She had 4 decades of nursing experience and was determined not to take advantage of the younger nurses in the hospital. Coworkers described her as a dedicated, compassionate nurse who advocated fiercely for her patients and for the rights of her fellow nurses. Celia contracted COVID after caring for a COVID patient without a respirator. Her employer, relying on the CDC's ineffective screening procedures, had not tested the patient for COVID. In addition, like so many other employers, her employer failed to have a fit testing program and rationed N95s. Her employer delayed reporting COVID exposures and failed to provide workers who were exposed to COVID with time off to quarantine. Celia died on April 21st, 2020, a week before she was set to retire. Next slide, please. Sandy Ofield was a registered nurse who fought for optimal PPE under the precautionary principle. In accordance with CDC guidance at the time, Sandy and her other colleagues were given only surgical masks, and their employer locked up N95s. Sandy was one of 50 healthcare workers, including 33 nurses, who were exposed to a single COVID-infected patient while wearing surgical masks. 10 of the nurses tested positive. 3 were hospitalized, including Sandy. Sandy died at the age of 53. Nurses are bound together in our grief and in our solidarity, in pain and in our courage. In honor of all the nurses and healthcare workers who have lost their lives, we vow to win the protections we all deserve. We want to thank OSHA for their work on this comprehensive, permanent COVID-19 standard. The cost of not providing these protections is simply too high. We implore OSHA to fulfill its mission of ensuring safe and healthful working conditions and protect every healthcare worker so that we do not have to mourn any more of our colleagues. Thank you again for your time.
Thank you very much. I believe now we'll proceed with questions from OSHA. I'll remind the panelists to please identify yourself for the record before answering any specific question. With that, I'll turn it over to our OSHA representative.
Thank you, Judge Henley. This is Jessica Schifano from OSHA. We have a few questions. The first is for Ms. DeLeon-Minch. Given the testimony that you provided on transmission, do you believe that distancing in healthcare settings is still important? And if so, how far does the distancing need to be?
Thank you for that question, Rosalind DeLeon Minch. For the record, I think, like as we mentioned, multiple measures approach is what is needed and what is based on the science of COVID-19, as well as the scientific research that is available. And I think, there are multiple steps that employers can do, such as limiting the number of people in the waiting room, for instance, so that the amount and the number of aerosol particles that's in that room can be reduced, and reducing the exposure for everybody.
Thank you. Another question for the panel. If a healthcare facility is already following the CDC and or the CMS's standard cleaning and disinfection requirements or precautions, do you believe the additional COVID-specific cleaning and disinfection requirements that were imposed by the ETS are necessary?
I can answer that. Rosalind DeLeon Minch. Yeah, I believe, I think the permanent standard should follow the precautionary principle and also based on the scientific evidence. While aerosol transmission is the significant and predominant mode, we also know that there are studies that have found infectious SARS-CoV-2 in fecal aerosol and in urine and other specimens. So I think it would be dangerous to ignore contact transmission as another mode, right? And so we want to be able to prevent transmission, and that includes preventing cross-contamination in all areas of facilities.
And the standard cleaning that is done in healthcare facilities is not sufficient to do that. Would there be additional cleaning that's needed for COVID for those purposes?
Yeah, I believe we addressed that. I mean, I think, definitely when you are in units with suspected and confirmed units, requires frequent cleaning and disinfection, and to make sure that healthcare workers who are in charge of cleaning those areas are provided respiratory protection and other PPE so that they can be protected from those chemicals, and also to follow what's listed under the EPA List N environmental cleaning protocols that will disinfect the virus SARS-CoV-2 effectively.
And also, I think you need to understand that patients don't always stay in their rooms. They're moving from different units for various procedures and medical imaging. So those viruses get transmitted as the patient is being transported to the different units. So it is crucial that there be extreme measures for cleaning all areas in the hospital and other patient care settings.
Thank you.
That last answer was from Deborah Berger.
You mentioned in your testimony the need for test-based screening. Do you agree with the testimony we heard earlier from the American Hospital Association about current practices in hospitals? They suggested that many hospitals were already implementing test-based screening for their patients, especially.
Thank you for that question, Rosalind DeLeon Minch. I can tell you that based on our last survey that was just released this past month, in terms of this is a nationwide survey. We have conducted several COVID-19 surveys since the beginning of the pandemic from 2020 to the current year. And based on our current survey, we found that only 24% of hospital registered nurses reported that their employer notifies them of COVID exposures in a timely manner. Access to testing is still an issue at some hospitals. 17.8% of registered nurses report that access to testing has declined since the beginning of the pandemic. Only 56.8% of hospital registered nurses report that every patient is screened for recent exposure history to COVID-19, which is down from 61.7% in our September survey. Screening of visitors has also gone down since our last survey. 48.6% of hospital nurses reported that all visitors are screened for COVID signs and symptoms at their facility, which is down from 52.7% in our September survey. And only 23.8% of hospital registered nurses report that every visitor is screened for recent COVID exposure history at their facility, down from 38.5% in our September survey. This is why NNU is urging OSHA to include precautionary screening and testing of all patients and visitors, and weekly testing of staff, because we want to prevent the transmission and the introduction of the virus in healthcare facilities to protect healthcare workers as well as patients, right? So what that means is to be able to screen patients and visitors for symptoms and any signs of COVID-19, to use a reliable diagnostic testing, and to also test or screen them for a recent exposure history. We know that testing by themselves are insufficient because of, again, asymptomatic transmission, and also depending on, when the patient or the visitor or the individual was tested, the viral load, and whether there was a sufficient sample. So, which is why we need multiple measures approach.
Thank you. For this screening testing of patients, employees, and visitors, who would pay for that screening testing?
Rosalind DeLeon Minch, it would be the employer. Employers are legally and morally obligated to protect healthcare workers, and by doing so, it would also protect patients.
Thank you. I'm going to turn it over to my colleague, Brian Lincoln, who has some additional questions.
Yes, hi. Thanks very much for your presentation. It was very useful. I wanted to ask a couple of specific questions. One being about, both in the comments and then in testimony we've heard today, questions about labor shortages and staffing problems and turnover and so forth. We'd love to hear more about your experience. And, we know it's a multi-factor, many factors involved in this. We're particularly interested in your experience in terms of how you feel the ETS will be affecting those situations. And sorry, then just last, both in general, and then also we've certainly heard about, rural settings in particular may have problems and so on. And so, if you had any specific things you'd like to say about
this is Deborah Berger, National Nurses United. I do have comments about the nursing shortage. The real issue is there was a shortage of nurses before the pandemic, and it was a self-inflicted wound by the employers because they often short staff, which caused nurses not to be able to give the care that they needed. They made it difficult for nurses to have a family life and work. After the pandemic, they made it even worse by rationing PPE, by locking up PPE, by not giving the nurses the resources they need to safely provide care for their patients, and to make sure that their families and their communities were safe during the pandemic. Many nurses went to great lengths to make sure that their family was protected by renting travel RVs so that they had a safe place to go and wouldn't infect their patients. So, and once we got the ETS, there were more nurses that felt safer in their workplaces because they had a consistent rule that they could point to demand that their employer give them the PPE that they needed. And it was especially hard for nurses that weren't in unions to get those regulations. So the hospitals that didn't have unions were better protected. And it had a benefit because the nurses weren't, and other healthcare workers weren't sick as often during that time in COVID. If half the nurses had the PPE protections that they needed, we wouldn't have had to have listed all of these nurses that died as a result of not having the PPE that they used, because the CDC said that they could use bandanas, they could use surgical masks, or even when the first pandemic first came out, that masks weren't necessary and that they scared the patients and were threatened termination. So I urge the OSHA to please look at these standards as a way to protect all nurses and patients in this country, and put forward a standard that nurses can rely on across the country. And it will improve the labor shortage, because nurses that I personally know left nursing because they were terrified about getting COVID during this time because of their age or immunocompromised status.
If I could add to that.
Oh, who wants to go first?
Go ahead. Go ahead, Jean.
I was just going to add to it because you had asked about rural hospitals, and I find that interesting every time we talk about what we need in a hospital, both before the pandemic and now. Rural hospitals are put forward as an example where we can't quite do what we could do in a larger facility. And the fact is, they should be getting the same standard of care no matter where they live in this country, which is one of the reasons we've advocated, of course, for Medicare for all for decades now. And they would have the staff that they needed and provisions for funding it. So in addition to that, as Deborah said, you had asked about our moral distress, which is what we call it. And she's absolutely right. The only way we will ever feel truly supported in the workplace is to have a standard that's permanent and that we can look to say to our employers, you must follow this. Otherwise, the kinds of things we're putting forward to you today were only seen by the public because of this pandemic. We've been putting up with this for years, the cutting of corners. We really need this. And I tell you, Deborah is right. Nurses have told us, and we know from experience, in the future, you will retain the nurses you have, and you will recruit new ones once they know they're safe. And that safety has to rely on that permanent OSHA standard for COVID-19. Thank you.
If I could just add, Deborah and Jean are absolutely right. They are the experts in their workplaces. And but if I could just add, going back to the very first COVID-19 survey that we conducted in 2020, which revealed that hospitals across the United States were unprepared, with just 30% reporting that their employer had sufficient personal protective equipment stock on hand to protect staff in the event of a rapid surge in patients. And this unreadiness, this unpreparedness was the direct result of healthcare employers' historic reliance on just-in-time practices, prioritizing profits over the health and safety of healthcare workers and patients. And at its core, just-in-time resourcing eliminates any unnecessary waste, acquiring inventories like respirators and gowns at the exact times that they are needed. And this just-in-time system equally treats hospital staff as inventory items, scheduling only the minimum number of nurses and other healthcare workers needed to cut costs and maximize profits. So in consequence, this just-in-time model has really eroded the nation's ability to properly prepare for emergencies like pandemics, and obviously directly impacts the moral distress that Jean and Deborah was just talking about.
Thank you. I need to move on, Mr. Lincoln. Do you have any other, Mr. Lincoln, do you have any other questions? We need to move on.
Sure, absolutely. Just on those subjects, certainly any data you have. One thing we noticed in your comments is that you have these great surveys of compliance rates for, that your members are seeing. We'd just like to make sure that you had all the documentation that you guys have on those surveys to be put in the record afterwards. That would certainly be helpful. Thanks very much for your responses.
Thank you very much.
Shifano, is that it for OSHA?
Ms. Tryon has a couple of questions.
Hi, good afternoon. First of all, Your Honor, I wanted to ask that the PowerPoint, we've marked this PowerPoint presentation as Exhibit 4, and I wanted to ask that that be added to the record, please.
So added.
Thank you. And then I just had a couple of follow-up questions for the panel regarding testing. I wanted to clarify your position on who it is that should be tested. All patients, all visitors to the hospital, all employees, or would there be any sort of threshold symptoms that needed to be shown? What's your position on that?
Thank you, Rosalind DeLeon Minch. Yes, precautionary screening and testing for all patients and visitors coming into the facilities, and surveillance testing, weekly surveillance testing for staff, because we know that testing by themselves, it will be insufficient to be able to determine who is infected and who's not. And as I mentioned, there are a lot of asymptomatic cases out there. And so for example, there was a study from Goldberg et al. That found that an outbreak investigation in an Israeli pediatric hospital. They identified 6 healthcare worker nosocomial infections from an asymptomatic patient that tested negative for COVID-19 upon admission. And everyone was wearing a surgical mask, which we know is insufficient, but that exposure lasted 10 minutes. And there are other multiple studies that it goes beyond the 15 minutes 6-foot definition of the CDC.
Thank you. And just one more follow-up. Do you envision requiring all of this testing to occur sort of at the door to the healthcare facility? What would you think about at-home testing?
Yes, at the facility, and if they are, because at-home testing, we know that antigen tests have some limitations. They are the PCR testing are much better, are much more sensitive and specific than at-home testing. And so there are studies that we've included in our comments about some of the limitations of antigen testing and the difference between PCR and antigen testing. And at-home testing are currently, there isn't a system where at-home testing are being reported to public health agencies.
Okay, thank you very much. That's all I have.
Is that it for OSHA?
That is it, Your Honor.
I believe we have time for one question from, if you could vote Rebecca Rendell, if she still has a question for this panel.
I'm here. Rebecca Rendell, and I have a question for probably Jean or Deborah. Wondering if you could give us a better sense of how hospitals and healthcare facilities work, and if nurses and other workers who are not with patients or in a COVID unit, how they might be exposed to COVID, and how they might, just like a better idea of the functioning of the setting that they're working in and how they might encounter COVID exposures. Thank you.
This is Jean Ross. I could start, and then I'm sure Deborah will want to add. We don't stay put. Nurses move all over the hospital, as Deborah mentioned earlier, so do patients. And we're part of a team. There are many, many respiratory therapists, medical technicians and technologists, people who bring the meals, people who clean the rooms and the rest of the facility that have contact. Now, granted, during a pandemic, the person who spends the most time, and we try to limit that so not as many people on the team are exposed to that patient, that person is generally the nurse. But just as we don't always stay in one place, neither do the patients. I think Deborah mentioned before, they may have to go for a procedure. You would go with them, or a transport team would come. That person would be exposed to the patient. So the concept that employers unfortunately often use, that these are the people who need to be trained and have the proper PPE because they'll be handling the patients. You can't limit it like that because it isn't limited. That's not life in the hospital. So there's lots of exposure to be had. There isn't such thing as one first receiver and then that patient will never be exposed to other people or the other way around. It's going to be continuous and constant. And so proper protection for every healthcare worker that's in that facility, for visitors coming in, if they're allowing them. I know that for a significant period of time, unfortunately, we couldn't have family come in at all, and rightly so. But if that's the case, if they're coming and going, the testing that you mentioned is needed. The protection that we talked about is needed. And that's why it's so important to have this permanent standard that we all understand and can rely on. Thank you.
I have no comment. Jean covered it. Thank you.
Your Honor, we can't hear you.
I apologize. Thank you, Ms. Rendell, for the question, and thank you, National Nurses United, for your testimony. If there are witnesses who had questions that we weren't able to get orally, you can submit them to ets@dol.gov. We'll provide them to this panel for their consideration in post-hearing responses. Again, thank you very much for your testimony this afternoon. Our final panel for this afternoon is the New York State Nurses Association. If you could promote our witnesses. And is Denise Davila available?
Hi, this is Lisa Baum from New York State Nurses Association. I'd like to give some introductory comments and then pass it on to our nurse members.
Is Denise with us, or are you speaking on her behalf?
Denise, Stephen, and Leah should all be present. Are you not seeing? Let me see. Are you not seeing Denise?
Denise and Leah, Robin, if you're available, please unmute and turn on your camera. So Lisa, and I hear you. I don't see you.
It looks like there is one Cjolin user who has raised their hand, which may be one of our missing panelists. I will promote them to the panelist role now.
Thank you.
And Leah reports that she's unable to unmute.
That would be a problem. Is she on the...
This is Denise Diabel. I was just able to unmute.
Okay,
Thank you. And Leah is the one who raised her hand.
Leah was just promoted to the panelist group.
Okay, so it looks like we have all four individuals. So if you could, then I'll turn it over to you, Lisa. If you could please identify yourself, your affiliation, and then turn it to the next speaker.
Okay, thank you. My name is Lisa Baum. I am a certified safety professional with over 25 years experience in the field of occupational safety and health. And I am a health and safety representative for the New York State Nurses Association, commonly known as NYSNA. NYSNA represents over 40,000 registered nurses in the state of New York. Our members work in both the public and private sectors, acute care and long-term care facilities, schools, prisons, and health departments throughout the state. Working with the nurses of NYSNA has been a great privilege, especially during the past 2 years of the pandemic. However, it's also been deeply painful and at times unbearably frustrating. We've watched members sicken and far too many have died. Many continue suffering new infections and symptoms of long COVID. Many have also been reinfected. We knew that there were ways to protect our members, but employers were, and many are still, resistant to improvements in ventilation, PPE, and policies and procedures that limit worker exposure. We wouldn't be here today if workers were doing the right thing. That's where OSHA needs to step in. Today, we've heard industry representatives complain that OSHA requirements will be too burdensome. When has industry not said this when OSHA has solicited comments for a new safety standard? But there is good news. The good news is that it's not too late. We know a great deal more now than we knew 2 years ago. And we know that with proper controls in place, healthcare facilities can be remarkably safe for both staff and patients. We've seen this with the bloodborne pathogens standard, which has saved countless lives. Airborne transmissible pathogens should be treated the same way, and exposure risk should be controlled. OSHA is holding a public hearing, so we are given the opportunity to make our case for a strong protective standard that will save so many from acute and chronic illness and even death due to COVID. We thank you, OSHA, for listening to the important voices of frontline healthcare workers. Few workers have ever had to make the kinds of choices healthcare workers have had to make during this pandemic. I've been told multiple times by NISA members that they have had to choose between resuscitating a patient while not provided with proper protection or protecting themselves from what could be a fatal exposure. Over and over again, healthcare workers have had to choose between caring for a COVID patient while wearing an ill-fitting, unprotective surgical mask or protecting themselves and their families. Before the ETS and after the ETS expired, our members received no notification of exposure to COVID. Workers exposed to dangerous chemicals and minerals, radiation, and many other toxic substances must be notified. Why should SARS-CoV-2 not be treated the same? We pull firefighters out of buildings when it looks like the roof is going to collapse. But for 2 years, we've continued sending nurses into the flames. NISA's message to OSHA on promulgation of a permanent COVID-19 standard can be summed up in one sentence. We want for workers in the healthcare industry the same level of protection that OSHA enforces in other industries, such as manufacturing and construction. The economy and the workforce OSHA committed to protecting at its inception 50 years ago has changed. That workforce was predominantly male and blue collar. The healthcare industry is now the fastest growing part of the U.S. economy, and healthcare workers are disproportionately female and people of color. There are no OSHA standards for the most common hazards in healthcare, ergonomics, violence, and infectious disease, other than the very effective bloodborne pathogen standard. Creating a strong, effective, permanent COVID standard will go a long way in righting this wrong. Previous speakers have spoken about the problems of OSHA ceding authority to the CDC. Unfortunately, CDC guidance has not followed the scientific evidence of SARS-CoV-2's exposure, transmission, or hazard controls. Surgical masks are treated as a form of respiratory protection when they should only be considered source protection. There's no focus on the hierarchy of controls. Screening and testing recommendations are not adequate to make sure pre- and asymptomatic infectious patients are identified. We hear of many cases where employees have been exposed to these patients only to find out hours or days later that the patient is actually COVID positive and they have unnecessarily been exposed. Because of the nature of pre- and asymptomatic transmission, we need a universal precautions type system with COVID that we have with bloodborne pathogens. We cannot ignore the science of transmission because it is convenient and easier to do so. Industry representatives keep complaining of being confused by differences between CDC guidance and OSHA requirements. Let's make it easier for them. OSHA has jurisdiction over worker safety. The CDC does not. OSHA has decades of experience with best practices in occupational safety and health protections. The CDC does not. OSHA acts as if it must take a back seat to the CDC on infection control issues, but it didn't do that with the bloodborne transmissible disease standard. For 30 years, OSHA has done an excellent job in this area. Tens of thousands of lives have been saved. OSHA can and must do the same for airborne transmissible disease. So how can OSHA hold the healthcare workplace to the same level of safety as other workplaces? By requiring notification of employees when they are exposed to SARS-CoV-2, through a record-keeping requirement that is not burdensome, and that requires healthcare employers to maintain records on file for several years, just like is required by OSHA for other record-keeping of exposures. Why is it so important for employers to clear the records and remove older cases? It is important that we have the ability to review those cases to look for trends. And in that same manner, we need to know the occupation or job title of workers who have been exposed so that we can accurately determine exposure risk based on job. There must be a strong hierarchy of controls component in the standard with a focus on engineering controls to decrease airborne viral load and with specific language, not using language like as appropriate, for example. By not passing off OSHA responsibility and jurisdiction to another agency such as the CDC. By effective hazard monitoring and risk assessment as is required for other toxic substances. Protection in the standard should be for all workers who are exposed to the hazard, not just those with certain job titles. Exposure assessment is necessary and must include risk of exposure from pre- and asymptomatic patients. There cannot be an out for employers who do not follow OSHA standards, i.e. the safe harbor language. We would like to ask, safe for whom? By allowing an employer to not meet OSHA requirements because they are following CDC requirements is seriously problematic and in our minds unethical. We have run into this problem with OSHA inspectors regarding the issue of fit testing, which is not required by the CDC, but is required by OSHA. The standard must follow the science on exposure, transmission, and hazard controls as determined through scientific evidence. And setting an action level at the outbreak level is unconscionable. Preventing outbreaks is the point of the standard. Waiting to put controls in place after an outbreak has occurred is really will result in a tragic number of infections, possibly long COVID, and even death. Questions have been raised about this standard related to the staffing crisis in healthcare. Nurses and other healthcare workers have felt completely unprotected by their employers and government agencies whom they depend on to make sure they're kept safe while doing their jobs. The nurse staffing crisis has built up over many years due to working conditions few of us would put up with. But the effects of COVID have pushed this crisis into a full-blown disaster. In a survey conducted by NISNA of its members last spring, over 50% reported experiencing long COVID symptoms, which is not surprising considering the workforce is overwhelmingly female, and it has been determined that women suffer more from long COVID than men do, and over 90% reported adverse mental health effects. Nurses are sick, exhausted, and angry that they've not been adequately protected. The best way to keep nurses at the bedside is not to force them back when they're still sick and infectious, but by keeping them safe from COVID infection in the workplace. Creating a safer environment with enforceable OSHA protections will help keep our healthcare workers safe and let them know that their lives, not that just their skills, are valued. You will now hear from 3 NISNA members, nurses who have worked tirelessly to care for patients over the past 2 years of this pandemic. They will tell you their experiences and their need for better workplace protections. And I now turn this over to Stephen Bailey.
Hello, Your Honor and ladies and gentlemen. I want to thank you. I'm looking for this. Must have been a really long day for you. And I understand you have a couple more days.
Mr. Bailey, I apologize. This is Judge Henley. I'm having difficulty hearing you. Are you close to your microphone?
I'll get a little closer, Your Honor. As I was saying, I just want to first just thank Your Honor and the ladies and gentlemen of the panel for doing this important work today. And I understand you had a long day today and you had a couple more. So I'm very thankful that you're giving this opportunity to speak right now. My name is Steve Bailey, and I'm a registered nurse. I've been a registered nurse for over 30 years. I've been doing something in the medical field for over 40. I apologize. I'm not wearing a business suit today like some of the people that presented earlier. I came right from the bedside, and I'm actually in my facilities break room right now. So if I get interrupted, I apologize for that also. My testimony, I apologize in advance if it's not as polished as some of the testimony that was given by the administrators for the various organizations earlier in the day. This is a very personal issue for me. My first information about COVID came during Zoom calls with other members of the New York State Nurses Association from New York City. One call in particular stands out. I remember some of the nurses from the Bronx had just ordered a third refrigerated truck to store dead bodies in, and they were emotionally devastated. I remember thinking, I knew some of these nurses personally, and these are some of the bravest, toughest men and women I've ever met. And to see how this had affected, really, I see my videos now.
Mr. Bailey, again, you're fading in and out again. I apologize, but we're trying to get your testimony recorded for the record.
Great, I'm getting as close as I can, Your Honor.
There you go.
So we had these Zoom conferences, and we would see the effects. COVID hit in New York City several weeks before it came to Western New York, where I'm located. So we were very fortunate to use that time to lobby aggressively through our union for appropriate PPE. And before we had a single case in our facility, we had won. I emphasize we won. It was not freely given. The right to at least one clean N95 mask every day, which is still not the manufacturer's standard, but it was far better than a lot of my colleagues were dealing with that were getting recycled masks and garbage bags for isolation gowns. On March 14th, 2020, I sent my first coworker home when he suddenly developed chills at work. That employee almost died and is still struggling with the effects of long-term COVID. I manage a long-term care unit and a behavioral unit in the long-term. Early on, I made a mental list of the patients that I thought I was likely to lose during the pandemic. And as of today, I have one of those patients left. Compared to many facilities, we did well. Initially, we were able to transfer our positive cases to our attached acute care facility. And we were actually written up in several publications for how well we were doing, including the Washington Post, compared to other nursing homes that had already been overrun. But unfortunately, when the hospital filled up, then they were no longer able to take our patients as they converted positive, and we began cohort patients in our facility. We were able to get people fit tested for N95s relatively early because of our association with the hospital. Although we did not have a great plan for the numerous people that failed their fit test. Basically, they're getting given N95s and a lucky penny and good luck and some thoughts and prayers. And we are just now getting access to peppers for people who did not pass the fit test. Initially, we cohorted the patient by unit, and we tried to limit, floating of staff, but it really wasn't possible. Our nursing home, like a lot of nursing homes, struggled with short staffing prior to COVID, and then afterwards it just got worse and worse. So we were frequently floating staff to and from COVID infection. And as things continued to progress, we ended up having to have people in isolation rooms on various units. So we had a system, and we still have a system of red units, yellow, orange units, yellow units, and we would have red, meaning infected residents on rooms with immune compromised people for various comorbidities, and that would continue to spread. During that time, we did not, and we still do not have any changes to our ventilation system. We did not have the ability to set up negative pressure rooms. And I want to emphasize also that, as long-term care nurses, long-term care is not a catch-all. It is its own specialty, and it's having these acute care people, strict respiratory isolation was not so different than, taking a nurse from, a neonatal ICU and putting them in a long-term care unit. Thing is much different. Most of us, including me with my 40 years of experience, had little or no with strict respiratory isolation prior to the pandemic. We, I was to hear the testimony from some of the individuals about short staffing. That's the most I've ever heard an administrator be concerned about staffing. I do want to echo some of the other panelists' thoughts on that it is largely a manual. Right after the very first wave of COVID, we did lay off only 4 people in our building. But it was the 4 people that did the hiring and training, and then we did not hire a new staff member for at least 6 months. And I'm not just saying nurses. We didn't hire a housekeeper, respiratory therapist, a social worker, anything. Meanwhile, staffing is just going down and down. This was on top of years of cuts to staffing. Prior to COVID, we were staffed for a good day, and we all know since COVID, we haven't had many good days. Nurses have been like Rose on the Titanic forever. We knew that there weren't enough lifeboats for years, and then COVID was the iceberg. We do need more nurses. Extra care requires extra staff. One thing that we don't have any extra supply of in long-term care is time. When you're in an acute setting and you add these precautions and you have 5 patients, it takes up a good bit more of your time. When you have 24, 25, sometimes up to 50 patients, it becomes undoable. And nurses are put in positions where people don't get their meds if you do everything by the book. In regards to talking about a safe harbor, I'm still trying to wrap my head around that when we were talking about a safe harbor, that we were discussing safety from financial liability, and really that should tell you everything about somebody's motivation if that was the focus of their presentation. When we talk about safety, it should be safety for the caregivers from an environment where they might lose their life related to decisions that are arbitrarily made or really made to err on the side of costs. In regards to having employees to pick and choose which regulatory body they're going to follow for which rule, it would be a disaster. I can tell you, as I said, I've done this before. Those decisions will be made to reflect the least costly option at all times. If you're going to allow that, then you might as well just write the loosest. They will always err on the side of cost. As an aside, we do in my facility have a full-time infection control prevention. That's the thing that has worked well in our facility. However, we are a 400-bed facility, and she's a little bit used more help.
Mr. Bailey, again, I apologize. I think we just keep having communication issues with you. I don't know what it is.
I'm so sorry. I think I'm having a little bit of a connection problem. And I think at this point,
So everything you just said, the last few words did not come through.
Okay. So as an aside, I just want you to know that in our facility, we do have an infection control preventionist, And that is one of the things that's worked well. Part of the problem is that she spends an inordinate amount of time trying to wade through all the different governing bodies to figure out what is the expected best practice. So it's it's part of a manufactured crisis that we need those people and that they have so much work to do. We're a 400-bed facility, and we probably could use more than one. And I'd like to yield the rest of my time, and thank you for your attention.
Thank you, sir. Ms. Davila or Ms. Robin?
Hello, Your Honor. This is Denise Diavella.
You may proceed, ma'am.
Thank you. I'd like to thank everyone for allowing my testimony today. This is going to be very heartfelt because this is obviously a very personal issue for me. My name is Denise Diavella, and I'm currently employed at Ellis Hospital in Schenectady, New York. I worked there for 16 years, but I've been an RN for 27. I have never felt as vulnerable and unprotected by my employer and the government as I have during this pandemic. In the very beginning of COVID, when there were so many unknowns about this virus, me and my coworkers were told by hospital administration that we couldn't wear our own face masks because it would scare the patients and the families, even though we felt that it was the right thing to do at the time, given what little information we had regarding this virus. There was absolutely no regard for our safety. And a year later, OSHA found that attitude still exists at Ellis Hospital. Ellis was cited by OSHA for violation of the COVID emergency temporary standard in December of 21, just 4 months ago. They were ensuring that staff wore face masks. Ellis management was very flippant about this hazard. Because we had ETS, even for a short time, Ellis was cited, and now staff has access to new face masks every day and must wear one in the facility. This proves that OSHA standards do work and makes our workplace safer and protects us from COVID exposure. Ellis Hospital, of course, appealed this citation, stating that the CDC's guidance was confusing and kept changing. That's why an OSHA standard is essential, one based on science and requires hazard controls that actually make worker safety a priority. That's OSHA's job, and under the ETS, it was allowed to do its job. But with the pandemic far from over, we need OSHA to continue to do its job to protect workers. We were eventually given an N95 and a paper bag about 3 months into the pandemic. We were told that we would put our individual masks in these paper bags with our names on them. And at the end of the shift, we would turn them in and they would be cohorted into a large Tupperware container where they would be sprayed down with a liquid detergent. We didn't know what the liquid detergent was, but that these masks would soak in this detergent overnight. We would then be given back the mask in the day to go ahead and wear this. We know that 3M, the manufacturer of the mask, does not recommend any kind of moisture because it breaks down the integrity of the mask. So then they came up with exposing the mask to ultraviolet light. 3M also does not recommend that, saying that exposure to UV light will also break down the integrity of the mask, rendering it potentially useless. Furthermore, there were no limits to the amount of times masks were to be worn, despite the manufacturer also stating that these were single-use masks. Nothing has been done to improve ventilation also at my facility. We heard in earlier testimony when representatives from Hospital Association was talking about improvements in ventilation. We have not seen any in my facility. Even though we know this virus is an airborne transmissible disease, positive patients in my department that are positive or suspected to be positive They're placed in a bay with 3 solid walls. We're told to contain transmission of this virus to close the curtain that forms the 4th wall. It is apparently the same soundproof curtain that doesn't violate HIPAA laws when practitioners can talk to their patients about their medical conditions and confidentiality. Apparently that same curtain also prevents the transmission of viruses. That was unbeknownst to me. With inadequate protection, many of my colleagues have become naturally infected over the last 2 years, some of them very seriously, almost requiring hospitalization. The hospital came back and blamed the frontline heroes as not being able to properly don used PPE. So in-services were provided to us. We were told we had to use single-use PPE, and we were taught how to put on dirty, contaminated plastic gowns. We were shown how to put this on. I immediately spoke up and said, you'd have to be an expert contortionist to be able to place this plastic, almost garbage-like material gown back on without contaminating yourself. I was told by my manager that we would only be given 1 article of PPE per day, so we would have to learn how to put it back on, even though it was soiled and contaminated. Keep in mind that prior to the pandemic, if we were reusing PPE, we would have run the risk of being disciplined, probably written up. Patients coming in for outpatient procedures do not have to be vaccinated. And if they do test positive, it's up to the physician if we proceed with the procedure, even if it's an aerolized procedure. The staff assisting in the procedure are never asked about their comfort level with proceeding with such a procedure, especially with lack of proper ventilation and at times lack of PPE. I have never been tested during this pandemic, even after several known exposures. I do, however, have many coworkers, or rather many friends, who work in other sectors outside of healthcare that still to this day get tested weekly for COVID. When it's convenient, Ellis will claim it follows the CDC guidance, even despite the CDC's lackadaisical guidance regarding healthcare workers' COVID status that clearly does not follow the science of transmission. They follow the CDC, but they lack following, but what they do lack is following simple common sense. The science that we were taught in school and that we have been trained throughout the years. It's about profit, not safety, convenience and revenue at the risk of their employees' safety. Ellis is no better prepared for the next major surge than they were 2 years ago. We, as frontline workers, are relying on OSHA to protect us, just like they do for millions of workers in other industries throughout the country. In closing, I want to just add that we need to use this past 2 years, as well as the great healthcare resignation of 2021, as a cautionary tale. And we desperately need OSHA standards to protect frontline workers and healthcare facilities. We can't rely on the CDC, and we certainly cannot rely on hospital management and administrators to put our best interest in mind. Consistently, we have seen through the years that it's profit over patients. And now it's even extended to profit over employee safety. I thank you for your time, and I thank you for listening to my testimony.
Thank you. Ms. Robin?
Your Honor, my name is Leah Robin. Can you hear me?
We can.
Thank you. My name is Leah Robin. I have been a registered nurse for 10 years and have worked as a nurse at St. John's Riverside Hospital, Andrews Pavilion in Yonkers, New York for almost 6 years. This pandemic is far from over. At the initial stage of the pandemic, we lost our dear nursing assistant, Opoku, to COVID-19. Recently, in January 2022, I lost my colleague, registered nurse Maria, at my hospital due to COVID-19. She, like most of us, was never fit tested for the N95 she was given to wear. She was our float nurse and hence cared for numerous COVID-19 patients without proper protection and eventually became infected herself. We are 2 years into this pandemic and we are still not fit tested. My colleague's death shows that COVID-19 remains a life and death issue for many workers in healthcare facilities. And yet I think it is embarrassing and disrespectful to those lost souls and their families that we must sit here and talk about the need of safety standards in healthcare. There only seems to be one type of N95 available currently at my hospital. We know that not everyone will pass a fit test with the same N95. So there need to be other options available. No one seems to be requiring that our hospital do this. We still don't have donning and doffing areas. We have no safe place to remove our mask to eat and drink. We work 12-hour shift. No consideration is given to the fact that we are human. We may be considered heroes, but our employers sometimes treat us like pieces of equipment because even though I end up in a casket, the loss is only for my family. The hospital will find my replacement as early as possible. Earlier during the pandemic, we had to bring in our own respiratory protection because we weren't provided with an adequate supply of PPE. I was expected to wear the same N95 for more than a week. Eventually, my hospital's management purchased some elastomeric respirators, which was good, but we need more. We are currently wearing one N95 for an entire shift. It's time for us to return to the conventional use of N95s, disposing them after every patient care session. But even though there is no shortage of supply, employers can save money by having us reuse the same N95 throughout the day and from patient to patient. So the story of it's better to use the same mask since taking it off with your hands can cause contamination doesn't stand. We healthcare workers know how to wash our hands. Please give us a space to take the mask off safely and fit test whenever you give a new model and make mask. Our hospital tried to create negative pressure rooms, but they weren't really done properly. Holes were made on the windows, and this so-called negative pressure machines were connected and sealed. In my hospital, it being situated in a hilly area and on the bank of River Hudson, the wind gust from New Jersey always interrupted the negative pressure system if there was any. And added to that, these rooms are not double doored, so every time we open the door, the room is no more negative pressure. We need to make sure that there are enough real negative pressure rooms for COVID-19 patients and that the hospitals are given the right guidance to create real, temporary, or permanent negative pressure rooms. COVID-19 positive patients are spread throughout the hospital. This puts both staff and patient at higher risk of exposure. We never had designated COVID-19 floors, and it continues. Although my hospital is good about requiring that surgical patients be tested for COVID-19, and the patient who are admitted from the emergency department to an inpatient unit are tested, there are still many holes in the system. For example, the support person accompanying a patient giving birth does not have to be tested, even though that person may be present for many hours and even days. The support person must be tested if they go into the neonatal ICU to visit their baby. But isn't it just as dangerous for that person to be untested during labor and birth? My hospital has been lagging in testing staff as well. It's important to regularly test staff and certainly test them after an exposure to make sure they do not spread COVID-19 among other employees and to the patients. I tested positive on January 6th, 2022. Even though I tried to not get it for the last 2 years, I got it. St. John's Riverside Hospital asked me to return to work after 5 days since I was asymptomatic. I didn't return to work since I was on vacation and decided to keep my days of vacation. Before I tested positive, I had staff around me who was positive 5 days ago, working closely with me and our negative other sick patients. They were not COVID positive. We all had to share the same kitchen, same restroom. The positive staff were using the non-fit tested N95 around the staff and the patient. None of us had a space to remove our masks safely to eat or drink. Staff was scared to say no to the return to work call after 5 days because of the scare to lose their job. As far as I understood, that was the case of almost all hospitals since they are horribly understaffed. My hospital requires visitors to wear masks, but many don't continuously wear them, and no one enforces the rule. That puts patients, staff, and other visitors at risk. There is no point in having a rule if it's not enforced. And expecting nurses to enforce these rules puts an additional burden on us when we are already more understaffed than we have ever been. As we all heard from the prior testimonies and evidences, OSHA health and safety regulations are stuck after bloodborne pathogens. The OSHA bloodborne pathogen standards have done a great job changing how we think about protection from bloodborne pathogens. We don't even have a standard for TB. That means OSHA has let us unprotected when it's come to airborne diseases. OSHA is the only system in the United States which could enforce the safety of the staff in any occupation. We need OSHA to step up to protect us. We as the current healthcare workers demands the need for better and standard safety protocols for COVID-19 to be enforced at the earliest so that we, the healthcare workers, America's risen heroes, will not be in the body bags and caskets in near future. As of now, with no safety standards enforced, healthcare workers' job is one of the most unsafe jobs one can ever have. There is a record-breaking resignation, retirement, and exits from healthcare field, and we, the so-called strongest America, is facing the worst staffing crisis. When recruitment and retaining of the current healthcare force is at risk, how are you expecting the future generation to enroll in a healthcare program? The youth of America is not dumb. A country, a hospital, or any healthcare system who are unable to keep their staff safe will not be able to keep their patients, means their people safe also. Straighten the system up. We need an unbiased system which will put forth life as the priority, not dollars. When CDC fails to keep up their standards, health workforce of this country wants OSHA to step up. Thank you for the opportunity.
Thank you. We'll turn it over to our OSHA representative for questions of this panel.
Thank you, everyone, for your testimony. We do have a couple of questions that we'd like to follow up on. Ms. Robin, you described how COVID patients are placed all over the hospital. There's not a designated COVID ward, or are people being admitted for other things and finding that they're COVID positive and continue to be serviced in other places?
Thank you for the question. I would like to answer that. So during the initial surge, after like March and April of 2020, every patient was COVID positive for a long time. So almost all the floors were COVID floors. But eventually when negative COVID patients were coming in because they were sick also. I work in MedSurg 5 South in St. John's Riverside Hospital, which is a ventilated floor. Almost like I will have 5 ventilated patients. They all were negative. Like surprisingly, they were negative. But I will have 5 ventilated patients who were negative on the floor, even though they are in a different room. I am taking care of COVID positive patients in the other rooms, and I'm taking care of the negative patients. And it was the condition in the whole building that there were no designated COVID floors. And because of that, the positive patients were sprinkled all over the building. And the same nurse was taking care of negative patient and positive patient. And there were time was like in 2020 of like March, April, and May, they asked us to like use the same gown in between MRSA patients, CRE positive patient, VRE positive patient, COVID positive patient, because there was a shortage of personal protective equipments, and which I had to like refuse. And literally I was walked down to the nursing office and they screamed at me for that, because I was like, I cannot do this because I'm not infecting my ventilated patient with COVID, because I know I have to go there to the ventilated patient's room, because he is already on another isolation, but he or she is not COVID positive. And me being a ventilator nurse, that's the last thing I want to do. They are surviving on a respirator already, and I don't want to give COVID to that patient. And all over the building, positive patients were sprinkled all over.
I just want to add to that, that what Ms. Robbins is discussing is common practice now in most hospitals. They are not designating specific areas for COVID patients. COVID positive patients are on units with COVID negative patients, and staff are assigned to both. So they are going from one patient to the other. And the horrific situation that one of the NNU speakers spoke about COVID positive patients being put in with severely immunocompromised cancer patients has gone on at our facilities as well.
That response came from Lisa Baum, for the record.
Thank you for providing that clarification. Are the patients transported from one place to another in the hospital through common hallways as well, or once they're placed and cared for in a certain unit, they typically stay in one place?
This is Leah Robin.
I'd like to
answer that. The positive patients are transported through the hallways for test, and if they're transported from one room to another or one floor to another, they are transported through the same hallway. And the COVID positive patients will be wearing a mask, and we are transporting them on the same bed or on a stretcher, and they are transported on the same hallway.
This is Denise Diavella. I'd also like to weigh in on that. At my facility as well, COVID patients are transported in the common hallways and transported in elevators that are shared with other employees as well as other patients. They have a surgical mask on them, but that's all. They are transported throughout our facility as well.
Thank you for providing that clarification. Ms. Robin, you mentioned the lack of respirator options and ones that would pass a fit test. Did you or your colleagues make any attempts to bring in your own respiratory protection? And if so, what was the result of that?
So initially during 2020 of April, March, and May, we ordered our own respirators, and hospital allowed us to bring it, and that was something which they allowed us to do. But those masks also were not fit tested, and we literally Googled and tried to find out whether these masks were fit, and we kind of relied on those information, and thankfully we were not positive. Like most of the people who used the elastomers we used from outside, which we brought with our own money from Amazon or Home Depot, worked for us. And as of now, St. John's is currently facing an OSHA investigation related to death of one of our colleagues. And there is information in OSHA chart regarding the mask fitting issues going on in St. John's Roseland Hospital. And the OSHA inspector is well aware of the issues going on there regarding fit testing.
Thank you. And just one clarification on that. The respirators that you brought in were elastomeric respirators and not N95s? Okay, great. And then I just have one final question for the panel. Your association stated in your comments that were submitted that you performed an analysis of COVID logs from facilities where your members are employed and found extremely high infection rates during the initial Omicron surge. Can you please submit that analysis and the data supporting it to the record for us?
I can, yes.
Excellent, thank you. No further questions from OSHA, Your Honor.
I think we have time for one question before we close today's session. If you could promote MK Fletcher, please.
Hi, thank you. And thank you guys for testifying. It was really powerful. You mentioned some things that you've seen employers do. What have you seen employers do that's been effective at preventing COVID exposures?
We have not seen these measures taken across the board, but we have seen certain facilities that did effectively set up temporary negative pressure rooms or spaces, larger spaces, for COVID positive patients. We have seen hospitals that have brought in elastomeric respirators so they are not so dependent on a very undependable supply chain. And we have seen facilities that have done a good job of patient testing so that staff and other patients were not unnecessarily and unknowingly put at risk of exposure. And I think that's important to point out because it shows that these measures are feasible. They have been done, and they've been done effectively. We would like for any standard that OSHA puts forward to require these kinds of engineering and PPE and other controls, administrative controls that we know work. There is an expense involved with some of these, not all. For example, elastomeric respirators have proven to be cheaper over time than disposable respirators. But, you know, the cost of replacing a single nurse is over $100,000. And the cost of paying for health care, paying the exorbitant prices of travelers, nurses, long COVID, staff being out sick is exorbitantly high. And keeping staff safe ultimately is an excellent investment.
I believe that
I
Ms.
oh,
Davella.
I'm sorry.
Ms. Davella, was that your response? I couldn't see you, so.
Oh, yes, I'm sorry, Your Honor. Yes, I was just going to kind of elaborate on what Lisa had just said, that my facility.
Yeah, that wasn't my question. I couldn't tell who was answering that question. That was Lisa Bowden. Okay.
Oh, yes.
Ms. Davella, did you want to briefly add something?
Yes, Your Honor, thank you. I'd like just to add that at my facility, Ellis Hospital in Schenectady, it's reported that they have spent $24 million on agency nurses last year alone. There was a record amount of retirement and resignations during COVID, many because of the lack of PPE and not feeling safe at work. It just wasn't worth coming in and continuing to work in that kind of environment, risking their own health and the health of their families. So many people opted to actually take early retirement. And the result is $24 million invested in temporary staff.
Thank you both.
Thank you.
Thank you. I'd like to thank the New York State Nurses Association for their testimony this afternoon. We are now at the end of all scheduled witnesses for today. And again, unfortunately, we couldn't get to all the questions from the witnesses for our panelists. So a reminder for those witnesses who had questions that we couldn't get to, please submit them to ets@dol.gov by the end of the day this Monday. And we'll submit them to the panelists who may choose to reply to them in their post-hearing comments. I also would like to remind all stakeholders that they may submit additional evidence or statements relevant to the proceeding within 21 days of the end of the hearing, which will be May 23, 2022. At that point, the record for this rulemaking will close. On behalf of the Department of Labor, I wish to publicly thank all those who gave of their time and testimony today. To all participants, thank you for your interest in this important matter. The hearing will reconvene at 9:30 a.m. tomorrow, Judge Almanza presiding. Until then, we are in recess.